hate looking at myself. Can you turn me off? It's like
People are still joining every minute as I'm watching the number of participants, so I'm going to give it a couple of minutes. And
Lisa said that like 430 people signed up as is. So that's terrific.
120. 120.
Yeah.
No. Oh, are we muted? No.
we're not muted.
So let's not clear any secrets about what's going on here then, right?
It's okay.
So I'm starting, right? And then I'm introducing you.
I don't know. Who's going to kick this off?
I think it's me.
Okay. Thank you, Steve. I'll
Pleasure.
keep my comments brief.
Yeah, you might have briefed too. You ready? All right, good morning, everybody. It's a pleasure to welcome you here today to our conference. So my name is Steve Percy. I'm the interim chairman of the Department of Pediatrics at Hackensack. It's my pleasure to welcome you to what hopefully will be the first of annual conferences on the care of the small baby. So with the advancement of our understanding of the physiology of the premature infant and the advent of new technologies, our ability to preserve not only life of the premature infant, but also to do so in a quality manner has really advanced tremendously. As you likely saw in the brochure, the Joint Commission in 2002 began awarding disease-specific certifications when programs met certain standards and outcomes. And I'm pleased to share that HUMC is a recipient of more DSCs than any other hospital in the country. At one point we had 29, but they retired a few, and I think we're down to about 15 now. I'm also pleased to share that our neonatology program was recognized for a disease-specific certification of prematurity back in 2020, and then was recertified in 2022. And we were also the first in the nation to receive disease-specific certification in advanced perinatal care in early 2023. And it was a cooperative effort between our neonatology program and our OBGYN program. You're going to get to meet Dr. Abdullah Al-Khan, the vice chairman of the department, a little bit later today. Today, you'll have the opportunity to learn a little bit more about how our program works, beginning with care in the delivery room, extending to discharge and follow-up to ensure that those babies have the best chance for a full and productive life. And our team will share with you strategies that can be initiated in your programs. So at this time, it's my pleasure to introduce Dr. Judy Ashner, the immediate past chair of the Department of Pediatrics at Hackensack University Medical Center, and the past division and chief of Hackensack Meridian Children's Health. Judy is a widely published, world-recognized neonatologist, a leader in research on the environmental impact on the development of infants. And she actively works with the National Heart and Lung Institute at the NIH in an expert capacity and serves in leadership roles with the March of Dimes. So please join me in welcoming Dr. Judy Ashner today and enjoy your conference.
Thanks so much, Steve. Can everybody hear me?
Yes, we can.
Okay, awesome. So I was really honored when I was asked to make a few introductory comments to this conference. It's really wonderful to see how much interest there is in this conference. As Steve mentioned, over 400 people registered to attend today. And I think you're going to find this to be an incredibly engaging conference with a lot of take-home messages for your own nursery. I want to do a shout out to Dr. Lisa Island, our chief of neonatology at the Joseph M. Sanzari Children's Hospital at HUMC. This conference was really her brainchild, and she applied for an educational grant, which was funded from the AAP District 2 section on neonatal perinatal medicine, which has enabled us to put this conference on for you. As Steve mentioned, we do have a small baby unit, and you're going to hear a lot about that today, and a lot about our Joint Commission disease-specific certification journey in prematurity. And I have to do a shout out here to Sabrina Malik, who really led this effort, but also to the incredible multidisciplinary team in our NICU, because in the end, you'll hear throughout the day that it is really about working together as a team. I've been practicing neonatology for a really long time, since the mid-1980s, hard to believe. And the field is almost unrecognizable today compared to the way it was practiced 40 years ago. One of the things that's really obvious is this enormous shift from a focus on pushing the border of viability ever lower, which was the focus when I was a fellow and junior faculty, to improving the outcomes of the survivors in our NICUs now. It's not that mortality isn't an important outcome, it's very important. But equally important is a reduction in morbidities and an increase in the number of infants with intact survival. There's also been an enormous evolution in the way that we care for our tiniest babies. Like no one in the 1980s, when I started in this field, would believe it possible to eliminate CLAPSIs in NICUs that cared for large numbers of extremely premature infants. But that indeed is happening today across our country. Or anticipate the shift to non-invasive modes of ventilation or delayed cord clamping as a routine or kangaroo care.
It's
And
a
a
small
shift in-
baby. I'm just
There's a
like
class.
muting.
Some people aren't on mute, and a shift in focus, which I think has been incredibly impactful on nutrition and brain health. So I think that special units, whether they're geographically separated or not, with expertise, skills, experience, and a passion for this patient population is part of the recipe for success. And there are a number of other things that I think have really pushed our field forward. One is benchmarking in collaboratives such as VAUGHN or state quality collaboratives, or even conferences like this where you learn what other people are doing and you take messages home and work on areas that you believe you have an opportunity to improve. I think NICU follow-up programs are incredibly important because it's essential that we track longer-term outcomes of the babies we're taking care of. And also incredibly important and becoming more and more aware for everyone is the embarrassing health disparities that still plague our field when it comes to perinatal outcomes for mothers and babies. And focusing on these things is going to be what's going to continue to move our field forward. Lastly, I have to mention collaboration with our OB colleagues. The improvements in outcomes for our babies start with prenatal care and delivery room care. And without strong relationships and a real partnership with our OB colleagues, the changes in outcomes for our babies would not be possible. It's also essential that your unit have a strong nursing culture of empowerment, which we certainly have here at HUMC. Involvement of parents as part of the NICU care team. Again, another incredibly important aspect of things that have changed since I started in the field. And then I mentioned, and it'll be mentioned, I think, many, many times, multidisciplinary teamwork among physicians, nurses, advanced practice nurses, physician assistants, respiratory therapists, our other therapists, PT, OT, speech, social workers, and dietitians. Because in the end, neonatology is a team sport. So with that, I think I'm going to end my opening remarks and turn the podium over to our next speaker, who I believe, is it Sabrina or who's following me?
Cassandra.
Cassandra, great. Well, so Cassandra, a great introduction to the role of nursing in the NICU.
Good morning. I would like to welcome you to our conference. It is our hope that we share, you learn from us, and we learn from you. My name is Cassandra Martin Walters. I am the nurse manager of the NICU. I have been here for 30 years. Today, I will share with you briefly the evolution of the continuous quality improvement structure timeline. In other words, how we begin our CQI journey. Presently, we have multiple collaborative CQI teams that are co-chaired by neonatologists, nurses, dietitians, pharmacists, anyone who interact with our unit are part of our teams. When I look at this process, I think about Patricia Bitter, novice to expert, her novice to expert model. I look at her novice to expert model. We start as beginners in whatever process that you're looking at. And over time, you travel from being a beginner to an advanced beginner, to competent, and then evolve into an expert. We do have collaborative CQI teams that are co-chaired by neonatologists, nurses, dietitians, RTs. Our goal of the CQI teams are to improve the outcomes of our babies, to create a culture with collaborative, respectful, and a shared vision. In 1996, we adopted Virginia Wiley's NICU integrated developmental care model. This is a model that was developed by developmentalists who went internationally to help NICUs worldwide to integrate this CQI structure into their units. Many NICUs in the US in the 1980s actually adopted this model into their units, which helped us to standardize care and have better outcomes for our patients. This model not only looked at standards of care for patients, but also looked at the culture of the unit. As I mentioned before, the teams were co-chaired by physicians, nurses, RTs, then directors of the pharmacy, infection control, and pastoral care. In order to have success within these teams, you have to look at who you need to bring to the table. Not only do you need clinicians, but you need administrators who can actually help you to get through the processes of how you get financing for projects that we implement in our units. Some of these team successes back between 1996 and 2000 were patient-specific medication dosing by pharmacy. The nurses used to draw up all of the medications, make all of the drips, but now the pharmacy does that. No verbal order policy that started in the NICU and it went throughout the hospital. Closed line blood draws and medication administration policies, which decreased the infection rates. The integration of respiratory therapists, lactation consultants, and equipment techs as part of the NICU staff. We did not have respiratory therapists in our unit around the clock, and now we have them 24/7. The development of interdisciplinary care maps, bereavement supports for families at the point of care, meaning if there was a loss and the patient came into the ER, labor and delivery, NICU, wherever the loss was, there were programs set up to support the families. Family-centered care maps, webcam viewing for patients, and just multiple evidence-based protocols that were developed by these groups. The year 2000, we were part of the OB pediatrics line. We realized that we were looking at developing potentially better practice for infants. We needed to collaborate with the other areas in the hospital where infants are admitted, not just the NICU. But for an example, if an infant came in with hyperbilirubinemia and was admitted to the pediatric unit, we should have one standard of care for that particular diagnosis. So depending on the diagnosis, there was an evidence-based protocol guiding the care, regardless of where the patient came into the institute. In 2002, we joined the Vermont Oxford Collaborative, even though we considered ourselves experts in the area of CQI.
Second floor.
Taught us how to work with units globally to achieve our goals and to use benchmark data to guide our development of potentially better practices that would affect our outcomes. Around 2006, the hospital implemented shared governance. This meant that any protocol or standard of care that we developed would have to go through channels for improvement. If there was a protocol developed in the NICU, the protocol would have to be submitted to the unit-based council, which are the nurses within the unit, and to the medical team to determine if it could be easily integrated into practice and look at how we would maintain our gains. And once those groups looked at the policy, then the policy would have to go up to the pediatric practice council, then up to the professional practice council, who have representatives from nursing from all areas throughout the hospital, and next to the executive council for final approval. So this is who we are now. This is our structure now. You can see that based on our collaboration with VON, Solutions of Patient Safety, the Children's Hospital Quality Council, and New Jersey State NICU NICU Collaborative. This is the NICU quality improvement structure today. Once we became Hackensack Meridian Health, which is a network of hospitals, we are now tasked with policy integration throughout the network, which proved to be very challenging. You can see that we have many teams than from the start in 1996. We have a robust structure in place. All the team members, the teams report to the NICU leadership. As part of VON, there is a NICU traveling team that collaborates with other NICUs within the network, investigating outcomes, data, and looking at ways to improve practice and implement new protocols for the upcoming VON cycles. Each CQI group presents their improvement projects either annually or biannually to the neonatal division. We continue to maintain the gains of continuous quality improvement by joining forces with other collaboratives, networks with the same shared vision. We believe that there is strength in numbers. Our motto is don't just stand there, improve something. The next speaker is Sabrina Mallon, who is a neonatologist. Sabrina Mallon, who is a neonatologist.
Hi, how are you? Hi, everyone. I'm just waiting for my slides to be shared. Thank you. Good morning, everyone. Before we get started, I just would really like to thank the Children's Hospital leadership for supporting the NICU in our journey to improving the care that we deliver. And thank you to all of our nurses and medical team providers for really all of the hard work that you do every day for our babies. Next slide, please. All of us here are striving to achieve the best outcome for our patients. We want our preterm babies to grow up healthy, thriving, and with no morbidities related to prematurity. Next slide, please. One slide back, please. But how do we go from the state of being born extremely premature, requiring at times maximum support, and all of the uncertainty that goes along with that, to being able to attain the milestones and being able to go home? We've all been there in the NICU when we've had that 23, 24 weeker who is just so critically ill, and we're wondering and thinking, you know, how is this baby going to get home and be morbidity and mortality free? Next slide, please. Very preterm neonates, as we all know, are a very special subset of babies that have very unique needs. As we all know, those neonates that are born at extremely low gestational ages are at the highest risk for morbidities related to preterm birth, which includes chronic lung disease, IVH, PVL, necrotizing enterocolitis, late onset infection, ROP, among many others. Next slide, please. As you just heard Cassandra discuss our involvement with Vermont Oxford. Our unit's dedication to quality improvement and excellence really dates back over 20 years when we joined the Vermont Oxford Network. It is a voluntary collaboration of interdisciplinary healthcare professionals whose mission is to improve the quality, safety, and value of care for newborns and families via a program of really data-driven quality improvement, education, and research. Now, we have been members of the Vermont Oxford Network, the very low birth weight data set and the expanded database, along with the NICU Collaborative for quite some time. And with this, through our participation in the collaborative, every 2 years or so, we have identified areas of improvement and worked with other centers and expert faculty to achieve our goals. And as you can see, we began our journey on the small baby back in 2016 when we focused our goals on improving our neurological outcomes in preterm neonates. We then expanded to improving the care to our smallest patients by implementing our small baby unit. Next slide, please. The target population for our small baby unit was really neonates born at less than 30 weeks gestation. This included both inborn and outborn patients. Next slide. Our pre-small baby quality improvement projects, as I just mentioned, really focused on improving our neuroprotective measures and improvement in our IVH and PBL rates. We then have expanded our care to the entire small baby population, and our neuro bundle, which you'll hear about later on in the conference, is now incorporated into our small baby protocol. Included in our expansion towards creating our small baby unit, we really needed to gain leadership commitment. We really focused on multidisciplinary team education, and this encompassed lactation consultants, nutritionists, our OB high-risk colleagues, peripartum, postpartum, our team members in the NICU. And then we also really focus on standardizing practice guidelines specifically for preterm neonates. As we all know, there's really no national benchmark guidelines for prematurity. And so, we really looked at the literature and really developed evidence-based guidelines for our unit. And then in 2019 is when we really started also our journey towards earning our disease-specific certification in prematurity from the Joint Commission. Now, the goal of the disease-specific certification program is really to standardize practice care for patients and maintain a framework for continuously reliable care. Now, this was an extremely rigorous process in obtaining our certification. Unlike other disease-specific certification programs that exist under the Joint Commission, where there are national guidelines such as stroke and in asthma and in diabetes, in prematurity, there really are no set guidelines. Therefore, during this process, we had to choose which metrics we were going to focus our efforts on, which I'll get to in the next few slides. Our care for our preterm neonates really starts before the baby is born. It begins when the mother is admitted to the hospital and there's a concern for preterm birth. As you'll hear, it really starts with our collaboration with our obstetrical colleagues. Many aspects of our care begin in the antepartum period, including, discussing with the mother the importance of colostrum care, donor milk, the importance of skin to skin, and, letting her know about our small baby unit and all that we offer here at Hackensack. Once the baby is delivered, our care continues to that very critical delivery room period, golden hour, where we really focus on providing the key critical elements of care in a timely fashion. And then as our babies are growing, the focus shifts towards, coming out of that critical time period towards more developmental needs of our babies. Next slide, please. Next slide. The benefits of a small baby unit are enormous. It helps to improve outcomes. Again, by standardizing practice care guidelines, we're able to decrease practice variations and improve outcomes. Also through, building a small baby unit, you're able to, again, hone in on looking at the evidence in the literature and building, evidence-based guidelines for your unit. Also, we focused on specializing education tailored to the small baby, and also focusing on our pre-golden and golden hour, which looks at delivering quicker medical interventions during a very critical time period. Other benefits of the small baby unit are also to improve the developmental needs of our babies. By creating this specialized space, we're really able to optimize the environment that our babies are in. Also, we've been able to bundle our care times and also promote parent-baby bonding with, a big focus on kangaroo care and skin to skin. And this, again, was a big effort between our nursing and respiratory therapists in order to, make our families comfortable in order to kangaroo care with their baby. And also multidisciplinary team collaboration. You're going to hear this, like Dr. Ashner had mentioned earlier, over and over today, that it really does take a village to, have a premature baby graduate from the NICU without any morbidities and mortality. And so, with the multidisciplinary team collaboration, we're really able to improve our patient outcomes and improve communication amongst all of our team members. Next slide, please. So the goal of our small baby unit really was to create a multidisciplinary team approach to improving the care and outcomes for our babies that were born less than 30 weeks. We also wanted to improve the education for all of our team members caring for our preterm neonates. And we really wanted to decrease our practice variation amongst our multidisciplinary team members, because it's been shown over and over that when you decrease the practice variation and you create standardized practice care guidelines, you really do help to improve the outcome for your patients. Next slide, please. Some of the metrics that we focused on when we looked at creating our small baby unit, and also when we went for our disease-specific certification, were a few patient-centered metrics, which included improving our overall rates of survival without morbidity and mortality. We also wanted to improve our rates of NEC and improve our initiation of early nutrition by introducing colostrum oral care and starting trophic feeds early by 12 hours of life. Now, this was a very multidisciplinary team effort in order to do this, because we incorporated our lactation consultants, nutritionists, nurses on our NICU side, also on our postpartum, peripartum side, in order to initiate early pumping for our mothers, early ascent for donor milk. So it really was a very big group effort in order to hit this benchmark of introducing colostrum oral care and trophic feeds early by 12 hours of age. We also wanted to improve our skin to skin and kangaroo efforts between parents and baby. And our patient-centered metric was improving our parental understanding and knowledge of their baby's care trajectory by implementing our family care meeting by 7 to 10 days of life. So this really was a focus on making sure that our families
Due to technical issues, Dr. Malik, her connection has been lost. We will plan on starting our next section at 9:30. Hopefully we'll be able to reconnect her and let her just summarize her presentation. Thank you for your patience.
Hi, I'm back on. I'm not sure what happened there. I think it was just some, technical glitches with my Wi-Fi, and really apologies for that. Next slide, please. So we just, really focused on, going through multiple PDSA cycles. And as you can see, care of the preemie is like putting together pieces of a puzzle. Everything has to fit just right. And all of our quality improvement teams, as you can see here, really came together and focused on the micro preemie to really improve our outcomes. Next slide, please. And I really just wanted lastly to say many thanks to our wonderful nursing staff, our medical team, providers, education, nursing, medical leadership for really providing amazing care to our tiniest and mightiest patients, and also to all of our multidisciplinary and interdisciplinary team members, lactation, nutrition, OB, high risk, postpartum, and really your efforts for helping us meet our metrics and goals and providing our care to our mothers and babies. And thank you so much. And I really wish all of our participants a wonderful afternoon and morning in hearing the rest of how we created our small baby unit. Thank you so much.
Good morning. Thank you for having me at this very prestigious conference. My name is Abdullah Al-Khan, and I am one of the maternal fetal medicine specialists here at the organization and have been here for shy of 21 years. I'm just going to give you a little informal introduction in regards to prematurity and where we started and where we are and where is this perhaps going to end. So just as a background, in the United States, as of 2021, 8.8% of singleton mothers who were delivered premature, compared to 63% in comparison to higher order multiples. And when you look at higher order multiples, clearly the incidence of prematurity is going to be higher once you go above twins and when you go into the triplets and quadruplets, so forth and so on. And multiple pregnancy represents about 3.2% of live births in the United States. Just as a background information in terms of clarifying terminology, preterm birth is any mother who gives birth less than 37 weeks. Moderate prematurity is 37 to 32. And the very preterm birth is between 32 to 28 weeks of gestation. And as you go down, that's when we start running into more complication. The extreme preterm birth is at 28 weeks of gestation. The micropreemie are those babies that are born less than 750 grams or before 26 weeks. And our focus is going to be now mostly on these periviable births, which is between 22 to 24 weeks of gestation. I think this is an important slide for me. And the question is, where does viability start? And I think Dr. Ashner described very elegantly that since she has been practicing in the 1980s, the paradigm has changed. In fact, When I was in training, viability was just between these two, between 24 and 28 weeks of gestation. But clearly, as time has evolved, we're seeing that the viability has really moved down. And now we're looking at viable pregnancies really falling right here between 22 and 24 weeks of gestation. So now we offer resuscitation to babies who are born. So I will not be surprised as this number trickles down, and perhaps in the next decade or so, we perhaps might be resuscitating 20-weekers. We think it's an impossible task, but I think when we were back in the 60s, we thought it was going to be impossible to resuscitate 26-week babies who were born. We're not doing good nationally in terms of prematurity, and this is a huge problem. So if you look at the scorecard, premature birth is a problem in the United States. I think the only state that is doing well is Vermont. They get an A. Interestingly, New Jersey is in the B+ category. But if you look at the rest, Middle America and the South, they are not doing good at all. And I think this should be an awakening call of what is happening, especially in the southern states. So there's a lot of problem that we have to focus on, and why is prematurity still on the rise? But not only if you look at the southern states and Middle America is not doing well, there's clearly some degree of ethnic and racial disparity. And this is no secret. We all know that when you look at patients of a different color, Black, African Americans, they are actually at higher rate and risk of having premature birth compared to the counterpart if you look at the Asian, Pacific Islander, or the white population. I can make this even more complicated. Not only the Middle America and the southern states are not doing very well in terms of premature birth, but now, unfortunately, with all of the laws which are being imposed, and of course, everybody heard about this very tragic, rule that came about in the state of Alabama, in which now, discarding in a humane way, frozen embryos is considered a crime. Mothers are basically cannot make decisions for themselves. This is just going to complicate the picture. And most of this is happening in the southern states. So really my philosophy has been, there are no brave lawyers, judges, politicians, or doctors, but only brave patients, and they have no clue how brave they are. I think we should be cognizant of that. If you look at premature birth, obviously, nearly 40% of these babies who are delivered occur because of spontaneous preterm labor, because of various factors. And 30% of mothers are delivered prematurely because of indicated fetal or maternal indication. For example, fetal infection, mother is severely preeclamptic. And the other category, 25%, is secondary to premature rupture of membrane. I urge people to focus on this model. Prematurity is on the rise, believe it or not, even though the March of Dimes states that prematurity has been stable, but we're seeing a rise, and I think there's going to be even a glitch, a higher glitch, and I think that's because of the reasons I mentioned earlier, southern states and a lot of rules and regulations that are impeding on patients' decision-making. The biopsychosocial model of medicine has a huge impact on how disease processes occur. So when you look at the syndrome of prematurity, there's lots of factors biologically, socially, and psychologically that we have to focus on that impact the well-being of the mother and impact prematurity or premature delivery. This is just a very complicated slide, busy, but I'll make it very simple. So a lot of the biopsychosocial models that are around us impact ultimately a common pathway, which is stress. And stress means high level of cortisol in the mother, and high cortisol in the maternal circulation high cortisol in the fetal circulation obviously leads to placental dysfunction, contractions, and hence you end up with the preterm birth syndrome. There are multiple other epidemiologic factors that contribute to premature birth across the nation. And I'm not going to bore you, but there's lots of maternal age has negatively correlated with various collagens, gravidity with endothelial, nitrous oxide, and inflammatory chemokines, and so forth and so on. Once again, this tells you that there are lots of environmental factors out there that could impact preterm labor and preterm birth that we have to be aware of. Importantly is if you look at this graph, and it tells you about in regards to a survival rate. We're not doing that bad in the United States. So if you look at the United States, it's that yellow line comparatively to the pinkish line to my left. That's going to be the numbers specifically to Japan. But I think if you look at Japan and China and other areas of the Far East Asia, they're doing actually pretty well in regards to survival. The United States is getting there. We're doing actually a little bit better than the rest of the Western countries. But to be aware of is survival has increased in regards to these extreme premature babies. Now, survival is one thing, and comorbidities, long-term comorbidities, is another thing that I'm sure my colleagues will talk about. If you look at this slide, it clearly tells you that there's a 33% survival nowadays. And this is obviously dependent upon where you deliver the baby, what organization, what facility, and also other maternal coexisting factors that lead to premature delivery between 24 to 22 weeks of gestation. Survival could be as high as 33%. Now, why are these babies surviving? I think it's a blessed thing. And of course, the simple answer is the development and modernization of NICU medicine. And if you look at this slide, a picture, it depicts like we have created a pretty much an ex utero environment for these premature babies to be controlled and to grow in to decrease all of the comorbidities. So obviously, kudos goes to our neonatology folks who spent an enormous amount of time with the nursing staff to ensure that these premature babies are taken well care of in the ex utero environment. That's one factor. But let's not be fooled also. So as modernization of medicine clearly has impacted outcomes in regards to survival, but this is a good slide, and I want you guys to give this a thought. If you look at the 1800s, and especially when in the late 1800s, if you look at survival has increased, men and women across the globe, people are living back in the early 1800s and 1700s. Average lifespan was in the 40s or even late 30s. But now the average lifespan is in the late 70s, 80s, and we're having people who survive even into their 90s. Now, why is this? Obviously, this is a lot to do with the environment. But also, as survival is increasing over here, this is what's happening to the in utero environment. So there are a lot of ex utero factors that are perhaps influencing survival of these extreme premature babies, in addition to the excellent work that the physicians are doing in the field of neonatology. And I think this brings me to the slide that ontogeny recapitulates phylogeny. And I think this is an important slide. Just give this a thought about what's happening in terms of evolution in regards to survival. So the field of medicine has become fascinating, especially in OBGYN. We talk about helping mothers with IVF pregnancy and what we do in the technology. But now the science fiction of the test tube baby has become a reality, right? Mother babies are surviving 22 weeks. Perhaps that's even going to go down to a lower gestational age. And we're creating semi-perfect environment ex utero. So really the science fiction of a test tube baby has become a reality. Kudos to the healthcare technology. This is my last slide. I'm not going to go to the details of this. Having said that, as we go down the gestational age in terms of survival, decision-making is crucial. I'm not going to spend a lot of time. I'm sure my neonatology folks is going to talk about this, but the realistic assessment of individual factors will direct strength of recommendations. And this depends, and this I mean in regards to at what point in gestational age will your decision make a difference? How do you discuss with the patient? Of course, this depends upon the place of birth, estimated fetal weight, accuracy of gestational age, gender, plurality, presence of congenital anomalies or chromosomal aberrations, the utilization of antenatal corticosteroids, so forth, so on. So this is important to focus that resuscitation and outcomes is going to be dependent on multiple factors. I thank you all for your time. I'm going to hand this now over to my colleague, Dr. Antonia Oladipo, who will continue this session.
Good morning, everyone. Thank you, Dr. Alkan. Thank you for the prior speakers who presented some of the information here. Thank you to the Children's Hospital, as well as the institution for holding this conference, Dr. Island, for putting together such a strong conference. I will also preface, my voice is a bit harsh. I have a slight viral cold. I'm not contagious, and I will be enunciating and speaking up so you can hear me to overcome my voice. I am also a maternal fetal medicine specialist, and I work very closely with my vice chair, Dr. Alkan. So thank you for the kind introduction. I will continue the concept of laying that groundwork. We're going to be talking about how do we enhance, what are the roles that really strengthens our collaboration. So my objectives today, I really just want to describe and analyze the roles of the key personnel in the team. I think you will hear and see that collaboration is key to success. And it's very important that you understand what that means. You understand your key roles. And as my other colleagues will explain further how those roles impact the outcome in creating a small baby unit, it's really important to just actually understand the basic components of those roles, as well as just describing methods to optimize our communication. So as we were discussing before, premature birth of a child and the admission into the NICU, it can be quite distressing. And in the prenatal and antenatal stage, myself and my colleagues, we quite so often are counseling and really managing quite complex pregnancies. And we know that in itself is its own risk factor for then subsequently having a fetus or a neonate in the NICU. And once in the NICU, or once in this unit, a patient really can feel quite overwhelmed with everyone and all the components of the care. And it's important that they understand, and we understand all of our roles in taking care of both of our patients. And in terms of the OBGYN, the OBGYN is leading much of the prenatal care, overseeing much of the health and well-being of the pregnancy. And they really monitor the pregnancy, address these conditions. And I'm not going to overemphasize their role, but quite important. And of course, in the maternal fetal space, we are dealing with the complexities of maternal health, maternal issues, as well as abnormal neonatal development, chromosomal abnormalities, as we alluded to, as well as structural abnormalities, and just once again, early birth, early life. Our neonatologists, we are we work quite closely with you all, specializing in our newborn care and in the NICU, in the preterm space, addressing the complexities. I really appreciated the picture that Dr. Alkan presented before that shows all the technology, the impact of the technology that a newborn will face, and knowing that all the complexities that go along with that, and our neonatologists actually managing all the different systems that are that technology has actually helped to advance. And so they help to really transition that care. Our anesthesiologists are also very important in their role in transitioning from the antenatal life to the outside world or the newborn world. They help to manage pain relief during labor, of course, and ensure safe administration of medication and anesthetics. Our NICU nurses, I appreciated our earlier colleague who was describing how our unit has become so successful. But in that, understanding that having a strong nursing unit is key and pivotal to the success of the unit, and they're providing that bedside care, the hands-on care for the newborns in the NICU, monitoring the vital signs, implementing the plans that the care team has discussed, and offering much needed support to our families. Our pediatrician, just going to highlight that they really are involved once the baby is discharged from the small baby unit, but it is important that they understand what has occurred to the infant while admitted in the hospital. Our genetic counselors, they're assessing the risk of the newborn, counseling patients about testing. And it's also important to know that also in this field, they've achieved a lot of advances. 10, 15 years ago, some of our testing capabilities in terms of prenatal, antenatal screening has changed. And then even all of the panels that continue to evolve and expand in detecting different abnormalities, chromosomal abnormalities, microarray, all of those things. I also want to emphasize social worker, point number 8. The social worker is addressing this psychosocial aspect of the pregnancy and the neonatal care. And depending on your unit, you can delineate particular roles for the social worker. Here in our unit, they do offer support, emotional support, practical. They help to meet the practical challenges of our families. They provide resources, and they assist in navigating how complex some of the challenges will be for these families, for our families. And one of the last roles here is just household administration, patient coordinator, and depending on how you create and evolve your unit here in our hospital, we have great patient coordinators on the NICU side that work closely with us, also on the antenatal side, and they facilitate that communication and coordination with all the team members. So I really just once again want to reiterate that collaboration and effective communication among all the specialties that I've described is really key for providing this comprehensive care. We really cannot optimize the care if we're, communicating in silos, or we're not really, allowing that transition for the patient will actually really see that disconnect. And I really like to use this pictorial to show all the components I've described. And once again, it isn't to sound, facetious or anything, but really collaborative and effective communication is key for success. I want to point also to 2 additional care team members. Here, lactation specialists, this was mentioned earlier, understanding about breast milk and donor milk and all the positive components that provides for the newborn's health, as well as our behavioral health specialists. In our unit, we're really expanding and building out within the mental health space, working with our colleagues to identify our patients who may have mood and anxiety disorders identified, and then making sure we carry that care throughout. And that once again is a part of the psychosocial model. So the second component I mentioned of my objective was to talk about what are the ways to optimize this communication. Here in our institution, in our hospital, we have monthly meetings to discuss either fetal cases or the maternal cases. So preparing our colleagues for if and when these patients will come in their unit, they have discussions in preparation for them. There's accessible call schedules and contact information so that all team members are able to reach all specialists and collaborators. We're able to also plan and have emergent meetings for when patients come without warning. I mean, that will happen. It's not everything that you're going to be able to plan for, so you want to be able to know how to mobilize your team members when necessary. We have inpatient consultation available at all times. And we're also able to transfer within our other hospitals to our main hospitals to optimize care. And lastly, this is my last slide. It is important to emphasize that a remote center must have consultants available at their institution or a way to contact these specialists. And whether that is going to be an in-person method or even telehealth with the use of technology, with the use of telecommunication. This has also enabled communication between patients and between team members. And then once again, that plan of transfer care needs to be in place, and also making sure that you have ways to transport, to calculate your time and your distance, to then prepare for the other steps that are needed to enhance success. So with that, I stop here and I'm gonna pass it over to my colleague, Dr. Annalise Jacobson.
Good morning, everyone, and thank you very much to my colleagues, Dr. Alcon, as well as Dr. Oladipo, not only for presenting today, but for your ongoing work with our division and collaboration with all of our babies. So I'm going to talk to you today about counseling, and I'm going to focus on the extremes of prematurity. When I talk about that, I mean in the weeks of between 22 weeks up to 24 weeks gestation. Okay, so an overview of what I'm going to discuss. First, we'll talk about the key factors and joint recommendations for successful prenatal counseling. This will include the interdisciplinary approach. It will include communicating with families, and then I'll discuss some common obstacles specific to counseling at this early age of gestation. Then I'll go into a framework for discussing options. We'll cover intensive care counseling, comfort care counseling, and really what the reality is, which is counseling along the continuum between intensive care and comfort care. So just to kind of using pictures to prepare your mind for counseling these families. These families are coming in, the mom is pregnant. In their mind, in the future, this is the beautiful baby that they're expecting, okay? And we are counseling them to somehow prepare them for this, or even prepare them for a comfort care situation where the baby then dies. So I like to use pictures because it reminds me that my patients don't know what I know, and my job is to help them understand. Okay, so key factors for successful counseling. It needs to be interdisciplinary, just by definition. So you have a mom fetus dyad that is transitioning into a mother baby. And obviously there are multiple caretakers along the way. You have your OB team, your MFM team that is handing off the baby to you, still taking care of the mom. So there's a lot of overlap. So by definition, it has to be interdisciplinary. Things are moving, things are changing. So you need to have a dynamic and adaptable relationship with your other team members so that you can pivot and turn and adjust your plans as the patient changes. So the recommendation, and these recommendations come from a joint workshop that involved the Society for MFM, AAP, and ACOG. It came out in 2014. So the recommendation, if at all possible, is to have a pre-counseling huddle with just the team members, the delivering team, the NICU team, including nurses and whoever else is pertinent to the discussion, sometimes some specialists, or at least a discussion. If it can't be in person, at least a discussion is very preferable. The ideal situation is that you have contemporaneous counseling, meaning you're in the same room at the same time with your patient and their support person. This really helps the patient with trust for the new providers, and also lets them see that everyone is working towards the same end. You're all on the same page. Sequential counseling is often what happens, especially if there isn't enough time, but sometimes there are families who do prefer not talking to everybody at once. So I'll just put that in there for that reason. And then once you have had a conversation with your family and patient, a post-counseling discussion to kind of just rehash, make sure everybody's on the same page before you move forward with the plan. This collaboration can help resolve differing perspectives between specialties, minimize redundancy and inconsistencies, and mitigate the impact of clinician bias. Okay, a lot of stuff on this slide. So communication with your family. So you as the counselor, provider needs to prepare. So we need to know the mom's history, we need to know preferred language, any pertinent cultural factors. You need to familiarize yourself with the morbidity and mortality statistics, both nationally and more importantly, locally, because local statistics are really the ones that matter most in terms of care for the baby at your institution. Be aware of modifiable and non-modifiable factors. So non-modifiable factors would be maternal age, fetal weight, is the mom ruptured? Those things we can't change. Modifiable might be things like are prenatal steroids available and useful in this situation? Magnesium, antibiotics, is their ability to wait, or is it really, is there a lot of time pressure? Make time. So when you go into a room with your colleagues, make sure everybody has a seat. When you're standing, it looks like you're ready to leave. So sit down, make sure the partner also has a place to sit and is comfortable and can see you, and you're facing your patient and their partner. Prepare the room. Don't do a conversation with the TV on, even if it's muted. Turn the TV off. Mute your phone, mute their phones. Make sure you really have a nice situation in which to talk to your family. Use a medical interpreter when needed, and make sure that your patient knows all of the roles, that you introduce yourself. You can bring a business card, sometimes that's handy. This is for the neonatologist coming into this relationship. This is the start of your relationship. So this is, you're beginning to build a foundation. So if you don't start to build it well, just like you build a house, if foundation is not good, it's going to be a little rocky. So you're building trust. So you need eye contact, you need to be involved, build rapport, show empathy, you need to listen, and you need to allow for silence. I like to tell the patients, I will tell you the truth when I know it, and I will tell you when I don't know. And I tell them that I won't hide anything from them. Underscore that it's a team approach and the parents are members of that team. And we are there to educate them to help take care of both mom and baby. each family situation is different. You can't just decide you're gonna have one conversation and then just apply it to every situation. That doesn't work. So I usually start the conversation by establishing what the mom and the partner understand so far about the situation. And then you kind of go through, the details of the situation. You explain, you want to check for comprehension, answer questions. Sometimes I draw pictures or show pictures. I'm a terrible artist, but I try. If possible, it's nice to be able to step out, allow the mom and the partner to process a little bit, and then maybe check back later. Maybe not at all of you if there's not time, but at least one person just to kind of follow back up and answer questions. The options I'll discuss a little bit later in this talk. And then try to prepare the mom and the partner kind of visually and step by step for what to expect. Like, it sounds silly to us sometimes, but it's like, your baby is gonna, be handed to us by the obstetrician. It's gonna go over to the giraffe or the warmer. We're gonna do X, Y, and Z. We're gonna show you the baby before we go to the NICU. Those kind of, step by step, what to expect. It helps to really decrease, not totally alleviate, but decrease some of the anxiety when they have realistic, concrete expectations. Common obstacles, there are a lot. You're trying to make a really rather intimate relationship with people that you don't know in a really short time frame. And that's very difficult. People respond to stress very differently, and often not in a very productive way. There's a lot of fear, there's denial, there's anger, anxiety. All of these things get in the way of absorbing information. This family is already in the first stages of grief, most likely because what they thought was going to happen for their baby and their family is not happening. They may not understand. Maternal illness is one to keep in mind. If you have a mom who's on a magnesium drip or actively in labor, she is probably not going to be able to take in a lot of information. This is very challenging, this next one. Sometimes the mom and the partner don't agree. And sometimes they're extended family members who also sort of factor in terms of having different opinions and beliefs. There are cultural barriers, language barriers, even within languages. Sometimes there are differences in sayings and stuff. So sometimes that can be a problem. Time's limited usually. So if you're talking the window of 22 to 24 weeks, most of the time you're in a rather urgent or emergent situation. So there's really not a lot of time. And that often paralyzes your patient and their partner. It's usually unexpected. Things are happening fast. They're usually paralyzed and really not wanting to make a decision about what to do because they're really worried about having regrets and they're just scared. Statistics, I don't use a lot of statistics when I talk to families. I use them to kind of frame the conversation in terms of basically how dire the situation is. For example, if really only 10 to 20% of babies are expected to survive, that's a useful statistic. But when you're applying statistics on how one baby is going to do, those are not predictive. So you should know them so that you can appropriately speak about their baby. But again, using, this percentage of this percentage of this, and throwing numbers, I personally don't find very helpful. You have to remember that we're balancing maternal health and future OB health. Your MFM colleagues and OB colleagues, this is very important. A classical C-section is a big deal. And we need to remember that mom's health supersedes the baby, up until the time of delivery. So sometimes mom wants everything, but really we need to look out for her health as well. Parents are generally, they're just not prepared. Not only do they not have anything at home, they have no context for prematurity, where they kind of feel pressured for decision making, and they are really not prepared for any of that. Okay, so the conundrum, so we're going to parents and who are the least medically knowledgeable, the most emotionally invested, and the least prepared to decide and saying, hey, what do you want us to do? So it is very difficult to make that kind of black and white decision, like do this or don't do this, when everything seems very gray and there are all sorts of layers. Okay, so now we'll talk about counseling. This is just to show the various layers of care teams and how we all kind of overlap each other. So you have time is the straight green line. You have OB MFM are taking care of mom from early on in the pregnancy through delivery and postpartum. The yellow is kind of our multidisciplinary counseling. And if we're talking about birth at 22, 23, 24 weeks, you know, if we have a little advance notice, that's helpful, but a lot of times we're really counseling like right before that birth. Neonatology takes over essentially at the time of birth in terms of providing for the baby. And then comfort care planning is in there if that's the direction that the care is going. And then kind of the overarching care team is really the neonatal, perinatal, palliative care team. It kind of oversees all of the above. Okay, so we have options. A lot of us were trained to say, okay, either you're going to resuscitate or you're going to not do anything, or we now use the term comfort care because that's what we're doing is we're not stopping care, we're providing a different type of care. And then there's what I've come to talk about a lot with families is kind of resuscitation with a trial of life. And I'll go into the details of that in a minute. First, some definitions. So comfort care is synonymous with end of life care. It can be provided in the labor and delivery or in the NICU. You can provide it right away at delivery, or it's something that you can pivot to after birth when additional medical treatment may not be effective in preventing death or severe morbidity. The drivers for comfort care are realistic goals of care as defined by the family in conjunction with the care team. We want to focus on bonding, warmth, nutrition and hydration, relief of pain for the baby, memory making, honoring relationships, spiritual needs for the family. For example, I once had a baby that was going to be taken off of respiratory support, and we waited to do that until the grandparents were able to fly in from California, meet the baby, and those things are, if you can honor those things, it's really important. We provide care across transitions, so prenatal care for mom, preparing for comfort care, care in the delivery room, keeping the baby with mom if she wants, and maybe potentially transitioning to comfort care in the NICU as appropriate. So the primary goal is dignified living, dying, and death, and focusing not so much on the longest life you can have, but maybe the best life that the baby can have. And then full resuscitation, I think everybody knows about. So you provide the same resuscitative care based on our NRP guidelines that you would any baby age 24 weeks and above. We're going to have a discussion with MFM regarding utility of prenatal steroids, magnesium antibiotics, et cetera, if there's time. And then also balancing maternal health goals. And then with all of those things taken into consideration, what you're able to provide, you want to set the fetus up for the best chances of survival post-delivery. And then the trial of life. Trial of life is often really useful when, because of how quickly all these things are coming out, parents are worried they can't really like process everything. And so sometimes it's a good way to start is to say, why don't we see how your baby responds? And then we'll have more information, which is true. Sometimes you have enough time to discuss limits that I write here. So sometimes parents will say, well, I don't want you to do chest compressions, or I don't want you to do like full CPR with epinephrine and all of that. Or you could say, well, you know, what if we aren't getting a good response from the baby by, say, 10 minutes? Would you like to hold your baby at that point? So you can have these kind of discussions where you kind of tailor your care in the delivery room. Again, if there's time to talk about that. Or you may have no limits. Either you don't have time to discuss them, or parents just can't really process that. So you just say, you know, we'll try to resuscitate the baby. They need to know the baby may not make it out of the delivery, may die in the delivery room, or the baby may survive to admission to NICU. There are options to transition to comfort care in the delivery room. So sometimes it's a back and forth. You're working on the baby and one person goes and says, hey, you know, the baby's not responding. You know, do you want us to keep going? Do you want to stop? Those kind of things you can have. Again, it's dynamic. Or you can transition the baby into the NICU if the baby is doing okay. And then if things aren't looking as good later on and there's, you know, some significant morbidities, there's always the option to transition to. And this is my last slide. So this is just me trying to put all that together. So if you're in the delivery room, you can choose comfort care directly, I mean the patient, or you can choose full resuscitation, or you can sort of start with a full resuscitation and then potentially flex to comfort care if needed, or you can go into the intensive care and continue on that route, or kind of see how the baby's doing, maybe decide with the parents that de-escalation is what they want to do, and then provide comfort care. So it's very dynamic. It's not necessarily a binary situation. So thank you very much. Appreciate you listening to us today, and we're really happy to be presenting our unit and our hospital. Thank you.
Good morning. My name is Nicole Spillane. I am the Associate Director of Neonatology. I have the pleasure today to speaking to you about our Golden Hour protocol, and particularly about our focus on gentle transition, a bundle of care. I'll be presenting this topic today with Christine Ligris. She's our NICU Respiratory Care Coordinator. So just starting to talk about the golden hour, what is it? It is the hours immediately following the birth of an extremely preterm infant or an extremely low birth weight infant. And in this time period, the care that is provided has the potential to prevent irreversible complications of extreme prematurity. During that time period, multiple tasks are typically accomplished, including delivery room resuscitation, transport of the infant with admission to the NICU. And there are many tasks and procedures that need to be accomplished efficiently and with detail in the delivery room. And there's a focus on maintaining stability during transport and admission to the NICU. However, this time is also a very challenging time because the care that is provided is both complex and time sensitive. And I depict this figure, which shows all the different tasks which are typically encompass the golden hour. And I display it not to go through each and every task, but just to show how many things typically should be accomplished in the first hour or so of life. And you can see it's both a large number and complex. So today I really wanted to focus on our approach to the golden hour. And though all the tasks that were depicted on the previous slide are incorporated in our golden hour protocol, I really wanted to talk about our focus, which is really gentle transition and how we achieve that through streamlining the process and minimizing stress. And this focus really started for us when we started our small baby unit in 2018, 2019. And as we approached each of our guidelines, we really thought about the golden hour and how could we make this as gentle a transition as possible. And so one of the things, or to go through some of the different things we considered in streamlining the process and minimizing stress, we thought about standardizing care and scripting roles. We really focused on preparation. So we had our roles pre-assigned and a golden hour pack, which has all the supplies that we need for the delivery room pre-packaged and ready to go. We established a pre-brief process where we have a shared mental model that is discussed and explicitly stated with all the team members. We identify our roles and responsibilities prior to going back to the delivery room. We really focused on prioritization. What needs to happen during the golden hour and what can wait? We wanted to minimize handling. So how did we focus on that? We said, let's weigh the baby in the giraffe instead of putting the baby in a bedside scale. We wanted to keep the baby midline, and we use a head positioning device to assist in that. And for babies who need intubation in the delivery room, we give surfactant in the delivery room. Additionally, we decided that we were going to place umbilical lines and avoid peripheral IV placement. Of course, we want to monitor how long that takes to make sure we're not inadvertently having the baby without fluids and dextrose. So we do monitor the timeliness of our line insertion. We have a large team that helps to resuscitate and admit the baby. So we have 2 admit nurses. We have 2 medical team members, one who oversees the big picture, helps prioritize and place orders. They also place an umbilical line. We have 2 respiratory therapists who one is really the delivery room champion, and the other helps with admission to the NICU and sets up the respiratory equipment prior to arrival to the NICU. In addition, we partnered with radiology. So they were able to prioritize for us getting an x-ray quickly after the baby is admitted to the NICU. And we were able to create this code small baby where radiology is alerted to a small baby admission and they prioritize our x-rays. And the goal is to have the hood down by 1 hour after admission to the NICU. So as we go through this golden hour protocol or guideline and our focus on gentle transition, I really want to talk first about why do we pick this? Why do we think a gentle transition is important? So we're going to talk about the importance of reducing pain and stress, the importance of increasing positive input. And I think this is really important, that it's not only the avoidance of negative experiences for the newborn, but also increasing and prioritizing positive experiences. We want to demonstrate or go through some of the evidence for the benefits of golden hour protocols in our specific approach. So again, why the focus on gentle transition? So we know that the perception of trauma varies by the age and the stage of development. And there may be a disconnect between our understanding of trauma and the experience of a newborn of trauma. And to illustrate this, I wanted to go through the adaptation that a newborn must go through as they transition from the intrauterine environment to the extrauterine environment, and what happens with the acoustic adaptation. So there's a big change in sound attenuation. The baby goes from having all sound attenuated by maternal tissues and fluids to direct exposure to sound. They now are experienced to a broad spectrum of sound frequencies when they were primarily only experiencing low frequency sounds. Typically before birth, the noise exposure is occurring during the day, and nighttime is fairly limited noise exposure. Now the baby is exposed to sound throughout the day. And the sound changes, so they are exposed to electronic sounds and natural sounds and non-biological sounds after birth, where previously they were only exposed to maternal vocalizations and biologic sounds. And though we don't know exactly how they experienced this transition, I think it's reasonable to guess that this might be stressful for them, as it's a large, very abrupt transition from in utero to ex utero. And we know, in addition to these possibly stressful transitions, that extremely preterm infants who undergo repeated painful procedures, they do that during a time of rapid brain development and when there's programming of stress systems. So they might be particularly vulnerable to its effects. And we know that the central nervous system of our extremely preterm infants is vulnerable to excitotoxicity, oxidative stress, and inflammation. And prolonged activation of the HPA axis may result in long-term changes in hormonal, physiologic, and behavioral systems. Neonates that have greater pain-related stress have associated lower cognitive and motor function and higher internalizing behavior. So with that background in mind, we really wanted to start in the golden hour by thinking about how could we reduce these stressful experiences. So gentle and thoughtful handling was a focus for us. So we decided we wanted to help keep the newborn in a midline position and to elevate the head of the bed by 15 to 30 degrees and avoid rapid elevation of the legs or fluid shifts. There are studies that have demonstrated that positioning the head to the side results in occlusion of the ipsilateral jugular vein with increased intracranial pressure. And for that reason, and we know, and knowing that newborns, particularly preterm newborns, have a limited ability to regulate their cerebral perfusion, we thought that these interventions could help protect the baby from intraventricular hemorrhage. And there have been studies that have demonstrated a bundle of neonatal care with maintenance of midline head positioning, the incubator tilted at 15 to 30 degrees, avoiding head position down and sudden elevation of the legs, and avoiding rapid IV arterial flushes and blood withdrawal do have positive effects. So in this study, they looked at 280 very low birth weight infants, less than 30 weeks, in the intervention group, which got this bundle of care, and they compared it to historical controls. For the composite outcome of reduction in new or progressive germinal matrix hemorrhage, or IVH, in the first 72 hours, in-hospital death or cystic PVL, they saw a significant reduction from 31% to 17%. In addition, when they looked only at new or progressive germinal matrix hemorrhage, or IVH, in the first 72 hours, they saw a significant reduction from 23% to 10%. We didn't only want to focus on decreasing negative interactions, but also increasing positive interactions. We know that positive parental interactions are associated with lower cortisol levels and decreased stress-sensitive behaviors at 18 months, corrected gestational age. Additionally, increased parental involvement in the NICU and increased skin-to-skin care and holding have been associated with improved early neurodevelopmental outcomes at term corrected and improved outcomes at age 4 to 5. So in the golden hour, how do we really help maximize these positive experiences in a time that the baby is pretty fragile? So one of the ways that we can help encourage positive input at the very beginning is by really engaging the parents and empowering them. So as parents go through this very stressful experience where they have very little control, by helping to focus on the things they can control and the influence they can have on their baby, we can really encourage them to be at the bedside. So one of the things that we do is in our antepartum consult, we really focus on mom's own milk and how providing mom's own milk can really have a positive impact on the infant. After birth, we do go and update the parents as soon as the baby is stabilized and provide the mom with a colostrum kit. And again, we reinforce to the mom how important her milk is and provide her with the hand expression and talk about the powers of mother's milk. And we've been lucky to communicate and partner with our antepartum, who have been great partners. So if we do not have colostrum by 4 to 6 hours of life, we call down to antepartum and they go and help mom with hand expression. In addition, we really focus on hand hugging in those first few days where the baby might not be able to do skin to skin, and really focus on that piece as well. So switching gears a little bit, I just wanted to talk about what is the data to say that golden hour protocols really make a difference. So this was a systemic review that was published in 2024, where they looked at 10 studies that were pre and post comparative studies or observational studies of golden hour protocols, and they reported on the short-term and long-term outcomes. They were able to see in over 2,300 patients that were included in this review, an improvement in admission temperature with a reduction in hypothermia from 59% to 26%. And that was statistically significant. In addition, they showed in over 2,000 newborns an improvement in admission glucoses with a reduction in hypoglycemia from 18% to 7%, and an improvement in admission glucose of greater than 50 milligrams per deciliter from 55% to 72%. More importantly, they also reported on some long-term outcomes. So you can see here they were over 1,100 infants that they looked at that were included in this review, looking at intraventricular hemorrhage. Although it did not, the positive impact of the golden hour protocol did not reach statistical significance, I do think it's interesting to note that all the studies trended towards favoring the golden hour protocol to reduce IVH. And with more patients included, we might see this become statistically significant. Interestingly, we did see in this study that there was a statistically significant reduction in BPD in the babies that received the golden hour protocol. So in this review that included over 800 infants, they found an odds ratio of 0.68 for a reduction in BPD in infants who received the golden hour protocol. So what is our approach? So this is the script that we follow for all our team members and what their expectations are for the golden hour. So our admit nurse 1 is responsible for pre-warming the giraffe, bringing the golden hour bag to the delivery room, bringing surfactant. She sets up the suction, turns on the cardiac monitor, and increases the delivery room temperature to 75. Often this is done with communication with the L&D nurse prior to our arrival. She also activates the chemical mattress, prepares the limb leads, prepares the head positioning device, and sets up the plastic wrap. Our second nurse gathers the umbilical line supplies. We do have in our protocol that the use of a UVC double lumen for less than 1,000 grams or less than 27-week infants. She obtains the quarter normal saline with heparin for the UAC, and she'll call radiology and alert them to an upcoming code small baby. In addition, she obtains the D5 starter TPN to start warming. Our neonatologist performs the prenatal consult, conducts the pre-briefing, reviews the delivery room setup, and introduces the team to the parents. Our med team member, which could be a APN, a fellow, a or a resident, they do use sterile technique prior to the delivery to set up the umbilical lines. This is really to help with the timeliness of line insertion, and they do cover it with a sterile drape to maintain sterility. And our respiratory therapist sets up the T-piece resuscitator and the pulse ox, prepares supplies from the respiratory box for intubation, and sets up the oscillator for infants less than 27 weeks. In our pre-brief, all of our team members huddle. Our team leader briefs the team members on the expected delivery and the expected neonatal condition and the goals of care. We review our roles and responsibilities and confirm that we're prepared for the resuscitation. In the delivery room, our admit nurse 1 does place the limb leads, assist in wrapping in plastic wrap, inserts the OG tube, secures the midline positioning device, and assists in resuscitation and weighing the baby in the giraffe. Our second nurse will prepare medications as indicated and assist in documentation. Our neonatologist communicates with the OB team on arrival to the DR and confirms the cord management plan. They supervise the resuscitation, direct whether there'll be early surfactant in the delivery room or early CPAP. They update the parents and will help assist in emergency line placement as needed. Our medical team member will provide respiratory support via the T-piece resuscitator and intubate as needed. And our respiratory therapist will place the pulse oximetry probe by 1 minute on the right hand and wrist, assist in intubation and confirming ET placement, secure the ET tube, and give surfactant as indicated. And then our approach as we come back to the NICU in the first 0 to 60 minutes is also scripted. Our admit nurse 1 will connect to the monitor, confirm the alarm settings are appropriate, obtain vital signs, the admission temperature, and a single limb blood pressure. They assist in line placement, bridge the umbilical lines after placement is confirmed, and start our TPN and give admission meds. Admit nurse 2 assists in connecting to the monitor and obtaining vital signs. They're in charge of documentation. They also monitor the length of time for line placement, alerting the medical team if it's exceeding our goal of having lines placed by 45 minutes. They run for medications and supplies, call for x-ray when the time is appropriate, and make sure we have an admission glucose by 1 hour. Our neonatologist is at that time assessing the clinical status of the infant and prioritizing tasks, is in charge of ventilation management, helps in writing orders, make sure we have a blood gas by 1 hour of life, reviews our chest and abdominal x-ray for optimal lung volume and line placement, and then updates parents, and at that time obtains assent for PDHM and brings our colostrum kit. Our medical team member will place the umbilical lines and obtain the initial blood work with line placement. And our respiratory therapist confirms our ET2 placement and that our holder is in the correct position. They help place the baby on the oscillator and assist in setting the vent settings. We give surfactant in the DR if not we give surfactant in the NICU if not previously done. They do remain at the bedside for the first hour of life to adjust the ventilator and observe the baby's response to the vent settings, and they verify ET2 position and adjust with the NEO's input. So to go through this golden hour protocol and with the goal of hood down by 1 hour, we wanted to show a video of our approach.
Nikki, this is Jessica.
Hello, it's LND. We're calling because we have a 23-weeker that's going to be delivering. We need the NICU team.
Okay, I'll gather my team. Thanks. Hey guys, I need the code team to come to the huddle board. We're going to have a 23-weeker delivering baby in delivery. Let's get Dr. Guzman and Dr. Spillane. Dr. Guzman.
Hey guys, All right, so we have a 23-weeker. Mom has severe preeclampsia. Got a full course of antenatal steroids yesterday and today. Estimated fetal weight is 550 grams. Got a full course of steroids today and yesterday. Mom's on MAG. God is on labetalol and hydralazine, and plan for classical C-section today. We plan on intubating and giving CureSurf in the delivery room. Any questions?
Okay, great. Dr. Guzman, I'm going to review the small baby protocol, and I'll also prepare the UVC and the UAC sterilely. I just want to confirm that you want a double lumen UVC because the baby's estimated weight is under 1,000 grams.
Yes.
Okay, great. Bianca, can you please pull quarter normal saline with heparin?
Yeah.
For me to run the lines? And Dr. Guzman, can you confirm the family would like to have intensive care rather than comfort care?
Family confirmed that they want full intensive care.
Okay. And I'll start to prep the lines and warm the D5 TPN.
Okay, I'll grab the golden hour pack and I'll also take CureSurf out of the Omnicell.
Okay.
Okay.
I'll get the oscillator ready, but what room are we going to admit in?
We're going to admit into room 24.
Okay.
Let me call X-ray. Hi, this is Jess in the NICU. Yeah, we're going to have a code small baby coming. Yeah, we're going to deliver in about 30 minutes, but I'll call you back when we deliver. Thank you. You know what, why don't I actually call labor and delivery too? I'll talk to their charge nurse and make sure that they bring up the temperature in the hour. Hi again, this is Jess in the NICU. Yep, we're preparing. I'm going to bring over the giraffe bed and set that up now, but if you could please bring up the temperature in the OR to 74 to 77 degrees. Okay, great. Thanks. Bye.
Great. Sounds like we're all set. Let's get ready to go.
All right, let's go.
All right.
Yes.
Okay.
Okay, guys, so we're expecting a 23-weeker who has a full course of steroids. We anticipate the estimated fetal weight to be 550 grams. I anticipate intubating and giving CureSurf in the delivery room. So let's review our roles. I'm going to be a supervisor role and going to be giving you guys any feedback.
I will take care of the pulse ox. I'm going to put it on the right wrist for the preductal sat. I have my T-piece resuscitator set to 20/5 on the PIP and the PEEP and 30% on the oxygen. I have a 2.5 ET tube with a stylet set up with a 00 blade, and then I also have 2 masks ready, a premature and an extremely premature mask ready, and a CO2 detector with commercial ET tube holders to secure the tube. And I confirm the cardiorespiratory monitor is working. The EKG leads are prepared when the infant, and I activated the chemical mattress. When the infant's born, I'll dry the infant's chest, I'll apply the leads, and then I will wrap the infant in the neo wrap.
Great.
And I will assist. I have the code car out in the hall. If I need to, I'll go out and get it and drop all the meds necessary.
Perfect.
I'm going to take the head of the bed and do airway. So after the baby's delivered, I'm going to suction and then anticipate applying the mask immediately, either CPAP or PPV as needed. After stabilizing, we'll intubate and give CureSurf.
Great.
The baby is born. Time of delivery is 10:45 a.m.
Okay. Okay. Baby is vigorous and is crying. Let's defer cord clamping. Baby looks apneic, 4-tone. Let's start some PPV.
Okay, I'm giving PPV. I see good chest rise. Our heart rate's 120 on the monitor, and also our saturations are in range per NRP guidelines. Are we ready to intubate?
Yep, we're ready to go.
Okay.
Suction. Clear.
Okay, I've got a good view. Give the tube.
Heart rate's good.
All right, I'm in.
Okay, I'm gonna take a listen. Where are we?
We are at 6.5.
Good.
We have positive color change.
Perfect. I hear good breath sounds. Heart rate's good, good chest rise. So let's secure the tube and then let's go ahead and give the carousel.
Ian, I'm gonna let go, okay? Yep, I got it. You're good. Okay, I'm still seeing good chest rise, vitals are stable. Perfect.
Okay, we're securing the tube with the neo bar.
Let's weigh the baby first and then apply the head position device.
Sounds good.
Good idea, Jess. I'll hold the tube.
Go ahead and lift the baby.
All right, stats are stable, heart rate's good.
Let's put your hand back. All right, our weight is 480. Let's readjust our carousel dose to reflect our current weight.
And let's apply the head position device.
And then we can show mom prior to leaving.
Okay. I
Great,
think we're ready to
perfect.
transport.
Yeah.
Okay. Okay.
Sounds good.
Looks like we're doing well on 20/5 and 30%. So let's go ahead and transport on those.
Yeah.
Can we show
settings.
the baby to mom before we head back to the NICU?
Yes,
Let's
absolutely.
close up and then move towards mom.
Perfect.
Should be tired.
And watch your head. Yeah, thank you.
Dr. Splain, do you mind getting the lines ready to go? I'm going to put in the orders based on our small baby protocol. I'll be sure to be monitoring the respiratory and cardiovascular status of the baby, and be sure to supervise and make sure to make any ventilator changes if need be.
Can you ask one of the clerks to call?
Oh, I will
X-ray
call
for
X-ray
small
for a
baby?
small baby as well. Sure.
Okay, and I'm going to place the baby on the monitor and obtain vital signs while keeping the head in a midline position. And I'll help the medical team with the line placement.
Perfect.
And I'll assist with documentation.
Okay.
Great. I've got the sterile lines ready to go. As soon as our nursing team has the baby stabilized and on the monitor, I'm going to go ahead and place the lines.
Okay, and I'll wait to obtain a blood glucose until lines are placed. In the meantime, I'll just assess the baby's temperature and I'll get the meds going, and we can defer length and abdominal circumference at the time. What settings would you want on the oscillator?
As long as the baby is on minimal settings and doing well, I think we can start with a map of 8, an amplitude of 18, and a hertz of 12.
Christine, I'm here. I'll help you put the baby on the oscillator. Perfect.
Okay. And do you agree with our respiratory plan?
Yeah, I think it's perfect.
Okay.
Sounds good.
Just a friendly reminder, guys, our goal is to have the hood down and hands off by 60 minutes after arrival to the NICU.
Okay. And our plan is also to just get a gas an hour after placing the baby
sounds
on
good.
our respiratory.
Ready for line?
We're gonna.
We're good?
Good, all good.
Okay.
It's in good position?
Yep.
Okay.
It's good.
Good wiggle. All right.
Yes.
Sounds good. Thanks, guys, for a great resuscitation. I just want to take the time now to kind of debrief, go over what you guys thought was good, what we can work on, and if you guys had any feedback you'd like to give me or any part of the team.
I thought that the teamwork was excellent and the communication was really good. Everybody knew their roles and spoke up throughout the resuscitation.
One thing I'd like to say is that the delivery room temperature wasn't warm enough, so next time let's just increase that temperature sooner.
Okay.
Okay, and if we don't have colostrum by 6 hours of life, I'll contact the antepartum nurse.
Great. Thank you so much for all that feedback. I'll take that back and make sure to next time we'll contact the OR or labor and delivery earlier, make sure the room is warmer, and I'll be sure to go and update the parents. I'll go and ask to see if they are willing to get some donor milk, and I'll go bring over the colostrum.
That's good.
All right, guys.
Sounds good. Great job.
Pleasure
Good
working
job,
with you guys. Good job.
Thank you for sharing that video with us. We're going to move on now to Christine Lugrish. The next stage in our golden hour process is our approach to gentle respiratory care.
Hello, everyone. I'm Christine. I'm the NICU coordinator for the NICU. I mean, for respiratory. We're going to turn our focus from our approach of using gentle ventilation to our approach in using a gentle transition to gentle ventilation. This here is our algorithm that we use to guide us on which respiratory course we follow shortly after birth for our small babies. Our 22, 23, 24 weekers, they're all getting intubated in the delivery room and getting surfactant as well in the delivery room. For our 25, 26, 27 weekers and up, depending whether they're spontaneously breathing or not, or whether mom has had antenatal steroids or not, we'll either follow the same course of getting intubated in the DR and getting surfactant, or we'll get early CPAP in the delivery room with a dose of selective surfactant, in which we would give surfactant within 2 hours of life if the patient either has is requiring at least 30% oxygen or has RDX on X-ray. So where do we start for ventilatory support? With a focus on gentle ventilation, our primary initial mode is the oscillator for our extremely low birth weight infants, many of which have a homogeneous lung disease process, such as RDS, shortly after birth. All of our extremely low birth weight infants that are intubated will go on the oscillator. We are using the oscillator as a lung protective strategy in preventing ventilator-induced lung injury by minimizing alveolar distension, which oftentimes occurs in surfactant-deficient lungs with low compliance. The use of very small tidal volumes to ventilate the lungs and mean airway pressure to recruit and stabilize collapsed alveoli are important to lung protection. This open lung concept of recruiting and stabilizing alveoli through the use of mean airway pressure helps maintain FRC and prevent atelectasis and allows for the infants to breathe easier. This is our guideline that we use for our oscillator. So again, all infants that are less than 1,000 grams will go on the oscillator with the initial settings of a mean airway pressure of 8 centimeters of water pressure. We will start with an amplitude of 15 cms and then look at the patient for adequate chest wiggle down to the umbilicus, and then start with a frequency of 12 hertz. For these infants that are intubated and on the oscillator, our team will remain at the bedside to make sure the ventilator adjustments are appropriate and try and find that optimal descending pressure for optimal inflation. After we settle on what we think is an appropriate mean airway pressure, we will obtain an X-ray to confirm that we have optimal lung volume and also obtain blood gases regularly to optimize ventilation. For ventilation, our primary control for ventilatory issues like hypercapnia is the use of the amplitude. If after, we've had a couple hypercapnic gases, and we had increases in our amplitude. And we do not have it, and is not resulting in the elimination of CO2, then we will go ahead and decrease our hertz by 1 centimeter. I mean, by 1. We just have to be cautious that small increments, small decreases in our hertz will oftentimes produce large changes in ventilation due to the increase in tidal volume. We will obtain an X-ray, again, to make sure that we do not have hyperinflated lungs. And then our goal is to stabilize and support. And then when ready, wean and extubate early if possible. So how do we find our optimal mean airway pressure? Starting from a relatively low mean airway pressure of 8 centimeters of water pressure, we will start recruiting by increasing our mean airway pressure by 0.5 to 1 cm. Every 5 minutes or so, until we start seeing a decrease in our FiO2 requirement. We continue to increase the mean airway pressure in small increments until we get down to an FiO2 about 30%, or we no longer see an improvement in oxygenation. At this point, we will be at the opening continuous descending pressure as seen. Let me show you on the, and seen in the graph right over here. All right, having been able to now overcome the opening pressure, we should be able to decrease our MAP even further and maintain optimal lung inflation through recruitment. You can see that over here. We should be able, because we recruited alveoli, be able to maintain optimal descending pressure at this point. This is just a simple case study of an extremely low birth weight infant, around 500 grams. As you can see, their X-ray, they're hyperinflated at almost 10 ribs, have flattened diaphragms. The ET tube is in good position and just shows RDS on X-ray. On the oscillator, the patient's on a mean airway pressure of 11, an amplitude of 22, and a hertz of 12, and requiring 23% oxygen. Our ABG is 7.3, 54, 80, 93%, and a bicarb of 26. Since this patient is on minimal amounts of oxygen, in this case, we would drive that mean airway pressure down until we either see a slight increase in our FiO2, or if we are already at minimal settings. As for ventilation, we want to avoid excessive ventilation. The PCO2 of 54 is adequate, given that the pH is also within an acceptable range. We will repeat blood gases regularly, allowing for permissive hypercapnia, CO2 between 45 and 60. This is our extubation criteria. So once our patients are stable, and we have reached minimal settings for our oscillator, if our FiO2 is less than 35%, our mean airway pressure less than 8, the patient has good respiratory effort, and their work of breathing is decreased with no retractions or minimal retractions, and we will attempt to extubate. This is our chart that we use for patients who have failed extubations. Our aim is to have no more than 30% reintubation rate, which is the pink line that you can see there. So what this consists of is, this is chart is for our patients that are less than 1,500 grams. Our rate consists of the number of planned extubations compared to the number of planned extubations that get reintubated within 72 hours. That definition of failed extubations comes from the bond. And then, as you can see, this is over the last 10 years or so. We've been relatively below the 30% line. This is our definition of extubation failure. requiring greater than 60% FiO2, needing greater than 8 centimeters of water pressure on nasal CPAP, having a pH of less than 7.20, a PaCO2 of greater than 65. If the patient has greater than 6 apnea and bradycardias within an 8-hour shift, or if the patient has had 1 episode of apneas, bradycardias, and desaturations requiring bag and mask ventilation. This guide is an to extubation failure is just a guide, and patient assessment should always be taken into consideration when we are determining whether the patient needs to be reintubated or not. This is our chart for chronic lung disease rates in our very low birth weight age group compared to the bond centers of similar size. So it's 22 to 29 weekers. If you look at the gray area, it is a 25th percentile and the 75th percentile. And our center has been relatively below the 25 percentile mark, with the exception of the last couple of years. This is the distribution of very low birth weight infants at our center. As you can see, our 2021 and 2022, we've had an increase in our extremely low birth weight infants, our 22, 23 weekers, which is the light blue area, as well as our 24 to 26 weekers, which is the blue area. Which is why you may have seen that little uptick in the curve from the previous slide. But if you look at this chart, this also has shows our chronic lung disease rates. Even though we have had an uptick in small babies in the last couple of years, this graph truly shows our chronic lung disease rates. When you look at this slide, the whisker plots show the observed chronic lung disease rates in our NICU minus expected based on our characteristics. This chart takes into account risk factors of our chronic lung disease rates in the last 10 years. And as you can see, we have been consistently low and have had significantly less than expected based on the patient characteristics. Each whisker plot is 3 years. So over the last 10 years, you can see we've been below the 0 mark, signifying less than expected. So in conclusion, general transition as a focus in the golden hour starts with well-defined teamwork and thoughtful task management, actively incorporates minimizing stress and promoting positive interactions, focuses on general ventilation with the use of the oscillator, prioritizes actively weaning invasive respiratory support for early extubation. Thank you.
Our next speaker, Dr. Planer, will be speaking about acute care as a foundation for successful continuing care. And we will plan to start at 11 a.m. as scheduled.
Okay. Good morning, everybody. My name is Benjamin Planer, I'm a senior neonatologist here at Hackensack, been here many years. First, I'd like to thank Dr. Island for taking the initiative in allowing us to highlight the work that we've done over the last number of years. It's much appreciated, Dr. Island. And I'm going to focus on our journey to establish appropriate nutrition for the small baby. So certainly you're all aware the global aim of nutrition for the small baby is to provide optimal growth. It impacts neurodevelopment and long-term health. But at the same time, there can also be a downside, right? It's associated with necrotizing enterocolitis, which has a high morbidity rate, and also impacts risks for infection. So as you've heard from other speakers earlier today, in establishing our small baby unit, it took there were multiple multidisciplinary stakeholders involved, all the way from senior leadership, obstetric colleagues, all the doctors, nurses, practitioners working in the NICU, other subspecialists within the NICU. And this talk is primarily going to focus on the nutrition group. And this is our group. To give them credit, we have 3 lactation consultants. We have 2 full-time dietitians who are amazing, as is everybody. We have lots of nurses involved. And then we've had over time, Chris Kozlowski, our clinical nurse specialist, who was very much involved with our QI work. And that's me on the bottom there. All right. So just as an introduction, for our small baby, why did we focus on the 22 to 29 week group? And essentially, if you look at our numbers over the last over 5 years, before we decided to do this, around 2012 to 16, if we just looked at the very small babies up to 25 weeks, we would have only had 2 babies admitted a month to do this on. And we felt that that was not going to be enough to sort of develop skills, maintain competencies, etc. And so we extended it to include babies under 30 weeks, which would on average give us about 6 babies a month, which we thought would be adequate. Just looking at the population that we're dealing with, you just saw this slide on the previous talk, but this is the gestational age distribution of our babies over the years, with the numbers on the right-hand side over here. You can see that the majority of our small babies are actually the bigger small babies, in a sense, between 27 and 29 weeks. Typically, about 60% of our small babies, which is a good thing for the mothers and the babies. And it changes over time, right? So certainly the data, when you have small numbers and you see changes on your outcomes over time, one has to bear in mind about the population that you're dealing with. And so for 2022, for example, we had a lot more of the smaller babies, which may have had an impact on some of our outcome data. And then in terms of maternal race for our inborn babies, it's pretty obvious that we've had quite a significant rise of Hispanic patients in our small baby, almost close to 60%. White babies are around 30% more or less, with Asian and Black babies accounting for about 10% each, more or less. That's just the patients that we see. Okay, so when we started the small baby, really our overall global aim was to try and improve survival without morbidities. Every mom, is having a baby, and ideally she wants to take home that baby, and without major morbidities. And so when we looked at this data from Vaughan has this collection of data. When they look at what they call major morbidities, which includes severe IVH, necrotizing enterocolitis, any late infection, chronic lung disease, pneumothorax, and periventricular leukomalacia. Back over here, we thought we're the blue dots over the years, and the gray bar is Vaughan's 25th centile and Vaughan's 75th centile, with their median somewhere in between. And we thought we sort of fell off the wagon a little bit, and we could do better And so our overall global aim was to try and improve survival without major morbidities from around 52% to 58% would have taken us to the 75th centile. For this talk, we're just going to focus on nutrition. And so one of the places that we started was to look at potentially better practices for nutritional support that were already published in the literature. And the California Perinatal Quality Care Collaborative, which was sort of ahead of the game, published these potentially better practices some time ago. And they focus on human milk, obviously, how to feed, when to feed, TPN, and some general potentially better practices. And so they include providing consistent nutrition care standards based on evidence or expert opinion, to monitor nutrition standards, to monitor for malnutrition, which our dietitians do, and to track our CQR data to modify our practice. And I'll show you a lot of data in future slides. With regard to TPN, to have a computer order entry system, which is what we do. I don't know what's happening with my slides, but there seems to... Anyway, I can continue. So to have a computer order entry system, to use a starter TPN within the, immediately after birth, to provide lipids within the first 24 hours, and to stop TPN and take out that PICC line when the baby's getting adequate amounts of enteral nutrition. In terms of that enteral nutrition, the focus should be on starting colostrum oral care, which you've heard about, or oral immune therapy shortly after birth, to start trophic feeds on the first day of life, to have a standard approach to feeding intolerance, which our nurses have excelled at, to provide feeds either via bolus feeds or use continuous feeds, to try and avoid transpyloric feeding, to have feeding advancement guidelines, to fortify the feeds before one reaches full enteral feeds, and to advance the feeds to provide adequate growth along the growth curve. Certainly, human milk, mother's own milk, is the feeding of choice, that we should advocate for human milk, that we should give the parents accurate information and then respect their choice. Not all moms want to provide breast milk. That the hospital should have policies to support breastfeeding, and that we should help the mom both establish her milk and maintain her milk supply. And then there are others in terms of transitioning to oral feeds, which is beyond the scope of this talk, discharge planning as well. And then other unresolved issues, I would say, probiotics, which has received a lot of press lately, and whether to use mom's milk if there's C and B. I've lost control.
Can you click the screen? There you go.
Okay, so we did a gap analysis with regards to nutrition here at Hackensack. And you've heard about the antenatal maternal consult, where we talk about mom giving us her breast milk. We talk about using donor milk and talk about putting the lines in necessary to provide TPN. We wanted to start early colostrum oral care before 12 hours of life, and start the first feed also by the first 12 hours of life. We want to get, in the absence of mother's own milk, to use donor milk as an alternate milk and not to use formula. And for that, we need the mother's assent. We want to put central lines in, but we also want to take them out when we don't need them, and not to leave them lingering. Like I said, we use a starter TPN on admission for all these babies. We've always had a computer entry system for our TPN. We stop the TPN when the baby reaches about 120 per kilo, and then indications for using other forms of lipids for babies who have TPN-associated cholestasis. We have feeding protocols for advancements of feeds, which I'll show you, for 3 different weight categories. We like to supplement our milk early at when the baby reaches 60 per kilo, up to 22 calories, and then up to 24 calories when the baby's on 80 per kilo. And we've subsequently actually changed that, and we're now skipping the 22 calories and going straight to 24. Vitamin D, we do check vitamin D levels once the baby reaches full feeds. We start iron at 2 weeks of life once the baby's on full feeds. There are indications for extra protein and fat, which our nutritionists follow. We follow nutrition labs on a schedule of every 2 weeks. And in terms of outcome, we look at our Fenton curves quite religiously and the Z-scores. We look at growth velocity, and I'll show you some data focusing on enteral feeds at discharge, trying to avoid babies going home less than the 10th centile. And then, of course, trying to prevent neck and spontaneous intestinal perforations. In terms of research in our unit, we are currently enrolled in a probiotics trial. And then in terms of quality improvement, as you've heard, we've been involved with VON for many years. We're also a member of the New Jersey NICU Collaborative, and we've done some work with them. And then in terms of the small baby moving forward, we're looking at when we should transition these babies to breast and bottle feeding, and whether or not we can feed these babies who are still on high flow nasal cannula or CPAP. So this is a driver diagram that we came up with to try and improve survival without major morbidity. Again, our overall goal was to improve that from 52% to 58% by December 2019. And as regards to this talk, try and reduce neck. And our specific aims here were to use early colostrum mouth care before 12 hours, early trophic feeds starting before 12 hours, to have feeding advancement guideline, and to use to get donor milk assent. And for some of these, we got the JACO certification for disease-specific care, which we're very proud of. So this is obviously something that we're trying to avoid when we feed our babies. As you can see, is necrotizing enterocolitis, big distended belly, very shiny, has a high mortality associated with, unfortunately, and morbidity. You can see pneumatosis, free air in the portal venous system, and ultimately perforation with free air under the diaphragm. Okay, kids with SIP sometimes are too small and too sick to go to the OR. Sometimes they'll just get a Penrose drain placed, and ultimately those kids that do go to the OR end up getting some kind of ostomy, typically of the small bowel with a mucus fistula, and that's what we're trying to prevent. Okay, so the focus is on mother's own milk. Okay, why is mom's breast milk best? So in the NICU, certainly it's associated with less enteral feeding intolerance, less nosocomial infections, less neck, chronic lung disease, retinopathy of prematurity, less developmental and neurocognitive delay, and in some studies, less hospitalization after NICU discharge. And as Paula Maia has pointed out, the impact on morbidity is really related to both the dose and the exposure of mother's own milk. So in terms of dose, the percentage of total enteral feedings being mother's milk, or the total number of moles per kilo per day. And then in terms of exposure, the actual number of days that the baby receives any human milk has been associated with decreasing morbidity in these little babies. So starting with colostrum oral care, the goal here was to try and get it into the baby within 12 hours of life. Essentially, colostrum oral care and also trophic feeds is really simply the practice of feeding nutritionally insignificant volumes, right, of enteral substrate to stimulate and supply nutrients to the developing GI system. So in the first days after birth, the paracellular pathways in mom's mammary epithelium, they open up and they allow all these good things to cross over into the milk, antibodies, anti-inflammatories, growth factors, other protective components, to get into the milk and then cross into the baby's GI tract. And essentially, they stimulate rapid growth of the intestinal mucosal surface area, facilitating endocytosis of protein and reducing digestive enzymes. And in animal models, what they've shown is if you don't give the if you don't give that preemie animal colostrum, the GI tract doesn't mature. And they've done this on little piglets, and it results in atrophy of the GI tract and also increase in inducible nitric oxide synthase and cortisol levels, all associated in animal models to be associated with necrotizing enterocolitis. Compared to mature milk, colostrum, right, has much higher concentrations of these protective substances, which improve immunity, decrease microbe adherence to the mucous membranes, and may even protect against ventilator-associated pneumonias. The mothers of least immature infants also have higher concentrations of the most protective colostrum, just highlighting the importance of getting that colostrum from the mom and giving it to the baby. In a review of some randomized controlled trials, they showed that colostrum leads to an increase of gastrin, enteroglucagon, and motilin, which really stimulate late GI growth, function, and motility. It improves enteric blood flow, increases proximal intestinal motor activity, decreases the time to reach full feeds, decreases the risk for sepsis and for length of stay. So we use it for oral care in our nursery. We also use colostrum for trophic feeds. It's been pointed out that it should be fed in the order that it is produced, even if it's frozen. So the containers should be numbered. After 3 to 4 days, one can alternate it with fresh breast milk. It's best if mom uses hand expression or a hospital grade pump to get the first milk, and to avoid using any formula with it or any human milk fortifiers that will interfere with its effect. And so we came up with this kit in a plastic bag that we take with us. As you heard, about 3 hours after life, we go back and talk to mom and dad, tell them how their baby's doing. And then we take them this kit, and it's got these little, these snappy containers, right? And little syringe, and we ask the postpartum nurse to help mom hand express and to get that first colostrum and to bring it into the NICU. And at the same time, we've got the assent form here for donor milk, so it gives us an opportunity to discuss donor milk with the mom. And then we've got our card, so she knows who she's talking to, and also the business card of our lactation consultants. And this is some of our data when we first started. So this was in terms of getting oral colostrum within the first 12 hours. And this is starting in the 4th quarter of 2018. And these are the numbers of babies that we're dealing with down the bottom here. And so we were way less than 50% in getting colostrum within 12 hours. And slowly it increased, and we got to 100% by the 3rd quarter of 19, 4th quarter of 19, the 1st quarter of 20, and then boom, COVID hit. And so our numbers fell off a little bit as there was a separation of mom and babies, and things changed around. Small baby things changed in terms of small baby practice, despite best efforts. And so we fell off the curve there a little bit. In terms of this is an audit done more recently on 30 babies from last year. On the x-axis here is the baby's gestational age, and you can see here the time from admission to first oral colostrum care, and the median is 18.5 hours. So we're off our 12-hour mark, and as with all QI, it's a challenge to maintain the gain. Some of the potential barriers and challenges that we face are we've had a lot of new staff join us, both nursing, doctors, moms who are unfortunately taking other substances that we can't use with breast milk, so that interferes with that. Moms who come from other hospitals transferred in, there's typically a delay in getting her colostrum. And then, of course, if mom's sick, baby's sick, and moms after C-sections, sometimes the last thing they want to do is hand express. In terms of the early first feed, our aim was to give the baby the first feed, trophic feed, using either her own milk or donor milk, also within the first 12 hours of life. The reasons here is that, again, early feeding promotes intestinal adaptation, it avoids the effects of enteral fasting, helps decrease villus atrophy, promotes intestinal hormone and enzyme production, improves gut transit time, reduces cholestasis, and just really prepares the gut for later advancements of feeds and helps improve the tolerance of feed. Probably the best maneuver that we did to achieve this was to take out the MPO order that was on all order sets, admission order sets. And we actually took that out of our order set and replaced it with a feeding order. And so for our small babies here, for example, on the first 3 days, between 500 and 750 grams, we'll give 5 to 10 moles per kilo per day, divided Q3 or Q4 hourly trophic feeds. And this was our data, again, when we started small baby. We got to 75%, more than 75% pretty quickly. And then when COVID hit us, it didn't really affect our ability to give that first trophic feed, primarily because we had the donor milk and we had donor milk availability. So we were able to maintain at least more than 75% of the time for these babies to get their first trophic feed within 12 hours of life. And then looking at that same data set from last year to 2023, our median time for first enteral feed was 12.5 hours, which is pretty close to the 12-hour mark that we originally set for when we developed the small baby. So here, looking at our first enteral feed from last year, our cohort from last year on small babies, the majority, over 75%, are getting donor milk for their first feed, and just a little under 25% are getting mom's own milk, and certainly none are getting formula. We hardly ever use formula initially for our small babies. In terms of preventing NEC, certainly for infection control, hand washing, we do a lot of work on that. We've done a lot of work over the years. But what I wanted to point out here is that from the Journal of Perinatology in 2017, they showed that just having a standardized feeding regimen for your small babies can significantly decrease the risk for necrotizing enterocolitis. And you can see on this forest plot with the diamond here way to the left, supporting having a standardized feeding regimen. This is our feeding regimen for babies, 500 to 750 grams. The goal is to provide consistent and a standard of care. It's easily accessible. We have it both in printed out on sheets and in a binder at the bedside, as well as a link in the order set, so those who are putting the orders in can look at it and refer to it and to see how much they should be ordering. And as I said, for the first 3 days in this cohort, 5 to 10 moles per kilo per day divided Q3. And then we feed our babies mostly bolus feeds to start, but if they're not tolerating, we will use continuous feeds. And in our unit, continuous feeds means 3 hours on and 1 hour off. And here's something similar for the next cohort. It's babies 750 to 1,000 grams, and with just slightly larger volumes. In terms of feeding advancement, so you just saw what the protocol that we use. Certainly in the old days, it was there was probably old data that suggested we shouldn't feed more than 20 moles per kilo per day, an increase at more than 20 moles per kilo per day because it was associated with NEC. But now that's really considered to be old data, and there's more data from recent reviews and meta-analyses to suggest that one can actually give more than 20 and that it is safe with no increase in morbidities. And certainly the advantages are that the babies regain their birth weight earlier, will then have fewer days on TPN, and allows you to get the PICC line out earlier to avoid that clemency. So this was data published in the New England Journal from 2019. It was a controlled trial of 2 rates of incremental feeding rates. Slow feeding rate was 18 moles per kilo per day. fast rate of 30 moles per kilo per day with good numbers of babies here in the almost 1,400 in each group. No difference in late onset sepsis, no difference in NEC of 5, which is 5%, and no difference in death before discharge, but significantly less time to get to full feeds, here defined as 140 moles per kilo per day, and significantly less days of TPM. The same study then went on further to look at these babies at 24 months of age, and there was no difference in survival without moderate or severe neurodevelopmental disability. Very encouraging data with looking at lots of babies. So it seems to be that advancing fees a little faster is safe. This was then followed by Cochrane, the Cochrane database systematic review that was published in 2021. Looked at 14 trials, over 4,000 babies, small babies, looked at a slow advancement of 15 to 24 moles per kilo per day versus a faster advancement of 30 to 40 moles per kilo per day. And again, the slow rates did not reduce the risk of NEC, death, or feeding intolerance. And then these are just some slides on the forest plots of, you can see the risk for NEC was right on the zero here. As mortality, no effect on mortality, no significant effect on feeding intolerance, although it seems to hint that they might favor, the faster rates might actually be more favorable. And no significant effect on infection, but a hint that it does favor the faster rates in terms of decreasing invasive infection. Okay. Our use of donor milk. So we've been using donor milk for some time now. It's offered to all small babies. Well, we started using it for small babies. I would say it's now subsequently been made available to all babies in the nursery. But in terms of small babies, we started using it many years ago, and with the aim that we will discontinue it once the baby reaches about 34 weeks. Corrected gestational age. It must be remembered that it's just a bridge, right? Donor milk is just a bridge until mom can give us her own milk, because mom's milk is superior to donor milk, but donor milk is also a very nice alternative and certainly better than using formula. This was the California Perinatal Quality Collaborative data looking at paired rates of NEC. From both before they started donor milk compared to afterwards. And you can see in all these 22 centers, after they introduced donor milk, NEC rates in each center decreased. Some more than other units, but in all centers, NEC rates decreased. And then we participated in a similar trial here in New Jersey with the New Jersey Collaborative. And kudos to Chris Tazlowski and Chris Padone, that you're going to hear from later. They published this paper looking at rates of NEC in those centers that had no donor milk, had rates of NEC of 5%. To similar rates in centers that then changed to donor milk. So before introducing donor, they were also around 5%. And then after introducing donor, the rates have in those units decreased to 2.9%, which was considered significant. So that was a very nice paper that we got through collaboration with the New Jersey NICU collaboration. Okay, this is how we use donor milk. You can see here, these are the 30 babies from last year that I looked at of increasing gestational age. The blue lines are mom's own milk as a percentage of the baby's feed that the kid gets over the first 7 days of life. And you can see there's more blue than red being donor milk. Some moms just can't give us breast milk, and so they're all on all donor milk. That's for that shows our use for the first 7 days, and then continued out to the first 2 weeks. It's very similar. Now we've got more use of mom's milk, but again, in reality, some moms just can't give us breast milk. And then you'll see, depicted as the red bars here. Days to regain birth weight, looked at 48 babies from last year across gestational ages. And I draw your attention to the box on the top here. So overall for the group, we had a median of 10 days for these babies to regain birth weight. It's obviously higher for the smaller babies, the 22 and 23 weekers, with a median of 13 days. And it decreases as you get to the bigger small babies, the 27 to 29 weeks, having a median of 9 days to regain birth weight. Something the data that we look at when we're making our rounds. And the same with the change of Z-score when the birth weight is regained. And you can see overall for our group, it's the Z-score changes by minus 0.76. Standard deviations, it's much more for the, how do I go back? Much more for the very small babies under 24 weeks, and much better for the bigger small babies, 27 to 29 weeks. And then as time goes on, we use the Fenton curves. It's in our electronic medical record. The weight is plotted every week with these circles, and we're able to look at how the baby's doing in terms of gaining weight and crossing percentile lines, as well as getting Z-scores. Okay, and we're looking at this on a weekly basis to see how we're doing. Here, the baby started off pretty bigger, I suppose, on about the 90th centile, loses weight, takes a good 2 weeks before he gets back to birth weight, loses weight again, and then sort of hugs just above the 10th centile, and then starts to take off around here, the 34th week, and actually gets back to the 50th centile with the time of discharge. And so our nutritionists are on rounds with us on a daily basis, looking at this data and helping us with interpreting weight gain. If you haven't got the Fenton curves, there's an app for that. It's available as an app, and you can plug in the data and get the baby's percentile and the Z-scores. And you can also look at growth parameters. You can plug in the data and get certain growth parameters. And the one that our nutritionists are looking at is the expected weekly increase of weight to maintain the current percentile. And then in addition, our practitioners are using looking at definitions of malnutrition in the nursery. These was published data from 2018, looking at mild, moderate, and severe malnutrition, and looking at parameters like decline in weight for age, Z-scores, weight gain velocities, and nutrient intakes to help make those determinations and to help then tailor the feeds as the baby needs them. Other potentially better practices to prevent NEC is certainly probiotics. The data does support using probiotics to decrease NEC, but now with the safety issues, that seems to be on hold. It is not currently recommended to avoid H2 blockers, which can act as a barrier to microbes. From one study, to avoid profound anemia, there was a thought at some point that blood transfusions might be associated with NEC, but probably is not that, not the blood transfusion itself, but maybe the profound anemia before you get the transfusion. And then to minimize antibiotic exposure and duration of therapy. So antibiotic stewardship, we've been practicing for many years with our electronic medical record. We put a limited number of doses into the computer, try and avoid treating culture negative sepsis, and to try and avoid giving not all these preterm babies when they're first born need antibiotics when they're born for maternal reasons. And this is data showing the odds risk of developing NEC as the longer one is exposed to prolonged courses of antibiotics. And this is our rate of necrotizing enterocolitis over the years. And when we started small baby, we were sort of at the upper range here, above the 75th centile, which gave us incentive to address this problem. We use the one definition in making the determination. It's one clinical sign of either a bilious gastric aspirate or emesis, abdominal distension or discoloration, as you saw in that picture earlier, and occult or gross blood in the stool with at least one sign on X-ray, so either pneumatosis or hepatobiliary gas or a perforation. Sorry, to go back. Once we started the small baby and made these initiatives, our rates did decrease. We decreased from almost 10%. We came down one lucky year over here, probably just luck. And now we're more closer to around 5%. So looking at our observed minus our expected rates, here we were above, not good. And we've made some progress. Now you can see we're significantly below the whiskers are significantly below the line as we decreased our rates to around 5%. In terms of parenteral nutrition, our goal is that all babies under 2,000 grams will get started TPN. The started TPN is in the unit. It's locked up in the Pyxis and is available. We've just got to warm it up. And is one of the first fluids that gets hung once the lines go in. And then our second goal is to get the baby off TPN when the baby gets to feeds of about 120 mils per kilo per day. And these are recent guidelines published by Aspen, the American Society for Parenteral and Enteral Nutrition, published just last year. They looked at 57 clinical trials over the last 20 odd years. These are some of their findings. So they recommend actually using starter TPN. We do that to start with an amino acids of 3 grams per kilo per day, and then slowly to advance to 3.5. They showed there's actually an increased risk of sepsis if you start with more than 3. But its effect on growth hasn't been determined as yet. What about starting at 4 grams per kilo per day? Well, they showed it had no real growth advantages and actually may be associated with higher rates for CP and worse Bailey scores at 18 months. And here's the forest plot favoring starting with less than 4 grams per kilo per day. From the PROVIDE trial, I think this is out of the UK, published in the New England Journal. This was a study that had a placebo of small babies. The placebo group got an average of 2.6 grams per kilo per day for 5 days of protein, and the intervention group got an additional gram per day through the UV line for 5 days. And these kids ended up having a mean of 3.5 grams per kilo per day. And while there was no overall difference in neurodisability, there were differences in moderate and severe neurodevelopmental disability and a significant increase in moderate to severe Bailey score delays. So to try and avoid starting with too much protein. This is our data, a small group of babies from last year. And you can see where we were actually giving more than 3 for our 22 to 24 weekers, starting at 3.5 and then advancing to 4 of parenteral. This is parenteral protein, right? Probably too much. And while our bigger babies also were probably getting too much, their rates would come down once their feeds were more established. And so we changed our protocol, and now we're starting with around just less than 3 grams per kilo per day, and then going up to a maximum of 3.5 grams per kilo per day. In terms of lipids, they recommend using to prevent essential fatty acid deficiency, using at least 0.5 gram per kilo per day of intralipids, and then advancing slowly to a max of 3 grams per kilo per day. There's no evidence of growth benefit from any one particular form of intralipid. No one specific product is recommended over the other to prevent TPN-associated liver disease. There was some data to suggest that decreasing the soy oil that you see in intralipids and increasing the fish oil may be associated with a decrease in the risk for severe ROP, stage 3, but this needs further research. And there was a strong recommendation that we shouldn't be decreasing the dose to prevent sepsis. The babies need the calories. And so here we have a guideline that we use in terms of initiating intralipids, how to advance it, the max goal. We check triglyceride levels, and we have cutoffs aiming to keep the less than 250 milligrams per deciliter. And there's a guide as to how we should adjust that based on what the level is, but at least maintaining the 0.5 gram per kilo per day to prevent essential fatty acid deficiency. And then this is our data from last year, looking at when the line comes out. And you can see here's 120 moles per kilo per day of enteral feeds. And you can see that we're pretty close to taking our lines out when the baby reaches close to 120 moles per kilo per day. In terms of routine enteral supplements, we focus on vitamin D. Sodium is a new initiative, and iron. Well, I'm not going to speak to iron itself. I'm going to just address the vitamin D and the sodium. So certainly we want to prevent rickets. Very small babies are at high risk. Those who are on TPN for long periods of time are at high risk. Babies with BPD who get treated with diuretics and fluid restriction puts them at increased risk. Same with the use of steroids in those babies. And certainly babies who've had neck and unfortified breast milk are at increased risk. And here you can see the swelling at the costochondral junction, gives you that little sort of owl eye look on the chest x-rays. And if you do x-rays, the long bones, you can see changes in the epiphysis and metaphysis here, classic for rickets. Just to point out of the intakes of calcium, phosphorus, and vitamin D for babies that are feeding, full feeds, certainly in our unit of 160 moles per kilo per day. Unfortified human milk, there's very little calcium, phosphorus, and vitamin D. I mean, we fortify our human milk. This is up to 24 calories per ounce, and you can see the numbers are much higher here. Preterm formula has even more than fortified human milk. And I just want to draw your attention to the fact that when these babies go home, they're no longer taking preterm formula. They should mostly switch to transitional formulas, which have slightly lower levels of calcium, phosphorus, and vitamin D. And so those babies might need additional supplementation when they go home. And so from the Committee of Nutrition summary, breast milk needs to be fortified. Breast milk needs to be fortified or use the preterm formulas. There should be a routine evaluation of bone mineral status. So for all babies under 1,500 grams, typically at around 4 weeks after birth, and then every 2 weeks after that until they settle. We focus very much on the vitamin D levels. So once the baby gets to full feeds, we do send away for a 25-hydroxy vitamin D level. The goal we're looking for is more than 20 nanograms per deciliter. So certainly if the baby's level is more than 20, we'll give supplements of 400 international units a day. And if it's less than 20, we'll give that dose twice a day and then check levels approximately 2 weeks later to see where they are. Certainly babies that have very high ALK-Phos levels, more than 800 to 1,000, to be cognizant of the fact that these babies might have rickets, at increased risk for fractures. Nurses need to know that. Take extra care in handling the babies, and then to maximize calcium and phosphorus intakes in those babies and to minimize the risks for bone mineral loss, the use of diuretics and steroids. Certainly babies that have low serum phosphoruses that are persistent, supplementation should be considered. And then, as I said before, at discharge, kids going home on transitional formulas probably will also need supplementation because they're going to go home on less than what they were receiving in the NICU. And this is just a graph that shows the same cohort of babies and their vitamin D levels when they come off TPN. And there's a good number that are under 20 and that need supplementation. So just get a hint that that the smaller babies have lower levels and the bigger babies within this cohort have slightly higher levels. In terms of sodium, this is a new initiative that we started looking at probably from last year. These preterm babies are at high risk for losing sodium and becoming total body sodium deficient, and that's ultimately going to affect their growth. Probably as a result of antenatal corticosteroids that the moms are getting that cross over to the babies. These babies are having an early diuresis and natriuresis that's certainly wasn't described in the old literature. We see that these babies can lose significant amounts of sodium in the first days, up to 8.5 milliequivalents per kilo per day in the first 2 to 3 days. That's quite a lot. And certainly while they're on TPN, we have the ability to give them the sodium and to tailor their needs in the TPN pretty easily. But once they come off TPN and they're just on enteral feeds and it's just breast milk, breast milk or donor milk, so these kids are at risk for having a big drop in their sodium. And the downside is that they don't grow as well. They can have neurologic dysfunction as a result. Some people have described increased risk for IVH and sensory neural hearing loss. And the mechanism of action is probably related to the sodium H+ ion antiporter system here in the cell. So when there's enough sodium in the body, the transporter system works well. Sodium comes into the cells, H+ ion go out, maintains a normal pH in the cell, and allows for DNA synthesis. And then just the opposite, when you total body sodium depleted, so the antiporter system doesn't work well, the H+ ions accumulate in the cells, makes it more acidotic, and it affects DNA synthesis. So to try and improve growth, we thought we would supplement our babies with sodium. And this slide just shows how much sodium is in these different milks that we give our babies. So here, if you take a baby, for example, who's on 160 mils per kilo per day of feeds, using preterm breast milk, is only going to be getting 2.4 milliequivalents per kilo per day. Certainly, if you fortify it to 24 cals, it goes up to 3.6. Donor milk's even lower at 1.4, and with supplementation, with fortification rather, comes up to 2.7. And Formula has a consistent level of 3.2 milliequivalents per kilo per day. Probably not enough. And this is what we decided to do in our very small babies, just once they get to full feeds off the TPN, to give them additional sodium. And then we divide the dose every 6 hours. We don't give it if the sodium is more than 144. We weight adjust the dose every week, as we do with all our other medications. And then we use serum sodiums and urine sodiums to guide our use of sodium supplementation, and then hopefully get the baby off about 34 weeks of gestation. And since we've started using it just last year, I don't really have any data to share of how effective this is. And then lastly, to move on to our outcome data, the aim was certainly to provide, hopefully that more than 75% of the very low birth weight babies would go home on some breast milk. And here you can see over the years, looking at 500 babies in this cohort, 76% are going home on some milk, some breast milk, 25% formula only. Compared to Vaughan, we were sort of doing pretty well. We came down a little bit, but still we're up here with in the upper centile compared to Vaughan. A lot of our babies are going home with some human milk. The numbers are better for the bigger babies within the cohort at more than 75%, and it's a little less, but still more than 50% even for our babies born under 24 weeks. In terms of what these babies are feeding in the last 7 days before they go home, it's a bit of a mixed bag at this point. So this is their total feed, looking at their total feeds over the last 7 days before discharge. A third will be taking mom's milk only with supplementation, with fortification. Just less than half will be getting more than 75% of mom's only milk. Also less than half getting more than 50%, and 12 out of 30 going home with formula only. Other outcome data that we can look at is growth velocity at initial disposition. These are excluding babies born small, and you can see we're sitting here at just around 13 grams per kilo per day over time. It is a challenge. I think it's fair to say that it's in the better centers of Vaughan, the upper centile is increasing, but it hasn't really increased for the centers at the bottom. Sending home babies greater than the 10th centile here, you can see we're in the better quartile. We send home few babies less than the 10th centile, but it does change from year to year depending on the cohort. And this is looking at babies even smaller going home under the 3rd centile. So we feel like we are growing our babies appropriately over time. I'm going to skip the change in Z-scores. And in terms of race and ethnicity, for equity, this is any human milk, going home with any human milk at discharge for this cohort of babies. And you can see the numbers are pretty equal across the different races over time in terms of going home with any human milk. And then again, looking at one of our first slides, looking at survival and survival without morbidities, also very similar amongst the races, with the green bars here of looking at survival and going home with, and then the blue ones looking at survival without morbidities. Pretty similar across the races. And then lastly, my last slide, I just want to express thanks, gratitude, and appreciation to the team. Like it was said earlier, this is a team sport, and these guys do incredible work, both at the bedside and in collecting data, etc., and keeping us on our toes. Thank you.
So we are going to be starting our first Q&A session. I know that there are lots of questions for our presenters, and moderating our session will be Dr. Shetal Shah. He is our District 2 section on neonatal perinatal medicine representative. And from having worked closely with him and the AAP, just want to also highlight that among his many accomplishments, Dr. Shah is one of our greatest advocates in the legislature for making donor milk available to our NICU patients. So give us just one moment as we transition, and a warm welcome to Dr. Shah.
All right, thank you guys. Hopefully everyone can hear me. I'm assuming people will chat in if they cannot. I'm going to ask if the presenters from the morning sessions can show themselves on screen so we can go through the questions. I think you guys have covered a lot of ground, but I think a couple of sort of themes emerge, right? Obviously, the theme of teamwork has been, I think, talked about really in almost every single talk. But I want to go back to actually the beginning of the conference with Dr. Ashner, where she was talking about the importance of knowing that there is no one NICU that does everything well. So knowing what your practices are and knowing what you do well, and then focusing on the things that you don't do as well, is really how we all move forward, particularly for the smaller babies. So I'm going to start going back to, I guess, Dr. Spillane's talk. There's a lot of sort of, I think, technical issues as well as some theoretical issues that, so the very first one, which I thought was interesting, was, do you use transcutaneous monitoring? And I think that's something that a lot of people are reconciling with now that there's the potential for the temperature at the interface to be a little bit lower. So there's less of a concern. I'm not going to say it's gone away completely about injuring the skin. And then, of course, the worry about putting a baby on high frequency ventilation of any sort earlier and maybe potentially driving the CO2 down too low in that first few hours of life. So I'll start with that question. And I guess that goes to both Dr. Spillane and Christine.
Yes, thank you for the question. I think that you do bring up a good point about the concern about hypocapnia and overventilation with the oscillator. I'm actually going to start with the easier question first. But I think that certainly was a concern for me when I joined Hackensack and first started using the oscillator as a primary means of ventilation. And I think that since the team here has so much experience with it, they really well indoctrinated me and into how to start the oscillator at a setting that's appropriate for the baby and the underlying lung disease, and not leaving the bedside until you've really got the appropriate jiggle and feel like you're at the right place before, and getting that first blood gas early. We did say get it by 1 hour of life, but oftentimes we're getting it in the first 30 minutes of life. And so really looking at the x-ray, looking at your baby, knowing how much support you gave in the delivery room, and adjusting the settings for the appropriate jiggle. So your baby has good jiggle, but doesn't have too much jiggle. And we haven't seen a lot of overventilation with close monitoring as we transition the baby to the oscillator. So that's the first question. The second question about transcutaneous, we don't currently use it in our NICU, but we are actually, it's on our wish list for capital for this year. Yes, Dr. Plana has a comment as well.
Yeah, we certainly recognize the possibility of overventilation, and we've made several attempts over years to get the appropriate machine to do transcutaneous CO2 measurements. We just couldn't get it to work. We tried, and we just couldn't get it to work. Initially, with the older technology, I guess there was risk for burns on the skin, and even with the newer technology, we just couldn't get it to work. And so, hopefully, moving forward, it'll improve, and we'll get better machines.
Going along the lines of some of the technical questions, there was a question about transporting from the, I think a lot of people were sort of mesmerized by the video, by the way, just because there are a lot of questions related to that. How do you transport to the NICU from the labor and delivery room? Do you use a shuttle? Do you use a vent? Or do you close the giraffe, I'm assuming, that you showed in the video, and transport that whole sort of unit directly, and that sort of becomes the admit bed space?
Yeah, good question. So we are very lucky in our unit that our labor and delivery is in very close proximity to our NICU. So you can practically reach from one unit to the other. So our transport distance is very short. So we admit directly into the giraffe, and then we have a neopuff or a T-piece resuscitator on wheels and a portable monitor, and we transport the baby in the giraffe without a shuttle into our NICU, and we use that giraffe as their admission isolette, and then we transition them to the oscillator or whatever the appropriate respiratory support is.
There is a question here that I believe you guys did answer in your presentation about extubating directly from high frequency oscillatory ventilation. I think you did show that slide where you had sort of your parameters for extubation on high frequency with the mean airway pressure of 8. So I'm going to defer that question just because it was answered. There was another, again, along the lines of the technical question about the double lumen VC, double lumen UVC, and if you're using the double lumen UVC, do you split the TPN, and how much heparin goes into each of those lines? Particularly, I'm going to assume that question is really focused on the 22-weeker baby, because there's a lot of question about whether the standard dose of heparin for a 25, 26-weeker is okay in a child who has such smaller, just such a different volume of distribution.
Yeah, that's an excellent question. I have to say we haven't standardized that. I'll tell you what our typical practice is. And that is that we put the TPN through only one lumen, and we use the second lumen kind of as our swing fluid, right? As we know, many of our babies that are 22, 23 weeks are going to have a lot of issues with fluids and electrolytes. So oftentimes we can use that second lumen to adjust other fluids to try to manage the fluids and electrolytes. But we have to say, that's the way that we initiate the use. And then obviously, depending on how the baby's doing clinically, we might adjust to whatever is appropriate for that child.
No, I think it's an interesting point because one of the things that we're learning, I think, from all of the focus now, not just in this conference and in this forum, but really around the country, is all of the different ways that units have been able to do things and be successful. And I think that's important because I think that speaks more to the teamwork aspect of it than it does to there's one right way, quote unquote, to do it. Plus the fact that there's such an absence of randomized trials on a lot of this type of stuff because these babies are few and far between to begin with. And standardizing practice for our true randomized control trial is very difficult because a lot of these practices now are becoming ingrained. But I do think the heparin question is one that we are going to, if we start seeing large numbers of bleeds in those babies, we're going to need to know if that's just because it speaks to their underlying fragility or if because we're facilitating that process, all of us, by giving sort of standard doses of a lot of our other micropremi drugs. I mean, I think Dr. Alkan talked a little bit about this when he was talking about the movement of prematurity to earlier and earlier gestation. We're 23-week babies are 90% water, 22-week babies are 93% water. At some point it's a bag of water with sodium in it, right? I mean, in terms of a fluid and electrolyte problem. So we're really going to have to start thinking about the volume and distribution about these types of drugs. Moving on to a couple of questions now related to feeding. So I'm assuming these are directed to Dr. Planner. One is a very interesting question too, talking about the assent for donor milk products rather than consent. And this is a very big thing that a lot of us are talking about as we aim to do what you guys do, which is to get the colostrum oral care beginning as early as possible and to begin those enteral feeds as quickly as possible. So I was wondering if you could speak to how, I guess, the medical legal process or the thought process behind that. And I think it's important also because sometimes these mothers just aren't in a position to consent. Just because of the underlying illness that led to the need for the premature delivery.
Yeah. What I'll say is that from the very beginning, we got permission, I guess, from medical legal to allow us to get assent as opposed to consent. We've been doing it like this for a number of years. And more recently, as we've adopted a sister unit within the network, they seem to be doing it with I think no assent even. And so the whole thing is up for reconsideration as we move forward. I think if I remember correctly, because it was a long time ago, they agreed that as long as we're talking to the parents and discussing it with them, the benefits and the risks, and with the condition of talking to the patient, certainly after she's given birth and which might not be in a condition to give proper consent with signing documents. As long as we spoke to the mom and spent time discussing it with her and her partner and getting her to agree, then it would be okay to get assent. And I must say, in all the years, we've had very few parents turn us down and say no. There is a subset of patients based on religious grounds that don't want to use donor milk, and we respect that. But in the same breath, these parents are also very motivated to give us their own milk. And so it might take an additional day or two to get mom's own milk instead of using donor milk.
Right. I think we've warmed up the 273 listeners because now there are a couple of questions coming in. I'm going to hit on this theme, which has come up now by 3 or 4 people. which was the decision to use high frequency oscillatory ventilation as the initial mode of ventilation. I think some of this is coming because Iowa's, of course, protocols, which have been sort of promoted, and because they have a large number of babies in the very small weight group, and they've been doing it, frankly, longer than a lot of us have. For their protocols that they've widely shared are based on the jet, and the theory behind that, of course, is that you want to try and have an IE ratio that prevents the prolong the IE ratio such that you have the prevention of PIE. So I guess the first question would be: is PIE an issue for you in your experience with the oscillatory ventilation, with the oscillatory ventilator? And then my second question would be if you could take us through the thought process of why you chose to use high frequency oscillatory ventilation as opposed to the jet.
Yeah, so I can answer part of that, and I'm going to ask Dr. Planer to chime in as well. So initially, this use of the oscillator was championed by Dr. Pearl, who worked in this unit for many, many years, and who really developed a special interest in the oscillator, and became convinced, though, I know the studies are not totally supportive of the oscillator, though he was looking at the open lung studies, which he really felt like promoted that there was evidence that it was more gentle. So at that time, we had only oscillators in our unit. So by kind of default, we started with the oscillator, and it really seemed to work for our unit. And Dr. Pearl really was the champion who really spent the time to sit at the bedside with the nurses, respiratory therapists, our new physicians, and teach them the open lung strategy and the importance of staying at the bedside in that first few hours to make sure you've really targeted the right initial settings. So that's kind of our how we ended up with the oscillator. But in terms of the issue with PIE, we have had at times some PIE, but we're very careful now that we really try to keep our Hertz. We start at 12, and we've seen an improvement with our PIE with the starting of the Hertz at 12 for our micro preemies. And again, really focusing on staying at the bedside and making those changes in real time when the baby's compliance is changing rapidly.
Yeah.
Did you find a higher, I guess, was your PIE experience, this dovetails into another question, which is why I'm asking, why the Hertz of 12 versus 15? Did you find a higher rate of PIE on the Hertz of 15 because they had less time for exhalation, or was that something that you guys chose empirically?
No, we had experience initially. We were starting at a Hertz of 15 for our micro preemies, and we're seeing some PIE. And then, guided with Dr. Pearl, I have to give him all the credit. He really did a deep dive and recommended to the group that we switch to a Hertz of 12, and we saw that problem disappear. I shouldn't say disappear, improve drastically.
Yeah, I think that again just underlies the need for there are no randomized controlled trials specifically of jet versus oscillator. There are trials from almost 2 decades ago now looking at conventional ventilation versus high frequency that found, depending on where the study was done, may have found a difference or not. I remember the New England Journal once published 2 articles, almost 2 identical trials, one in Europe and one in the United States, with 2 different results. So I don't think that answer has been completely settled. But a couple of other questions that are coming in from the chat. The first one is, and I guess this will go to Dr. Alkan to bring OB into it. And certainly I can tell you that this is something we are actively discussing with our OB staff, is what is the gestational age in which the MFM will routinely give steroids? 21 5/7 weeks, or 22 weeks, or 20, I'm assuming, or 23 weeks. Of course, the argument being 21 5/7 would be to optimize 48 hours before they would potentially deliver a 22 0/7. 22 weeks, which I believe the ACOG statement says can be considered, or 23, which is sort of where we've been.
Thank you, Dr. Shah, for the question. Obviously, nobody has the right answer because I don't think we have studied this population specifically, whether utilization of corticosteroids at 21 and 5 will make a big difference, or whether you give it at 22 or even 23 weeks of gestation. In fact, you have to be very careful about utilization of corticosteroids, especially in these micro-preemie setting. And that's for a couple of reasons, because number one is the patient delivering at 22 weeks or 23 weeks of gestation because she's infected? And I think if she's infected, the last thing you want to do is give corticosteroids. So your decision-making of corticosteroid has to be really calculative. You have to calculate whether there are contraindications or not. But if there are no contraindications for us over here at our facility, we administer it at 22 weeks of gestation. We do not give it at 21 weeks and 5 days. The conundrum over here and the challenge over here is how accurate are we with gestational dating that you could say and predict that she is really 21 weeks and 5 days, where she, is that 2 days going to make a difference, right? And I don't think we have the answer, but right now we choose what we have and we stick with whatever data we have in terms of dating.
Very good. I think that there are a few. This question and answer session could go on for a while, but I'm going to just take 2 more questions. One is a question about, and again, I think this comes from potentially Iowa's discussions and Jonathan Klein, is the indications or use of a booster surfactant dose, what used to be called Tolsurf when it was given at 7 to 10 days, but now is called booster dose when it's given 5 to 7 days, for surfactant for babies that might experience a slump, quote unquote, or an escalation in their mean airway pressure and FiO2, unattributed, I'm assuming, to a PDA, around that time, around 4 to 5 days of life. Is that a routine process? Is that something that's being evaluated on as routine care? So I'll sort of leave that for all of you guys to answer.
Certainly, it's not routine, but it's certainly considered when that happens. If and when that happens, we haven't really looked at it in any meaningful way, quite honestly. But certainly, we're aware of that it's being done elsewhere. But we're not. It's not routine or part of a protocol as of yet.
Yeah, it's a really interesting thought, right? Because the original Tolsurf trial was supposed to look at BPD, but all those kids got prophylactic INO as part of the Richard Ballard protocol. So I think a lot of us felt that it wasn't the most applicable to the way we were practicing. But when it became something that we were all thinking about, we all looked back at the same trial and said, well, it was safe. It didn't hurt anybody. So then maybe it's something that should be considered. So I think, again, it just speaks to how the pendulum sometimes in neonatal evidence moves back and forth. We're at the time, and I want to keep everyone in time, but we have one more question, and I'm going to, it comes from Dr. Villanueva, former fellow at Stony Brook, one of mine. Great presentation on the golden hour. Wondering why the decision was made to have top down for 60 minutes after arrival to the NICU as opposed to 60 minutes from time of birth?
Yes, thank you for that question. And certainly, I think Dr. Villanueva makes a good point. There are quite a few golden hour protocols that do focus on 60 minutes from birth rather than 60 minutes from the admission to the NICU. For example, like UNC, that they published a very nice golden hour protocol study, and their goal was 60 minutes from delivery. We chose not to do that for a few reasons. One of which we thought that was not an achievable goal. So as we went forward with our golden hour guideline, we wanted to have something that we thought we could achieve. And then with time, maybe create a stretch goal of decreasing the time. But even with UNC, they looked at their initial time to IV to hands off, and it was 121 minutes. After their golden hour protocol, they only got it to 90 minutes. So their goal was 60, but even with everything they could do to get it to 60 minutes, they were only able to get it to 90. So we thought 60 was a reasonable goal and something that we could achieve with all the things that we needed to accomplish, and a safe goal, a goal that was appropriate.
All right, we're gonna have to leave it at that. The next thing I have on the agenda is the break, and then everyone will reconvene, I'm assuming at 12:30 for the talk on human milk and optimal nutrition. All right, thank you guys very much.
Thank you. Thank you for the question.
Sorry. Okay, I just wanted to make sure I'm on the right phone. Okay, you're good to go. Good to go. Yeah. From a lactation perspective, the two sides of the proverbial coin is one in which the mother dreams of nursing her healthy infant, while on the other side is the reality that a mother faces when her infant is born prematurely. Parents expect a healthy full-term pregnancy, an uncomplicated birth experience, and to be able to hold and breastfeed their newborn. When an infant, however, is born premature, the reality is that the mother must use a machine to make her milk, a tube will be used to feed her infant, and breastfeeding may seem like something that will never be realized. When we started our small baby DSC journey, in order to achieve one of our aim, colostrum oral care within 12 hours, we knew that we needed to cast a wide net to capture all disciplines and units who would be instrumental in achieving our mission. Outside of our NICU team, we partnered with the high-risk antepartum unit, labor and delivery, and the mother-baby units. It was not going to be simply us asking them to do what we needed, but we needed to ensure that we were on the same page and using the same language. In front of you is an image of the one-page educational tool we developed on the who, what, why, when, and how we're obtaining colostrum as early as possible. We identified who was the target population, who's responsible for obtaining colostrum, what is the goal, what's the benefits of colostrum, and why. When should hand expression be initiated? When should the infant receive first colostrum oral care, and how to document in EPIC? Additional education for nurses via mandatory education on hand expression and pumping was also provided. DSC tip of the week was sent via email, daily huddles, and e-learning. As a member of the small baby team, my responsibilities included data collection regarding number of hours to first colostrum oral care prior to implementation, providing education to the various units, prioritizing the small baby family for initial lactation visit, collecting data post-implementation and identifying barriers to achieving our aim, and acted as a resource to hardwire nursing practice that aligned with our objectives. I also provide continuous lactation support and education to achieve and sustain optimal maternal milk production. So this is our team. On top of our list of team members are the parents. From the get-go, the parents of the premature is reminded of the very important role they play in the care of their infant. The father or partner's role in supporting lactation cannot be understated, as they can significantly influence initiation and continued efforts of the mother to achieve and maintain target milk volumes. Parents often rely on their family to help with childcare, transportation needs, preparation of meals, and of course, emotional support. The high-risk antepartum team, labor and delivery, and mother-baby units are tasked with providing early postpartum lactation education, which include hand expression and initiation of pumping preferably within 4 to 6 hours post-delivery. So this is a team where everyone can impact lactation outcomes. This is an image of the colostrum kit that our team put together when we started this project and continue to use today. The kit contained everything we need to facilitate early hand expression for colostrum, such as small oral syringes, an illustrated instruction sheet on hand expression, and information regarding available lactation support and the lactation team's number. The neonatologist is responsible for bringing this kit to the family in labor and delivery when discussion is had regarding mother's own milk and donor milk. The message of early hand expression and pumping is once again shared by the NICU RN when the mother makes her first visit to the NICU. And at 6 hours, the NICU RN is tasked with making a call to the postpartum nurse to remind them of the need for colostrum. Next, we have the social worker who identifies support systems available to families. She may look into parental socioeconomic status as well as any food and housing insecurities, all of which can impact the mother's ability to be able to make milk, express milk, store and/or transport milk. Maternal socioeconomic and educational disparities affect breastfeeding outcomes. Thus, communication and collaboration between the NICU lactation consultant and the social worker enable us to anticipate maternal needs and remove barriers which can result in lactation issues. The oral motor feeding specialist can provide encouragement and the reassurance to the mother that direct breastfeeding can and should be started when readiness is established and when appropriate. The WIC programs, which serve many of our families in their respective communities, have been able to provide many of our underinsured and uninsured families with the proper breast pump to use at home. Then there's a dedicated NICU lactation consultant. Since overwhelming evidence has already established that human milk is the gold standard in infant nutrition, its critical significance in preterm infant outcomes should be the driving force behind ensuring that all NICUs have a dedicated lactation consultant on their team. Lactation support is provided to mothers prenatally, early in the postpartum period, and continue throughout the infant's hospitalization. And when necessary, families are referred to a community-based lactation consultant for follow-up. Lactation consult in our NICU is generally done within 24 hours of delivery or as soon as mother is medically stable. We assess mothers and partners' emotional and mental readiness to receive education. We discuss initial infant feeding goals, review of pregnancy and breastfeeding history that can impact current lactation goals, past history of preterm birth or NICU experience, and of course, we initiate milk expression. As I had mentioned earlier, the small baby family is prioritized when it comes to initial lactation visit. This first visit can either be intensive and comprehensive if mother and partner are receptive, or brief depending on maternal condition. Oftentimes, the mother is eager and willing, but her condition may not permit her to continue to receive education and consult is ended and deferred for later time. If donor milk is sent is still needed, parents are also made to understand that for the most part, this is temporary and serve as a bridge to maternal milk supply and not equivalent to her own milk. So at this point, we educate her in the effective techniques to initiate and support breast milk production, such as breast massage and hand expression, and frequent pumping 8 to 10 times a day. We discuss realistic expectations, a reminder that it does not happen overnight. We review timelines and target volumes. We ensure that she has the tools needed to express her milk post-discharge, such as a breast pump. The breastfeeding in the NICU kit we give her contains a handbook of instructions and information, collection bottles, and diary. You can also contact the WIC program on her behalf. And of course, we encourage early and frequent skin to skin. I plan to formula feed. What then? Well, we need to gain understanding of what they know about breastfeeding. We want to give the parents the opportunity to make an informed decision, understand how they came to this decision, explore past breastfeeding history, including negative past breastfeeding experiences. Inform them of other options without coercion, to pump only with no direct breastfeeding, to pump only for colostrum, pump only for the duration of mother's choosing. Whatever they decide, respecting parental decision is also another means of empowering the family. We want to also educate on breast care for the non-breastfeeding mother. Breastfeeding challenges for the small baby mother are many. Early challenges include the mother being too sick or unstable to initiate pumping. Of course, this results in delayed initiation and of course, a delayed milk coming in. Maternal risk factors, such as things like diabetes, hypertension, preeclampsia, and comorbidities that delay onset of are all comorbidities that delay onset of lactogenesis too. Decreased mammary gland development and exposure to lactation hormones, which generally does not occur with preterm delivery, is another risk factor. Stress and fatigue. The release of oxytocin, which stimulates active milk flow, is inhibited with stress, fatigue, fear, and anxiety. Maternal infant separation, delayed skin to skin, and of course, compliance with pumping. Many mothers are not usually certain of whether they're going to be able to do this and often delay and not be compliant. Later challenges can include prolonged mother-infant separation, daily trips to the NICU, are tiring, childcare responsibilities, are unable to dedicate time for pumping. There is a decrease in supply, which many experience. It can be pumping fatigue, returning to work, as well as a cessation of pumping before infant can be fed at the breast. Close follow-up in the early postpartum period is critical. You want to be able to recognize that the small drops are a step in the right direction and can serve to motivate and reassure the mother that she is progressing as she should be. Review of previously given education is often necessary, as the hours immediately after delivery is a time of magnified stress and anxiety, impacting receptivity and memory. The dedicated NICU lactation consultant is in a position to understand the unique needs of each mother and be able to tailor interactions accordingly. During this time also, we want to be able to provide emotional support, and you want to discuss the benefits again of early and daily skin to skin, which we remind mothers can increase in milk production. Many parents are actually fearful and apprehensive of doing skin to skin, but their feelings must be validated and addressed. And we want to provide them with the reassurance that specific eligibility criteria must be met, and thus skin to skin should not be delayed. Lactation support through the NICU stay is a team effort. Monitoring of maternal milk supply is everyone's responsibility. Identifying issues can allow the team and the lactation to provide early intervention. Some maternal issues may include lower drop in supply, breast issues such as mastitis, engorgement, clogged up, oversupply, pumping fatigue. Mom may feel like I can't keep doing this. And of course, we need to address the guilt of stopping. We want to promote non-nutritive suckling and initiate direct breastfeeding when appropriate. At 32 weeks gestational age, we encourage cue-based feeding. Scoring is actually start. And we encourage our parents to initiate direct breastfeeding as first feeds or as soon as possible. However, there are certain challenges. Parents are often reluctant because 1, feeding has always been volume driven. 2, they fear that infant is too small, too weak, and not ready. They fear that this will delay discharge. Also, there's limited opportunities, need for fortification. Mother's not always present when infant exhibits readiness behavior. We do pre and post feeding weights. Nipple shields are offered to improve transfer and increase maternal confidence. The focus, however, is always on quality rather than on quantity. And of course, there's the post-discharge lactation referral. I feel like a mother. This is what one mother said to me just last week when she breastfed her infant for the first time. While breastfeeding may not be how some or even most mothers feel is a definition of feeling like a mother, it was for this one mom.
As a lactation consultant, I have the distinct privilege of being able to convey to the mother that my primary purpose is not simply to harvest her milk, but more importantly, to support her in whatever goals and plans she had in mind and empower her as a woman and as a mother. We as her healthcare providers cannot underestimate the profound effect meeting this basic and biological need has on many mothers. And if we can help this one mother with making this her new reality, then we have the potential to help many others. I want to thank you and will now hand over the rest of our presentation to our two NICU dietitians, Gina and Alexa. Thank you, Christine. I'm Gina Signorelli, one of the dietitians in the NICU. Implementation of nutrition support practices by dietitians in NICUs has shown to improve nutrient intake, growth, and clinical outcomes, reduce length of stay, and improve safety. We have many tasks, but when discussing donor milk, we can obtain assent, educate parents on donor milk, stress the importance of mother's own milk, alert the lactation consultants on the floor in regards to the volume of donor milk being used, and education on maternal diet. We've had a high success rate of breast milk for a while. In 2012, 95% NICU infants, all gestational age and weights, mothers chose to provide some kind of breast milk, some amount of breast milk. We started early discussion around 2013 about donor milk, and we introduced in 2015. We started with very low infants. We expanded post-NICU, post-GI complications, any feeding intolerance. We continued it for a month, and once they were over 32 weeks. Initially, only the MD, the APN, or the PA could obtain assent or decline, and then it went to the lactation consultants as well as the dietitians. In 2017, we expanded to include a 7-day duration of use for babies born with a birth weight of 1,500 to 2,000 grams. And then in 2021, we expanded to include all babies less than 34 weeks, or any baby that was over 34 weeks with growth restriction as a bridge for 7 days until maternal supply could be established. We also stopped weaning off donor milk for all infants. In 2022, again, we expanded to include all infants to be used until 34 weeks corrected gestational age, or for up to 7 days of over 34 weeks. And now in 2023, we're very excited that it expanded to mother baby unit and everybody is offered donor milk. We obtain assent versus consent as donor milk is a standard of care. If declined after another discussion with the physician, the mother or parent signs the decline form. Our high acceptance rate is due to our multidisciplinary approach. Donor milk is being addressed by a neonatologist and OBGYN prenatally. It's being addressed by the nurses on labor and delivery. It's being addressed upon admission by any member of the team once in the NICU. In 2023, we had 100% assent rate for infants less than 30 weeks. We had about 59 babies, and we only had 2 that initially declined, and we went back and did some further education, and that's how we ended up getting 100% rate. Human milk is preferred nutrition for all preterm infants, and there has been no history of a donor milk recall. The AAP, ESPGHAN, the WHO, the US Surgeon General all have statements on the recommendations for preterm infants on the use of donor milk when mother's own milk is unavailable for the very low birth weight population. Donor milk has been associated with reduction of time to full feeds, reduction of parenteral nutrition, reduction of neck, and possible effect of ROP incidence.
Donor milk is not equal to mother's milk, and mother's milk is far superior. So it's important to continue to support a mother's breast milk journey. I'm in the middle of it. I have a 7-month-old. I'm also pumping, so it is very draining, and it's very important to encourage all mothers. Even when we just see them in the hall and they bring milk, we always say, "Good job, mama. Good job. You're doing great." Even that little bit of support, you definitely changes things for a mom. Donor milk still has advantages over formula as far as immune function and keeping the oligosaccharide content intact. There are no guidelines for the number of donors used per pool for nonprofit milk banks. Generally, 1 to 10 donors can be pooled at one time. Donor milk tends to be during the later stages of lactation and mothers who have an oversupply. Other factors can include maternal diet, lactation containers, time of collection of the pump. Did the mother complete the pumping session? Sometimes we have moms that have an oversupply and they'll just stop at 10 to 15 minutes and it never was complete. So that will affect the fat content. At any point with pumping, collecting, and storing can cause fat loss. There are limited studies available on donor milk, especially with long-term outcomes. Freezing can also affect the components of human milk, which donors are told to freeze their milk to donate and ship to the milk bank, which potentially decreases in macronutrient content before pasteurization has even begun. The effects of pasteurization, well, higher heat and longer processing time, which leads to greater composition changes. Most nutrients remain relatively stable. However, enzymes, anti-inflammatory cytokines, it reduces immunoglobulins, lactoferrin, insulin, caloric composition, fat composition, and micronutrients like vitamin C and vitamin B6. There are so many factors that affect human milk composition, and it's difficult to generalize donor milk's nutritional composition. There are also different reference values for donor milk, depending on which article you were referencing. For example, one article with 295 samples reported that the range of calories were 10.8 to 27.5 calories per ounce. Generally, we estimate the average donor milk to be anywhere between 15 and 19 calories per ounce and 0.8 to 0.9 grams of protein per deciliter. The milk study, which Alexa will review, used 0.8 to 0.9 grams of protein. We do not have a milk analyzer. Many banks do not routinely analyze the milk before or after pasteurization. Some milk banks do analyze all their donor milk, and calorie protein content will be shown on the label, but it is not required. However, the macronutrient analysis can still be different than what is actually listed on the label. A study from 2020 did show that 90% of donor milk samples were within 20% of the labeled 24 calorie per ounce. Donor milk composition, protein content is strongly correlated by preterm birth and steadily decreases throughout the lactation stage. Donor milk is associated with late lactation stage, so less concentrated even before pasteurization. Preterm milk has almost double the amount of protein. Protein content also of term milk decreases over time and plateaus at about 1 gram per deciliter around 6 to 8 weeks after birth, which mirrors donor milk. Limitations to donor milk. We know we must intervene early with infants, primarily whom are receiving donor milk, to maximize weight gain and delivery of macro and micronutrients. It's associated with slower weight gain and linear growth when compared to formula. The availability and shortages. As dietitians, we review all infants and then prioritize with the medical team during times of shortages. At our hospital, we've had minimal shortages with donor milk, with the exception to kosher donor milk. With cost, we try to minimize waste, and you can see standard milk is about $4.60 an ounce, whereas the higher calorie milk is more expensive, ranging from $5 to $6 an ounce. Now Alexa is going to take over and briefly review some recent literature. This study, published in 2023, analyzed commercial donor human milk. It includes donor milk of varied pasteurization methods, including high temperature short time, Folger pasteurization, and sterile shelf-stable donor milk. It also compared the donor milk composition to that of early preterm and mature preterm milk, with early preterm milk being defined at day 7 and mature day 28. In this analysis, they found there were minimal differences in calories between the 3 types of milk. The calorie content of donor milk fluctuates greatly, as Gina mentioned, anywhere between 15 to over 20 calories per ounce, depending on the resource, as well as the individual mother's milk calorie fluctuations. But the average calorie concentration remained similar between all 3 groups. Carbohydrate content also was similar between all 3 groups. And interestingly, fat content was significantly higher in donor human milk when compared to early preterm milk, but there was no difference between mature and donor human milk. We know the fat content of milk fluctuates greatly throughout the day, as well as throughout the stages of lactation. This preterm milk from this study was analyzed from a small sample of a 24-hour batch. It's also important to note that the type of pasteurization does impact fat loss. Protein, as Gina discussed, is well known to be significantly lower in donor milk when compared to early and mature preterm milk. Sodium chloride and zinc content were found to be significantly lower in donor human milk when compared to either early or mature preterm. Zinc concentrations in human milk are highly variable from mother to mother and have been shown to decline significantly throughout the stages of lactation. Preterm infants have high zinc requirements at 2 to 3 milligrams per kilogram per day, as zinc is mostly accumulated after 24 weeks and into the 3rd trimester. It plays a very important role in growth and potentially in neurodevelopment. Often preterm milk does not even meet the needs of these extremely preterm infants, highlighting the importance for fortification. Human milk in general does not have high amounts of calcium or phosphorus, again highlighting the importance of fortification. In general, we know that breast milk is dynamic, and preterm breast milk is optimized to best meet the needs of the preterm infant. There are limited articles available with original data. Until 2019, only 27 reports on human milk composition were published, only 9 of those being in the United States. Of those, there's a huge underrepresentation of minority mothers, and no data available on those delivered less than 28 weeks. The study published in 2019 that was referenced in the previous article I discussed was the first to include mothers that gave birth less than 28 weeks and had information about race. All this is to say that donor milk should not be used and considered to be an equal substitute for maternal milk. Ideally, donor milk should be used as a bridge to mother's own milk, as Chris and Gina mentioned. When exclusive or majority donor milk is being used, special attention must be paid to replace those nutrients that are lacking in donor milk. We've talked a lot about donor milk versus preterm milk, so I want to briefly go over this study that was published this year about donor milk versus preterm formula. We know that maternal milk is associated with better neurodevelopmental outcomes based on mostly observational studies. Donor milk is widely recommended as the standard of care for our small baby population. We have very limited information on the effects on neurodevelopmental outcomes. This study was published this past January and is the only study that looks directly at the outcomes of infants fed majority donor milk versus preterm formula with minimal, if any, maternal milk intake. There was no clinically significant difference in developmental outcomes between the 2 groups. They looked at several secondary outcomes, and the only significant outcome was the lower incidence rate of necrotizing enterocolitis in the donor milk group. So this study reinforces what we already know, that donor milk continues to be the best practice, especially when used appropriately. So now we're going to talk about our intervention and how we monitor these babies in our unit. All this data corroborates that exclusive and unfortified donor milk, as well as preterm breast milk, is unable to meet the requirements of a preterm and extremely low birth weight infant. Human milk fortifier is designed to augment preterm mother's own milk, and it is not designed to replace donor milk deficits. In our unit, we use bovine liquid HMF as opposed to a purely human milk diet. For those on exclusively receiving donor milk, we almost always go to 26 calories, and we very closely monitor these kids to figure out when the best time to do this is. Maternal breast milk on average has 2 times as much sodium as donor milk. So an HMF fortified donor milk likely will still provide inadequate amount of sodium. We have unit guidelines for assessing sodium needs and supplementation appropriately. We also have been using zinc more regularly in our unit. We have the option to purchase higher calorie donor milk. And we reserve this for infants receiving exclusive donor milk, but that we've already optimized their fortification and with persistent growth failure. We have the option to purchase preterm pasteurized donor milk. We don't do it often, but we always have that in our back pocket. And at 34 weeks correct gestational age, we transition from donor milk to formula. We no longer wean these kids. We reserve that for kids that have significant intolerance issues or a GI history that we are concerned they won't tolerate the formula. So as Dr. Planer touched on in his presentation, we have many unit-based guidelines we follow to ensure that every small baby is consistently receiving the same level of care. We have weight-based feeding advancement guidelines, and we have fortification guidelines. We've recently switched from a stepwise fortification approach from going from 22 calories to 24 calories. And now we've been going right to 24 calories at 80 milliliters per kilogram of enteral feeds, which is going pretty well for us. We also have sodium guidelines, vitamin D guidelines, and iron guidelines. Lastly, I just want to touch on our involvement in discharge planning. We very rarely send kids home on liquid HMF. We do have the option to, but we haven't found it necessary. We also very rarely discharge kids on donor milk. Occasionally, we do have parents inquire about purchasing it, and in that case, we do provide them with information on where to purchase it, how to go about it, and all of that. We recently added a nutrition section of the discharge note. This is mainly used to provide the pediatricians with a brief summary of the infant's nutrition and growth history, as well as our current recommendations and where we anticipate the kid's nutritional and growth needs to be in the near future. We are also involved in the high-risk NICU follow-up clinic. We work closely with the practitioners that reach out to us with any concerns. We are able to go directly to the clinic and assess the patient that day, or we're able to reach out to parents and provide recommendations and follow up that way, which has been going pretty well for us so far.
Good afternoon. I'm happy to be here to discuss positive feeding practices for our smallest baby cohort. We prioritize early preparation for oral feeding. The pharyngeal swallow was one of the first early oral motor responses emerging between the 10th and 11th weeks of gestation. The true suckling emerges between the 18th and 24th weeks of gestation, so our micropreemies are typically capable of engaging in reflexive non-nutritive pacifier sucking following birth. Early and initial oral stimulation of suck and swallow for us includes colostrum mouth care provided by nursing and frequent opportunities to engage in non-nutritive pacifier sucking. The pacifiers that you see on the side of your slide are, the top one is the wee thumbie, the smallest pacifier, and the other is a soothing pacifier, which is your typical premature pacifier. The nurses will look at the oral configuration, the size of the oral cavity, and make a good choice that fits comfortably in the infant's mouth. Engaging in non-nutritive sucking promotes strengthening of the jaw, the tongue, and the core components of the oral suck, which include the tongue rising up against the palate to compress and shaping of the lingual seal around the pacifier to create a channel that will eventually focus on channeling liquid backward.
The reduced respiratory burden when compared to nutritive sucking allows us to start so early with non-nutritive sucking. How do we determine oral feeding readiness? Well, it's generally documented that infants are able and ready to begin nutritive sucking trials between 33 and 34 weeks gestation. Our small baby cohort of infants that are born less than 30 weeks can frequently be expected to start later and transition slower to oral feeding. They begin with very immature skills with regard to organizing suck, swallow, breathe coordination, and the expectation for their volume intake, the length of active participation while feeding, and the frequency of oral feeding attempts need to be adjusted. In our NICU, all babies born less than 30 weeks are evaluated by a speech-language pathologist either immediately prior to or shortly after initiation of oral feeding. Our small baby cohort includes a population of infants with a variety of challenges that impact oral feeding. There are multiple factors that determine an individual infant's readiness to begin oral feeding. They include the ability to achieve and sustain adequate arousal, development of functional oral motor skill, the strength and integration of the core components of the oral suck, their respiratory status. They need to have the ability to safely coordinate suck swallow with breathing. Their cardiac status. They need to have the adequate endurance and stamina for the work of feeding. Their neurologic status. We need to look at children who are neurologically immature versus neurologically impaired. And we need to look at gastric motility. Many of our small babies have had histories of feeding intolerance, and many of their feeding protocols include extended nasogastric feeds. We need to look at getting them ready and compressing because normal gastric accommodation for bolus feeds is most compatible with oral feeding. In our NICU and in our practice, we found that volume-driven oral feeding does not produce the most positive feeding outcomes. Our NICU culture prioritizes several things. We want to determine PO feeding readiness at any given feeding based upon assessment of infants' behaviors, their readiness cues that we'll talk about in a moment. We want to use supportive oral feeding methods. We want to prioritize PO feeding quality over their quantity. And at all costs, we want to avoid infant stress during their oral feeding. The acceptance of each infant's individualized trajectory and rate of progress is something that we want to look at. And we want to encourage early and often parent education and participation. As we found, this produces oral feeding outcomes that are optimal for each infant. And in a pilot study found it also decreased overall length of stay for our small preemies and reduces hospital costs. So what are feeding readiness and stress cues? Well, when infants are awake and alert at their baseline, they're ready to go. What we look at is does the infant independently arouse for feeding in response to internal hunger cues? Or are they easily arousable by the caregiver? Now, is the infant able to sustain that arousal? If the caregiver is arousing the infant during pre-feeding care and the infant then goes right back to sleep, they're not ready. We're looking at oxygen saturation and respiratory rate. Is it within acceptable parameters at rest? Is the infant observed to be actively rooting? Their mouth is open and turning to any stimulus that's near and brushing their mouths. When do we have to stop? There are behavioral and autonomic stress cues that we need to note. There's a reduction in the strength or the loss of the oral seal. That's noted in an increase in oral spillage. Outstretched arms with accompanying finger splay, fingers widely splayed apart, facial grimacing are notices to stop. Arching and our active withdrawal away from the bottom nipple. Behavioral shutdown. The infant presents with eyes closed and apparently transitions to sleep. You stop the feeding and all of a sudden their eyes pop open and they're looking at you.
They're not really sleeping. They're telling you they just can't do this anymore. Any significant change in respiratory rate, either elevation by tachypnea or shallow breathing that's associated with the fatigue towards the end of a feeding. Any negative impact on oxygen saturation or heart rate. If we are very careful to look at those signs, we can stop the one at the bottom of your slide, which is occurrence of incoordination marked by cough. Our babies are typically, the majority of them are silent aspirators. When we get a cough, it's because there's been a significant laryngeal penetration. So how do we individualize feeding management planning? Well, we look at feeding position. For our small baby cohort, the default position in our NICU is elevated sideline. The infant is lying on the side, facing the feeder, with their head and neck raised a little higher than the hips and flexed slightly forward, like the position you see the doll in on the side of your slide. This provides maximum body surface support and midline stability. It allows for maximal diaphragmatic excursion and optimal respiratory support for the work of breathing during feeding. Eliminates gravity-enhanced backward liquid flow that you can see with a semi-reclined position, and it reduces any abdominal pressure that can precipitate occurrences of reflux. We look at oxygen support. We want to consider the need to possibly increase oxygen support above current resting levels for infants with chronic lung disease. That will more optimally support the elevated work of breathing during feeding. Some infants may continue to require oxygen support during oral feedings, even after they become stable on room air at rest. It's also important to balance energy expended during oral feeding with growth. We need to consider the need to limit the daily number of oral feeding opportunities or limit the length of each oral feeding during the early stages. It's not going to be helpful to our infants for them to be oral feeding but not growing. So bottle, nipple, and nipple selection. This is a hot topic. Commercial bottle nipple systems versus disposable nursery nipples. In our NICU, we use air-vented bottles to help reduce the volume of the air that's swallowed during nutritive sucking. Our smallest preemies usually have weak oral and tongue seals. During suction, they pull in air from outside of the bottle. Reducing the air that's inside the bottle helps reduce the total air swallowed during suck, swallow, breathe. Commercial bottles, many of them, have a dripless feature. Our infants usually take short cycles of sucking and long and sometimes extended respiratory recovery intervals. When the airway is open, disposable nursery nipples tend to drip. A dripless feature will allow the infant to continue to breathe safely for as long as they need to reoxygenate and support the next cycle of sucking, without having anything penetrate into the laryngeal vestibule. Bottle nipples made from commercial-grade silicone material provide a more consistent flow rate as compared to disposable nipples that also typically have a higher variability in rate of flow. Less flexible nipples provide increased resistance and sensory input to the midline of the tongue for strengthening the lingual seal that we talked about. So identification of a compatible nipple shape and flow. We evaluate the nipple shape and the length as compared to each infant's oral structure and demonstrated oral motor skills. We're looking, majority of our infants take standard tapered nipples. There are wider orthodontic shaped nipples, and some the children need compensatory specialty bottles that will support their weak strength of suck. We always choose the slowest flow nipple that matches an individual infant's strength of oral suck for optimal ease and consistency of liquid expression. We need to educate our parents and the staff about nipple flow rate. There is no industry standard, so it can be incredibly confusing. Slow flow is not always slow, and one nipple company's slow flow versus another versus a formula company's slow flow isn't always the same. Why do we slow the flow? Well, reduced flow limits the size of each liquid expression. Flow can differ if you're feeding express breast milk versus formula through a bottle nipple. Formula is slightly thicker than breast milk just on baseline viscosity. And while it may look no different to the eye versus water and milk, going through a small nipple, going through a hole in a nipple can be very, very different. So I do sometimes use different flow rates if we're feeding express breast milk versus formula. Slow flow nipple improves oral containment, control, and backward channeling of liquid. It enhances assumption and maintenance of suck, swallow, breathe coordination and encourages sustained nutritive sucking persistence. So one of our major challenges in our small baby cohort is the impact of chronic lung disease on their feeding performance. Continuous nutritive sucking affects the respiratory rate, and the respiratory rate impacts the ability to coordinate nutritive sucking, their suck swallow with breathing. For children with moderate to severe and chronic lung disease with tachypnea, this often delays their ability to initiate oral feeding. A respiratory rate typically increases during oral feeding. So initiating oral feeding at a respiratory rate of over 65 to 70 is not recommended, since the steady respiratory rate of 77 or higher is indicative of a criterion for terminating oral feeding. When an infant cannot meet the respiratory demands of feeding, they become at risk for volume, which is associated with an inefficient nutritive sucking pattern. When I say inefficient, I'm talking about reduced length of active sucking versus long extended length of respiratory recovering breathing intervals. They become also at risk for incoordination of suck, swallow, breathe with laryngeal penetration and recurrent episodes of oxygen desaturation with and without bradycardia. Laryngeal penetration can often occur with airway protection reflex and cyanosis. Laryngeal penetration can often have an aspiration as a result. So, looking at oral feeding while on high flow and CPAP. With some of our babies, there's a continual reliance upon higher level of respiratory support over longer periods of time. This indicates an increased severity of chronic lung disease. The higher the pressure of CPAP or the liters per minute of high flow with elevated O2 support are incompatible with safe and successful oral feeding. Continuous nutritive sucking is dependent upon the power of respiration and the coordination with respiration. Unfortunately, there is limited evidence-based research regarding the safety and efficacy of feeding our small babies while maintained on CPAP and high flow. We know that respiratory distress and disease makes oral feeding harder for these infants. We also know the majority of aspirations within this population are silent and frequently unmarked by clinical evidence, a cough or desaturation. I've often taken some of these infants into the radiology suite and done modified barium swallow studies, and we can formally see that they're aspirating, and the monitors say that they're fine and they're not coughing at all. So when infants have significant respiratory support needs, we need to talk about what makes feeding a priority. In a retrospective analysis, Dumpa et al. In 2020 compared two groups of preterm infants at less than 32 or equal to 32 weeks gestation. One started PO feeding while still supported on CPAP, and one delayed initiation of oral feeding. The study found no significant difference in the age at which full feeding was achieved between groups. Oral aversion, which everyone is always afraid will happen if we delay the critical onset of feeding, was not found to be associated with delayed initiation of oral feeding. The author hypothesized that the fact that both groups reached full oral feeding at the same age may suggest that the suck-swallow maturation at a specific age is a more important determining factor for successful oral feeding than the introduction of oral feeding at an early age. So in our NICU, when infants are approaching term at a minimum of 37 to 38 weeks, and they're not actively in the process of weaning respiratory support and not expected to be ready for transition to regular nasal cannula in the near future, they are considered for possible candidacy to begin oral feeding while continuing to receive that elevated respiratory support. Decision-making with respect to initiating oral feeding while an infant is supported on CPAP or high flow includes a couple of things. We review the infant's overall medical complexity, their severity of respiratory illness, their aspiration risk, and current level of respiratory support. I use the risk assessment for feeding on high-flow nasal cannula that was proposed by Wolf and Glass in 2014. We do this in combination with a thorough clinical assessment by a speech-language pathologist. In combination with both, we make a determination of whether this child is a candidate or not. Cautious initiation of limited oral feeds with a default to a slower flow nipple is based upon those results. Formal documentation of oral pharyngeal swallow competency by doing a modified bearing swallow study is considered, especially when we are looking at longer term of feeding on these methods. So clinical growth and research opportunities. In our NICU, we're looking at some future directions for our clinical growth. One of them is adding fiber optic endoscopic evaluation of swallowing fees into our toolbox. This is applicable in some cases when a formal modified barium swallow may not be needed, and it limits an infant's radiation exposure. It also provides the ability to evaluate swallow competency during breastfeeding. We want to encourage our parents to engage in breastfeeding, and oftentimes they're more comfortable with bottle feeding because we can see a result. And they're also, with our more fragile preemies, they're afraid that breastfeeding, we can't measure the flow. So this would help us to do this and encourage and increase our breastfeeding amounts. Future directions for research in all NICUs is to look at the fact that we need more evidence-based research with respect to feeding our small baby preemies while they're maintained on CPAP and high flow. We know there are dynamic and variable pressure changes during breathing that are produced in the upper and lower airway, but we don't know how this impacts liquid bolus flow, alters swallowing physiology, airway protection, and laryngeal sensation, and is there a safe level of support? Work of breathing and respiratory rate are typically decreased when we support children on these methods. Can this possibly enhance timing and coordination of suck, swallow, breathe? We don't know. Functional respiratory lung capacity is increased when the infant is supported on these methods. Would infants be better able to manage respiratory suppression during recurrent swallowing? We don't know. Another way to evaluate is pharyngeal manometry with impedance. This is used in adults, but not really typically used for infants yet. But measures of pharyngeal and upper esophageal sphincter pressures integrated with liquid bolus transit may provide us with insight and guidance regarding offering our young infants PO while supported on CPAP and high flow. The positive impact of time and maturation on feeding performance. I so often hear people talk about that infants have to learn to feed. Oral sucking elicited during infancy is not a learned activity. Reactivity of the early oral suck is reflex bound when there is absence of any significant neurologic deficit or complications. An infant's ability to discriminate non-nutritive pacifier sucking from nutritive sucking, requiring immediate adjustment of the sucking pattern when liquid is expressed to accomplish and maintain suck, swallow, breathe coordination, benefits from neurologic maturation with advancing gestational age. Time and growth also positively impact other ideas of when children are ready. Independent and sustained arousal, increased strength and effectiveness of the nutritive suck, increased efficiency of the nutritive sucking pattern. Infants with better lung capacity have longer cycles of active sucking that support adequate volume consumption within an acceptable time interval of 20 to 30 minutes. Recognition and response to internal hunger and satiation cues. These drive nutritive sucking persistence and support transition to ad-lib feedings. Our NICU has had a good history of success transitioning infants to oral feeding, starting at later gestational age, when the oral feeding delay is related to chronic lung disease and respiratory status, absent any significant neurologic complication or deficit. Many of these children have started post-term age, and they take to feeding like a duck takes to water. It's important for us to have family participation at the bedside. Long hospitalizations alter the normal infant-parent bonding and infant caregiving experience. Initiating oral feeding is a milestone event in the life of a premature infant and their parents. It's approached with excitement and fear. It's important to encourage early and consistent parental participation during oral feedings to build competence, confidence, and recognition of infants' behavioral cues. This will help to alleviate that anxiety and fear. Competence is the consistent implementation of therapeutic positioning, infants' individualized therapeutic feeding needs and strategies that are applicable for both bottle and breastfeeds, and knowledge of the criteria for selection of bottle nipple flow. Confidence, which is the relief of parent anxiety, is the goal. The goal is that the parent becomes the expert in feeding their baby. In order to do that, they need recognition of the infant's behavioral cues. They need to notice and note changes in their infant's behavior that provide communications during feeding. I'm ready to start. I need a break. I have to rest. I have to burp. I'm showing stress and I need to stop. Active encouragements of opportunities to provide breastfeeding with the guidance and support of our lactation specialists in combination with bottle feedings are seen as integral during the early transition to oral feeding. Transitioning to home. Although long awaited and welcome, discharge can often be a stress-inducing time for parents. With respect to feeding, we work collaboratively with our nursing colleagues. Our discharge goal for each infant is that they're able to successfully participate during oral feedings that optimally support their individual nutritional needs, and that each parent is knowledgeable with respect to all their therapeutic needs that are appropriate for their baby, has demonstrated competence and confidence during feeding that's provided at the bedside. Research acknowledges that our small baby cohort, who often present with persisting chronic lung disease and other medical comorbidities, are most at risk for persisting feeding difficulties. Monitoring of an infant's progress across all areas of development, provided at intervals, is offered to all small baby graduates as part of our NICU follow-up program. Transition to outpatient services is available when indicated as necessary to address longer-term oral feeding skill development and attainment of future age-expected oral feeding transitions. That includes going from puree spoon feeding all the way up to diet of varied table foods and weaning from breast and bottle to cup and straw drinking. Sometimes babies are ready for home, but are not yet ready for full PO. I'd like to share Reagan's story. Reagan arrived following a premature labor at 23 weeks and 5 days in early February 2022. She was small at 680 grams, and her APGARs were low at 1 at 1 minute and 2 at 5 minutes. Our respiratory course started with a short interval on high-frequency oscillator, followed by a month on SIMV, wean to NIV CPAP, nasal CPAP, high-flow nasal cannula, and regular nasal cannula, and eventual transition to room air 16 days prior to discharge. An additional array of medical issues typical of small baby preemies resolved over time. This clinician first met Reagan at 35 weeks and 6 days. She had recently started bottle feeding following transition to a regular nasal cannula. PO feeding was supported by elevated sideline position, an increase in oxygen support over current resting level during feedings, and the use of a Dr. Brown bottle with slowest flow ultra preemie nipple. The evaluation noted independent management of suck swallow breathe coordination with short cycles of active sucking, only 2 to 3 suck swallows per cycle, bordered by respiratory recovery breathing intervals that were frequently extended in length and limited in endurance for the work of feeding. 15 minutes of active participation was her personal best. Initial average daily oral feeding volume was 22% of the current total nutritional volume over a 24-hour period. The inefficient pattern of nutritive sucking, which is the reduced length of active sucking versus extended length of respiratory recovery, not the slower flow nipple, was identified as the primary factor impacting volume intake. Reagan's parents actively participated in Reagan's care and feeding, and mother was present in the NICU every day. Her oral feedings remained significantly challenged by reduced endurance with rapid early onset of respiratory muscular fatigue, despite the need and benefit from continued oxygen support. Over the course of 6.5 weeks, maturation allowed for one-step advance of nipple flow. An inverse ratio of less active work, short sucking cycles now averaging 3 suck swallows per cycle, in relation to length and frequency of resting recovery breathing intervals continued to compromise nutritive sucking efficiency and her ability to complete volume intake. Continued to chase a moving target of increasing volume needs with growth. Oral feeding consumption never exceeded 50% of her total nutritional needs. And a little over 42 weeks, her neonatologist and I met with her parents to discuss the current situation. It had become clear that Reagan was doing her best, but was expected to require some level of alternative nutritional support over an extended interval to allow for additional lung growth. Replacing her current nasogastric tube with a gastrostomy tube was proposed to support transition to home. Tears flowed, tissues were offered, and many questions were answered. Reagan's parents ultimately made the difficult decision to agree to surgery. A gastrostomy tube was successfully placed, and Reagan was discharged to home in July of 2022, just 2 days short of 5 months. And here's our NICU graduate. Reagan's story transitioned to home. At home, a bolus feeding schedule was followed to maintain a typical hunger satiation cycle. Parents continued to provide oral and gastrostomy feedings during most daytime feedings and woke nightly to provide an overnight feeding, mostly via gastrostomy. We wanted to maintain that bolus feeding schedule because that is most compatible with oral feeding and maintenance of a typical hunger satiation cycle. Reagan continued to receive HOMO-2 support during PO feedings only until she was ultimately weaned from that as well. Parents were counseled to limit the length of the oral feeding portion of each feeding based upon infant's ability and level of engagement, and to avoid focus upon volume and persisting past her endurance. Reagan was transitioned to outpatient therapeutic feeding intervention. Her parents were supported by family members, and all who participated in providing Reagan's feeding became masters of patience and restraint. In the absence of pressure to force volume intake, willing engagement during bottle feedings and oral feeding participation was maintained. Development of oral motor skills and diet progression was supported by clinical guidance provided during outpatient feeding therapy sessions. Therapy sessions were provided at intervals that most often coincided with critical ages for introducing oral feeding transitions. All oral feeding transitions were introduced at the appropriate adjusted age to correct for prematurity. At 6 months corrected age, Reagan continued to consume 50 to 60% of her daily 30 ounces of formula during bottle feedings and successfully started accepting puree spoon feedings. At 8 months corrected, a structured feeding schedule was introduced that included 3 daily meals provided prior to offer of bottle feedings. Following introduction of the structured feeding schedule, a variety of puree semi-solids consisting of representation across all food groups increased from a prior 1 ounce to portions of 4 ounces or more at each meal. We obtained guidance from a dietitian, which helped us to adjust formula intake to balance with gradually increasing food consumption. A small decrease in volume needs per bottle feeding supported consistent completion of the bottles. At 10 months corrected, Reagan began supporting herself solely via oral feedings. Transition was made from smooth puree to fork mashable solids, an addition of easily dissolvable teething cookies, crackers, puffs, and other snack food items. At 14 months corrected, we moved on to successfully introducing a variety of soft chewable table solids and introduced cup drinking. At 19 months in September of 2023, her gastrostomy tube was removed, and at 20 months in October of 2023, Reagan was officially discharged from therapeutic feeding intervention. Reagan is now a thriving 2-year-old. There are 5 important takeaways that I want to leave you with. Fostering positive feeding outcomes requires an adherence to baby-led feeding practices. When and how we offer feeding opportunities determines our outcomes. When we're not awake and not rooting, we are not ready for oral feeding. A NICU culture that emphasizes quality over quantity at each feeding is optimal. Don't be afraid of slower flow nipples. It is more often the efficiency of the sucking pattern and not the nipple flow that determines volume consumption. Consistency in carryover of therapeutic feeding strategies and establishment of good quality feeding skill supports optimal volume intake, both in the NICU. Coordination between the multiple caregivers in our NICU, multiple nurses and parents, is so important in the consistent carryover of therapeutic feeding strategies. The carryover of therapeutic feeding strategies also follows the transition to home. Prioritize early parent engagement and participation. Parents need to be supported to develop competence, confidence, and become the expert in feeding their baby. Time, maturation, and growth is so important. Slow and steady often wins the race, and patience is truly a virtue when it comes to feeding our small babies. We have to acknowledge that not all of our small babies follow the same path. Sometimes the path to oral feeding is a marathon and not a sprint, but we can still make it successfully across the finish line. I've included some resources that I've used in my practice and that I've used within this presentation that I thought would be helpful for you to look at and to share with your speech language pathologists. And I want to thank you.
Thank you. We'll resume our program at 1:40. Take a few minutes to stretch.
A warm welcome to all of you that are joining us today. My name is Judy Senecola. I'm the chair of our family-centered care team here in the NICU. I would like to begin by sharing a definition of family-centered care taken from the Institute for Patient and Family-Centered Care. It is an approach to the planning, delivery, and evaluation of health care that is grounded in mutually beneficial partnerships among healthcare professionals, patients, and families. In patient and family-centered care, patients and families define their family and determine how they will participate in care and decision-making. Core principles include treating everyone with dignity and respect, communication of all information so families can make informed decisions, encouraging participation of families, and making the family part of your team. Now I will turn the microphone over to Dr. Island.
Thank you, Judy. I'm Lisa Island. I'm the current Division Chief of Neonatology, and I'm also the AAP District 2 Diversity, Equity, and Inclusion Champion. And today I'll be talking to you about equity. So a good starting point is to really start in defining equity. And we can understand equity by understanding inequality. So here you see two fruit gatherers. And based on this illustration, it's not easy to predict which of the gatherers will receive the most fruit. Equality. Equality would be giving the fruit gatherers the same tools. And in this case, they're given a ladder. It is still not it's not hard to predict which of the gatherers will get the most fruit. Equity. Here, we notice that the fruit gatherers do not need the same tools to gather equal amounts of fruits, but that the tools needed are different. But still, in looking at this cartoon, you can predict that one of the fruit gatherers will still get more fruit than the other. And that brings us to the concept of justice. And justice is changing the tree. Fruit gatherers can use the same tools, but the conditions under which they are gathering fruits have been changed so that they have equal access and opportunity to gather fruit. So what is meant by health equity? Health equity can be defined as a state in which everyone has a fair and just opportunity to obtain their highest level of health. In a word, it's the elimination of health disparity. And I would be remiss in talking about equity without mentioning the Reverend Dr. Martin Luther King Jr., who says, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So what are some of the contributors to disparity in healthcare? What are the contributors to disparity in the NICU? And you can see that we have three main areas that can be looked at in terms of contributors to disparity. There's care team interpersonal biases, care process biases, and structural racism. So let's start with care team interpersonal biases. And you can see here, there are a myriad factors that can contribute to bias. It can be based on income, geographic region, sexual orientation, mental characteristics, education, gender, race, political preference, physical characteristics, to name a few. And how do these interpersonal biases show up? I'd like to introduce you to the Harvard Implicit Association test. And this is to say that our healthcare workers do not come into work and say, I'm going to discriminate against someone today. But a lot of what transpires is related to implicit biases. Some of you may be familiar with this test, where the test taker is shown a series of faces of Black individuals and the faces of white individuals. This is paired with looking at words, a dichotomy of words that can be easily characterized. The good words are things like joy, love, wonderful, laughter, happy, and the bad words are terrible, horrible, evil, etc. And basically this test, through an individual's pairing, a sorting of words with the faces, can detect implicit bias. One of my colleagues, Tiffany Johnson, a pediatric emergency medicine physician at the Children's Hospital of Philadelphia, was very interested. We'd known that implicit bias occurred in adults, but did it happen in children? Would people be biased against children based on the color of their skin? And so she administered the implicit association test to pediatric residents in her program. And here's what she found. She actually found that among the residents that there was a strong pro-white bias that was seen in people who were charged with taking care of children. And so here is a study by a colleague, a neonatologist, Karen Hendrick Munoz, who looked at kangaroo care. You've heard throughout the day the importance of the skin-to-skin care in our population of infants. And so in looking at this slide, we can see that even though this was a query of nurses and mothers in the NICU, the mothers are represented by the gray bars and the nurses by the black bars. And what you can see here is that the mothers and the nurses agree that skin-to-skin care is beneficial for infants. They may not agree on how long infants should be allowed to do skin-to-skin care or when it should be introduced, but they certainly did agree that it was something that was beneficial for infants. So let's take a look at their perception of the implementation of skin-to-skin care in the NICU. So the one thing that you can see here is that, first of all, to orient you, we're no longer looking at mothers and nurses, we're looking at non-white mothers represented by the gray bar and white mothers represented by the black bar. And what do we see here? So when asked whether or not nurses were supportive in helping them provide skin-to-skin care for the babies, we saw that significantly fewer non-white mothers thought that their nurses were supportive of them in doing kangaroo care. A second question that they were asked was whether or not skin-to-skin care was something that they were told that they could do for their baby. And again, we see a significant difference between the non-white mother and the white mother, and that non-white mothers thought they weren't told. Now, here's the part that I thought was sad. When asked whether or not they thought that skin-to-skin care was offered in the NICU, significantly more non-white mothers thought that it was offered. And when we take this into account with they thought it was offered, but it also seemed that they thought it wasn't being offered to them. What about care process biases? This has to do with things like preferred language, the day versus the night shift, and certainly gender roles can be parts of care process bias that we implement in the NICU. So in regard to preferred language other than English, I think most of you will be familiar with this setup. There are different vendors, but essentially we have in-person, we have tablet, or we even have some phone apps that help us communicate with families in a language that might be different than English. And one of the things that I think is funny is this one says, easily connect to an interpreter. And I think that most of us on this call today know that sometimes it's not so easy. First of all, it can be difficult to find the tablet. When you find it, is it charged? Are you able to get internet connectivity? And then once you have the interpreter on the phone, how do we assure that they're saying what we actually want them to say? What is the quality assurance when we're using this? And then certainly we know that the ability to connect to someone in a personal relationship as a provider with a parent is hindered by not being able to directly communicate with them. And why is this important? Well, in looking at the study by Khan et al. In a pediatric population, they looked at the incidence of adverse events in their hospital related to whether or not there was comfort with English. And what they found that there was a significant increase in adverse events in families where there was limited comfort with English. So that communication is very important. And here, this is a graphic from the WHO showing skin-to-skin care between a mother and her infant. And so for those of you who work in a NICU, we know there can be differences between the day and night. Just think about your NICU experience walking through the unit in the day. How often do you see skin-to-skin care occurring versus when you walk through at night? How often do you see breastfeeding occurring day versus night? How often do you see lactation support in your unit, the day versus the night? Care process bias. And then let's take a moment to consider gender roles. And first of all, I'd like to recognize that although we're showing a couple of a male and a female, that our families and parents today look varied and different and are diverse. But this is just one parenting dyad. So if I were to give you this quote of your job is to deliver the milk, I think many of us would know who the statement was meant for. Oftentimes, we're not comfortable. We don't know what to tell fathers to do. So we say, hey, you can deliver the milk for mom. And for parenting, that's not enough. We need to be more mindful in the roles that parents can take with babies. So I'm going to shift gears here and talk about structural racism in healthcare. And I will preface what I'm going to speak about with the statement and the knowledge that I could give a full day conference. Someone could give a semester-long course or a year-long course on structural racism in healthcare. But we're not going to do that because I have about 2 or 3 more minutes. So suffice it to say, let's define structural racism in healthcare is that it's a system that operates through laws and policies that allocate resources in ways that disempower and devalue members of racial and ethnic minoritized groups. So how does this happen? And so I don't have time to walk you through all of the legislation that has led to our current healthcare system, but suffice it to say that things starting back in the 1930s with the Hill-Burton Act and the National Fair Labor and Labor Act, as well as tax acts. The Civil Rights Act in 1964, the Medicaid-Medicare Act in 1960s, the Affordable Care Act more recently in 2010, have helped shape healthcare today. And so these things, these laws that have built our health systems determine where the hospitals are, what neighborhoods they end up in. Those laws also influence who is insured. They also influence who gets the care, and certainly who are the people providing the care is all influenced by the way that our healthcare system was structured. And so how can we contribute to equity? An important first step is recognizing what affects health equity in your community. These list of factors of language, education, race, ethnicity, sex, and gender identity. And we oftentimes call these as social determinants of health. I'm sharing this slide by one of our physicians at our healthcare system, Dr. Ogunadegbe, who used this during our health equity certification by the Joint Commission. And this is notable. 20% of a person's health and well-being is related to access to care and the physical environment, and these social determinants affect 80% of our health outcomes. So personal contributors to equity, become comfortable recognizing your biases. We're all biased. We're human. Be an upstander, helping your peers recognize their biases and helping them to implement equitable care. And know your data. Seek out equity. It's impossible to know where you need to implement change if you don't know your data. So here is an equity dashboard from the California Perinatal Quality Care Collaborative, and they are able to stratify based on race and ethnicity some of what we know is important in the NICU in terms of health outcome. Advocate as an individual within your institution and legislatively at the national and regional level. Go to your state capital and help build programs, laws, policies that benefit your patients. And with that, I'm going to pass the baton back to Judy, and she's going to help understand how family-centered care and equity are integrated to provide for our families.
Thank you, Dr. Island. So first, we're going to talk about barriers to equity. So when we say there are barriers to equity, what does that really look like? Barriers may relate to culture, socioeconomics, disabilities, or medical care. They all impact equitable treatment. With all these barriers, it really comes down to the fact that our families just want to be moms and dads. Out of 65 million parents in the US, more than 4 million parents currently have a disability. Combine that with 1 out of 33 infants born with a defect, and we can see the challenge more clearly. So where do we begin? Remember that we are strangers joining our families in the midst of their trauma. At admission, an assessment of the family is vital to providing care. It is important to build trust and to help them to be honest. Who are the parents and the guardians? You need to validate their preferred language for everyone. What are their resources and networks? How will we be contacting the family? What are current phone numbers? We need to educate our families to answer phone calls and allow for messages. Do they have other children? Do they have family or friends that are helping with their care? Do they have responsibilities such as caring for an older or disabled person? Do they have pets? Is someone caring for them? What is the family relationship? Is there abuse, violence, or illegal activity? Are parents able to be at the bedside? The baby may be transported from another facility, or the parents may have a contagious illness and not be able to come to the NICU. Remember that mom is recovering from delivery and parents are recovering from the trauma of the delivery and admission to the NICU, which is usually a sudden and unexpected event. At the first meeting with the medical team, we all need to remember to speak in simple terms, encourage questions, and give the family time to process. The social service team will identify any social determinants of health or needs. Does the family have a place to live? Is it adequate, especially if the baby will be coming home with equipment or special care at home? Do they have the food they need? Do they have insurance? Do they need to apply for insurance? And what help do they need to complete this application? Are there any cultural needs? Do they want someone from their religious community to come to the NICU to bless, to pray for, or to baptize their baby? Our child life specialists will assist with siblings. We have a sibling program, so brothers and sisters of the baby can come to the bedside and see the new baby of the family. But remember that siblings need support too. So that's where our child life specialist can help. Our bedside nurse performs an educational assessment. How does this family learn? What is their educational background, and are there learning disabilities? These things we may not discover right away at admission, but our assessment is always ongoing as we work with the family. Sorry, everyone. So how do we engage our resources and what is available to help our families? It is most important for parents and family to know that we are all there for them and their baby. Some of the resources that may be available would include, as we mentioned earlier, interpreters, culturally appropriate opportunities, mental and emotional support, both at the bedside from staff or professional resources that are available, free parking or valet service, lift rides, free meals, providing breast support with supplies, assisting with WIC applications if appropriate, supplies and support from local organizations, and information about insurance coverage that is available. Always remember to show compassion and caring, especially when answering family questions. Address any issues or needs immediately. Parents always need to feel comfortable and safe in your NICU. I have always felt that parenting is the most important job we can ever have, but it comes with the least amount of education. So we learned some very vital information recently from our families during a project last year, where we asked a panel of our graduate parents questions about their discharge experience. They shared 3 important areas that created confidence and competence during their NICU stay. The first was attending our NICU classes offered. The second was receiving bedside support from the nurse. And the third was being able to provide hands-on care to their baby before leaving the NICU. We recently had an example of how this worked. We had a baby that was born with an airway abnormality and required a trach and a gastrostomy tube. This was the first baby for a very young family. They made time to attend all our regular classes and the special classes to learn about all the equipment and their special needs. They were at the bedside every day and encouraged to provide hands-on care with the support of the baby's nurse. The baby was sent to a rehab facility for a short stay and then discharged to home. The parents expressed that this plan allowed them to become confident in providing all the care that their baby needed. We continuously learn from our families every day. It is important to provide encouragement, create hope, and be flexible with dates and times for training. Teaching needs to be practical and doable. You need to allow times for parents to talk about their anxieties and continue to adapt to their needs as you move through their educational experience. So when offering family education, there's a few things to keep in mind. This is a list of some of the things that we do for our families, but it is sometimes challenging to capture family attention. Always build an individual plan for each family. Teach patience and teach with patience. Plan realistic goals according to the time that they can give you. Consider their responsibilities at home. Consider their work schedules and how far they need to travel. And it is also important to follow up with the family after they go home to answer any questions that they might have. When preparing parents with disabilities, you need to adapt your education for each family. Demonstrate, practice, and use reinforcement. Don't underestimate what parents can do. Create educational needs such as pictures, checklists, and videos. Allow for failure. Be reassuring, but also learn to be honest. The goal is to create a safe environment at home. Start with basic needs such as diapering and bathing, then move on to creating a safe environment, and then address all nutritional needs, including feeding and medications. Determine if they need help or supervision. A few years ago, I was given the task of preparing a developmentally disabled couple to care for their premature baby. The educational plan began with simple lessons and hands-on practice with mannequins. The scenarios were created to test their critical thinking and decision-making skills. In the end, I had to recommend that continuous supervision was necessary for a safe environment. The important decisions we make every day are focused on providing a safe and smooth transition to discharge to a family that is confident and fully prepared. Thank you for your attention today, and I will now turn the mic over to Angeline Arizari, our March of Dimes Family Support Program Coordinator.
Thank you, Judy. So like Judy said, my name is Angeline. I am the March of Dimes NICU Family Support Program Coordinator. And my role is to implement the March of Dimes NICU Family Support Program, which has been in place for more than 20 years. Our program here in the hospital was established in 2021, and I'm a full-time hospital employee. And it is a result of a partnership between March of Dimes and our hospital. The program has three main goals: educate NICU families, educate NICU staff, and improve the NICU experience. What is unique about my role is that I am uniquely dedicated to the needs of the family and help support them during their NICU stay. We currently are in more than 70 hospitals across the country. Some sites might be currently present with us today, such as in New York. We have sites in Stony Brook University Hospital, New York Presbyterian Morgan Stanley Campus, New York Presbyterian Alexander Cohen Campus. We have one site in Connecticut, Yale University, and two in Pennsylvania, Geisinger Medical Center and Geisinger Wyoming Valley Campus. Currently, we are the only NICU family support site in New Jersey. Through the program, our staff is equipped with the most up-to-date evidence-based information concerning family-centered care to enhance the ability to support parents throughout their journey. By staying up to date on current research, our team not only enhances their expertise, but also cultivates a greater empathy when interacting with our patients and their family. Also, our staff has access to annual training sessions focusing on addressing their implicit bias and patient-centered communication skills. We believe that by addressing and fostering a culture of empathy and respect and inclusivity, we're creating a more welcoming and safe environment where our parents feel empowered and valued. Through ongoing training that we provide in workshops, we help to continuously improve our communication skills and challenge any unconscious biases that may impact the quality of care we are providing. So some of the ways that we are improving the NICU experience is through family feedback for quality assurance. So we achieve this by three main things. One of them is the Voice of the Patient panel, which you heard Judy speak about, that we've done last year. Having social events to help normalize the NICU experience, as well as developing a family staff advisory committee. These initiatives have really changed the atmosphere in our NICU by creating a more supportive and welcoming environment for both our babies and their families. The Voice of the Patient panel provides invaluable insight that really help us continuously improve our care to ensure that we're meeting the needs of our families in the best way possible. Our social events not only bring a sense of normalcy in the NICU setting, but also offers the families an opportunity to really connect, get to know each other, share experiences, and form a lasting bond. These events are a vital source of emotional support during what can be very challenging times. The Family Staff Advisory Committee, it really plays an important role in maintaining strong relationships between our families and the healthcare team. By working together, we can address any concerns, celebrate successes, and collaborate on ways to further enhance the care and support we provide. Through these collaborative efforts, we're not just providing medical care, we are creating a community where our families are feeling heard, supported, and valued, and really making improvements in quality care. The Voice of the Patient panel is designed to facilitate graduate family feedback on a specific topic to enhance and improve the NICU experience. The topic is chosen in partnership with unit leadership. It is a way to bring parents back to share feedback and experience for the purpose of quality assurance and quality improvement. We learn what works and what doesn't work. The real lived experience of our families is then a part of our decision-making as a unit. So the real purpose is to engage families in quality improvement, and the outcome is to identify opportunities for improvement. So once our families leave, we really aim to stay connected with them by actively involving them in our Family Advisory Committee. This partnership enables us to draw upon their valuable experience and work together to improve their NICU experience for future families. During the planning stages of our small baby unit, we collected feedback from our families to get their comments on recommendations surrounding participation in bedside rounds, how to better receive education from staff. We had one parent representative that was directly involved in the planning committee meetings to ensure that the family is getting the perspectives that is at the forefront of our discussion. This parent representative played a crucial role in bridging the gap between our healthcare team and the families that we serve to ensure that their voices are not only heard, but is really an integral part in the decision-making. As we moved forward with implementing the changes based on the feedback we received from our families, we saw a positive shift in the overall experience for families in the NICU. By embracing a collaborative approach and valuing the input of our families, we were able to create a more supportive and inclusive environment where our families felt heard, respected, and empowered. Thank you.
And so, thank you, Angeline. We will begin our Q&A session. Dr. Michael Posenchak, who is our District 3 section on neonatal perinatal medicine, who in District 3 is also a supporter of our conference. So we have both Dr. Shaw and Dr. Posenchak here joining us today. We're going to begin our Q&A session shortly. We're assembling our panel of speakers.
Well, we're waiting for our speakers to come on camera. If you would, that'd be great. And Shettle, you did such an amazing job with the first moderation. I'm wondering if you might want to kick us off. There's a number of questions in the chat that I think we can start with. I have my own, but where should we start, Shettle?
I think we'll start in order. I think the feeding one was very interesting because volume is pretty much, for as long as I can remember, really been kind of the metric by which we measure the quality of feeding. So to me, I thought that that was sort of paradigm changing in terms of the way we think about it. One question I have though was one comment was when you talked about transitioning your patient from G-tube feeding, you specifically said that you wanted to maintain Q3 feedings to increase, or bolus feedings, excuse me, to allow for the normal hunger cycle. Whereas a lot of times when this includes us, when we send babies home, we do the bolus feedings during the day and then the continuous feedings at night. And I was wondering what the data behind that the bolus feeding practices versus the continuous at night practice is.
I don't have any evidence-based comparison data, but I can tell you from my own experience constantly, our digestive system just isn't made to work that way. And a lot of times people are doing continuous feedings overnight, and they are they're also increasing the number of calories, so there'll be a less caloric load during the day. And what I found is that even when you stop it at like 6 o'clock in the morning, these kids, the best you can hope for is they're ready to eat at noon, sometimes not till 3. So I just think you have to look at every kid. We have children that we send home that have neurologic deficits, and that PO feeding is going to be pleasure-based and maybe not really full. And we want to allow parents to sleep and to get, this is going to be a long, long, long road. But for somebody that we're sending home and we really know that PO feeding is not only an option, it is the way we're going to go, keeping them to be hungerful, hunger satiated is the best way to do it. And in many cases, I know as physicians, you're trying to be kind to parents and letting them sleep longer, but they were going to take that infant home and get up in the middle of the night anyway. So I think when you explain it to them, they are really willing to do whatever because their target goal is oral feeding too.
Hildy, can I ask one quick question just as a follow-up to that before we get, because I want to make sure we get to the questions in the chat. You emphasized in your presentation the importance of following the baby's cues in terms of their readiness for feeding. I'm wondering if your unit uses any sort of a scoring system that's criteria-based that allows you to put a number to that. So for example, is there a readiness score for feeding that you have to achieve below or above a certain number before you start or introduce oral feeding for preemies?
That's a great question. We actually have a long history of doing this, and we actually were using scoring that was developed by 2 occupational therapists out of Cincinnati Children's Hospital in around 2010. So what we were, and it was called infant-driven feeding.
Mm-hmm. That's what we use.
Okay, and we do use that scoring system, and then somewhere along the line, the company, Dr. Brown, purchased the right to that. And I'm happy to say that we are going to be reinitiating our infant-driven and updating our infant-driven feeding protocols with the new 2024 version of infant-driven feeding. We've just, we're going to engage with the Dr. Brown company for this.
Great. Well, thank you. There are a couple questions, I think, from the first talk from Christine and Gina and Alexa. There's questions in the chat about how much zinc you're supplementing daily and sharing your iron and zinc supplementation guidelines. And then another one related to that is, do you use ferritin levels in guiding iron supplementation? So 3 questions about how you operationalize your zinc and your iron supplementation.
So first off, for thing, we don't have guidelines right now. It's one of the things that we are working to develop in the next year. But there's a standard dose of 4.4 milligrams per day of what we give these kids, and we split usually when they're around 2 kilos. We start it so we get to that target range of 2 milligrams per kilogram, and we can use it for 7 to 14 days and monitor for the need to continue or to discontinue based on if there is any improvement in growth.
Okay. So we have iron guidelines. We'll be happy to share them. Currently, we have our fellow is collecting data, doing a research project about ferritin levels. But we do check ferritin levels as well. So we start iron at day of life 14. Obviously, that's assuming that they're not on TPN or any parenteral nutrition. And then we will check after 2 blood transfusions, we will get a ferritin level, and then we have a whole algorithm right now that we're following.
Fantastic. Thank you. There's a question about the reasoning behind not weaning from donor milk to formula. I wonder if you guys could address that question. I think every unit does that a little bit differently.
Sure. So initially when we started the donor milk, we had donor milk, we asked around with different hospitals. There was no clear guideline on how to take them off of donor milk. So we did do 4 days of weaning. We found it didn't, there was no, again, there's lack of evidence of whether or not it's 4 days, it's 3 days, it's 2 days. We just found it didn't really make a difference. So there's no wean. The only time we do a wean is if we have a baby that's post-neck or has some GI intolerance, and we're a little weary about going full-fledged. We will still do the couple of days, but for the majority of our babies, it's not necessary. We haven't had any increased neck rates. No concerns at this point.
Great, thank you. Cheryl, I've asked too many questions. I'm gonna throw the ball back to you. This is a fun little tag team.
There are a couple of questions about going back to this speech language pathology. One about operationalizing the standing order for speech language pathology, sort of consults or assessments prior to oral feeding. I don't know how it goes in other places, but in every place that I've been in, I think you're right. People look at a certain gestational age window, and then when either the physician brings this up based on physical exam, but more importantly, nurses drive a lot of the, oh, I think the baby's ready to eat. And then we start giving the baby feeding. So I think if you could elaborate a little bit more on that practice. Now, is that a speech language pathology consult prior to every baby less than 30 weeks getting oral feeding, or only babies with certain risk factors?
No, we like every baby who's born less than 30 weeks to have a speech and language consultation. However, we don't always make every baby wait until one of us can get there. There are certain babies, the doctors, the medical team with the nurses decide on certain babies that really may need to wait until we can get there and our priority. We have an algorithm that there is a setup for what the nurse can choose to use and start with 2 different slower flow nipples, depending upon whether they're feeding thinner viscosity express breast milk versus formula. And they can start, and if there's not an issue, they will stop and they will call and we will prioritize. We also do usually a good week or so, a couple of days of queuing, just scoring the children for readiness before we feed. So we see that they have some consistent readiness. And we do look at scoring for every feed, which does not mean when these kids start, they're going to feed all 8 feedings Q3. They're going to only PO when they're ready and when they're showing the readiness cues that similar to what I described in the presentation.
Great. I want to pivot a little to the health equity lecture, because that I think has brought up a lot of points for discussion. The first question was someone was asking you guys to elaborate on the NICU classes. I thought this was a really fascinating idea. If you guys could share, at least obviously you went over some of what's covered with the introduction to the NICU and other things, How often are these classes offered? Who teaches them? Are there days and nights? Are they available in different languages? I think a lot of people are intrigued by this idea.
I think I'll take that answer. Yes, we have currently 3 classes that we offer every week. An orientation to the NICU for our new families. We offer an infant care class, and we also offer CPR and safety at home. So the classes are given at various times during the day, in the morning, in the evening, in the afternoon, and at special times, depending on families' time factors. If they can't come to any of the classes, then we arrange a special class for them. Definitely in their preferred language. We have in-person interpreters that can come to the unit and assist. We also have some instructors that Spanish is their primary language as well. So we try to cover the classes and hold each one every week. Sometimes multiple times if we have to, depending on how many patients we have.
Yeah, I think it's a very important. Oh, go ahead. Sorry.
The nurses are primary instructors. I teach most of the classes, but we do have other nurses that teach as well.
And it's not required that parents go to these classes the way it's required that they watch certain videos prior to discharge. These are optional.
They're highly recommended. And we do try to, invite them and explain how important it would be to receive this education. And we try to be adaptable if possible, so that they have an opportunity.
There's another question here, really basically, I guess, fanboying or fangirling over the NICU Parent Advisory Council, and talking a little bit more about how you establish that. I think people are specifically saying that everyone, I think, understands the value of it, but they're not sure where to start on that journey.
I think, Judy, you can speak on how you established and then where we are right now.
We originally established our first Family Advisory Council many years ago. Because parents were interested at the time in becoming involved. So we determined different levels of involvement, and we had them sign up as volunteers in the hospital. Some parents came to the bedside and did peer-to-peer support, so we needed to provide special education for them and ongoing training and support. We also had parents that would review documents, help with processes and different things we were doing in the NICU, fundraising and social events. So over the years it had developed. We've had different groups. And then when COVID hit, and I'm sure everybody would agree, was difficult to bring them into the hospital. And so now we are reforming our group again, because we know how vital they are to the NICU. And there is a role for each one of them.
Yeah. And if I may add, one of the important things that was said at the opening of the conference by our NICU nurse manager, Cassandra, is the importance of involving administration in the support of efforts of the NICU. Having started a Family Advisory Council at a previous institution, the first step was to really engage hospital administration because they're the purse strings. And then certainly in the context of equity, some Family Advisory Council members are paid participants. You should also think about meal vouchers, babysitting vouchers to allow a diverse group of families to participate.
Thank you so much, Lisa, for saying that, because I mean, I don't know, Mike's nodding his head too. I think Mike's experience might be similar to ours, whereas you decide that you want to start a parent advisory council and it's overwhelmingly higher socioeconomic status parents and families who really were bonded in the NICU because they had the ability to be at their baby's bedside 24/7, or at least every day. They bonded to the staff, they bonded to the physicians, and now they want to give something back, but they also have the luxury of potential childcare or other things. I'm going to send it back over to Mike.
Yeah, I have one other quick question, and then I think I think we'll be at time. Dr. Island, thank you very much for your talk. It was amazing and highlights a lot of the things that we certainly, our units, I think, struggle with in terms of disparities and the quick story about kangaroo care and day versus night in and of itself, I think, sets up a disparity just because of who can visit during the day versus who can visit at night. I think that was fascinating. And I guess my comment before I ask the question, that the one more question in the chat that I want to bring up, my comment is that if we don't address how the membership of our parent advisory councils in terms of how well they represent our patients and their families, we could set up a disparity right there because we're going to rely on our parent advisory councils to help us come up with ideas for changes as much as we involve them in our quality improvement projects. And if they're not they're not really representing our population, we actually can make our disparities of care worse. So thank you for acknowledging that. There's one last question. I think it's a pretty quick one, and then I think we'll be at time and move on to the last set of lectures for the day. If parents are involved as supporters to other families, how does that work with HIPAA? It was a question brought up by the person who asked the question, their leadership as well.
Okay, they work through the volunteer program, but they're held at the same standard as any staff member in the hospital as far as confidence. They have to sign a document and they receive special training as well. So, and ongoing support. So if there is a situation or something they need to talk about, there will be a staff person that they can come to.
Thank you. There are a few more questions in the chat. I think if for those that could answer them while we move to the next set of lectures, that'd be great. There's one around starting caffeine and another one around kangaroo care and umbilical lines. And I think with that, I will transition this back to the conference organizers for our next set of talks. Thank you.
Thank you.
Hi, good afternoon, everyone. I want to thank our leaders that have put this conference together today for allowing us to present on our nursing education. And I want to thank our participants for staying with us throughout the day. We've had a full agenda, and I'm happy to be here to present with nursing education with some of my coworkers. My name is Terry Spirito. I am the NICU education specialist. I'm here presenting today with Jessica Villarreal and Maggie Campestri, who are two of our NICU charge nurses. I wanted to mention some of our team leaders in nursing that helped our small baby unit from the beginning and helped this become a reality for us at Hackensack. So Joanne Pazinski and Chris Toslowski were instrumental in starting this program, and you'll actually be hearing from them in the next presentation. Jamie Avalon, who was my predecessor as an educator in the unit, myself, Maggie, and Jessica, who were part of the original team and have been part of this program from the beginning. And a couple of our other staff nurses, Kelly and Roseanne. Also, of course, this did not come together without the tremendous support from our nursing leadership team, Cassandra Martin Walters, our manager that spoke earlier today, and our 2 assistant nurse managers, Susan Thompson and Beth Kim. So we've heard from a lot of different presenters today, and this quote really just sums up how this project came together with all of the different departments and stakeholders that were involved. So teamwork, coming together is a beginning, keeping together is progress, and working together is success. And that really does summarize our project for our small baby unit. So the small baby unit, as you've heard earlier today, development began around 2016 when we were actively planning how we were going to move forward in building a small baby area. Our overall aim at the time was to improve survival without major morbidities for inborn infants less than 30 weeks. Around that time, we were at about 52% in this data. And our goal was to get to the 50 to 58% or the 75th percentile in Vaughan by December of 2019. Our outcome data was really based on 6 major morbidities for these infants less than 30 weeks. And again, these are inborn infants. We were looking at chronic lung disease, pneumothorax, late infections, severe intraventricular hemorrhage, periventricular leukomalacia, and necrotizing enterocolitis. And currently we are above the Vaughan median, above that 75th percentile for survival without any of the 6 major morbidities. So when we started our initial education in early 2017, it was a multidisciplinary team as represented by our speakers here today. And we started with a core group of team members from the NICU. So this included physicians, nurses, respiratory therapists, and so on. The initial education, we used an online platform, SharePoint, for our small baby unit, and it included assigned articles, book chapters, and weekly online discussions for the core team. Some of the initial topics in our peer-reviewed journal articles included improving outcomes in extremely low birth weight infants, neuroprotective measures, reducing noise, long-term effects of pain in this population, promoting and protecting sleep, prevention of hypothermia, early skin-to-skin, family-centered care, BPD and NEC. And we included some articles and research data, evidence-based practices about supporting workplace environments and nursing burnout and stress. We thought it was important to highlight the effects of caring for these small babies and how it affected our staff. In the initial training, we also used this book authored by Mary Coughlin, a neonatal nurse practitioner. And this is just an outline of some of the chapters in her book, highlighting some of those components that we were also focused on in our articles we used to guide our team education. This book also highlights those last 2 chapters, meeting the needs of the clinicians and self-care guidelines for clinicians. But of course, highlighting the healing environment, pain and stress, protecting sleep, and included family collaborative care as well. So our initial neuroprotective measure guideline that we put forth with this initial implementation of education for the team really did focus on practice changes that were on neuroprotection, thermoregulation, and infection prevention. So this is just an example of a guideline that we had developed at that time with some of those clinical changes and practices that were going to help guide our care in our small baby area. And this was put forth by that initial team. With the implementation and the pursuit of our DSC in 2019, we decided to pursue the DSC from the Joint Commission in Prematurity. And this gave us the opportunity and really was a way to launch education to other departments and our entire NICU team. So in 2019, we developed a small baby course, which we'll talk a little bit about more in a few minutes. And it included all NICU multidisciplinary team members. So our respiratory therapists attended the course, all of our nursing team and the medical team did attend training as well. We also did a DSC e-learning online for our nurses. I'll touch on that in just a second. And then we included education for other departments because this does not just happen in the NICU. The care of these babies starts in the high-risk antepartum unit, starts in labor and delivery, and extends out to the mother baby floor as well. So it was important for us to include education for those teams at that time. Oh, sorry, wrong way. So in terms of the other departments, we thought it was crucial to partner with them and help them really understand what our goals were for our small baby and the performance measures that we were outlining in our DSC application at that time. So some of these things included setup in the delivery room with our specialized equipment. We use the Giraffe isolette, and rather than admitting our small babies into a warmer bed, we bring the Giraffe directly into the delivery room. So that was something we had to partner with our labor and delivery colleagues to make them aware that we needed a few minutes ahead of the delivery to be able to set up that equipment that we're using as our standard equipment as well. Another piece of that was to make sure the temperature of the room was appropriate. So calling ahead to make sure that we had a few minutes to adjust that temperature. Colostrum collection. So this was an instrumental part of our original DSC application and still one of our core measures that we use. So the collection of colostrum oral care, this doesn't just happen in the NICU. We had to involve our other departments, whether the mom was back in a high-risk antepartum, if she had been a patient, that occurs sometimes, whether she's on labor and delivery or on mother baby. It was really important for us to be able to partner with our colleagues on those other units to understand the importance of early colostrum collection and colostrum oral care, and have them partner with us in talking to the mom about pumping and early hand expression. Following up with mothers and partners, how can we partner with our other colleagues on the other units to make sure that families getting updated as needed, and really understanding the care of their baby that the baby's getting in the NICU. And then lastly, there was an e-learning that was sent out to all nurses in maternal child health to help them understand our goals with our DSC and how we were going to move forward with our program. So in the e-learning that was sent out to the maternal child health nurses, we did highlight what a DSC is. There aren't as many DSCs that are available in perinatal and neonatal medicine as may be in an adult setting. So some of them weren't familiar with really what the process was and what that meant to obtain a DSC from the Joint Commission. So we like to highlight those points. We included the objectives of our DSC, including the stakeholders that were involved and the performance measures. Those core measures, really the outcome data that we were hoping to show improvement in with our patients. We provided education and ways to link our clinical practice guidelines that were in development through the medical records. So if a nurse was in the patient's medical record, they had an easy link through that platform to be able to see some of our practice guidelines. And then lastly, we highlighted documentation, and I'll touch on more of that in just a second. So these were our original core measures, our performance measures in our original DSC. And this we thought was really important to try to impress the importance of these to our colleagues, both in the NICU and in the other areas for patient care, to help them understand what our goals were with our DSC application and ultimately how we could impact the care of our small babies and our small baby unit. So the administration of colostrum oral care by 12 hours of life, the initiation of trophic feeds by 12 hours of age, skin-to-skin holding within 24 hours of eligibility, and a family care conference held between 7 and 10 days of life. Prior to the implementation of our small baby area, some of our data we were far away from these metrics, and we were really trying to show an improvement. Our previous incidence of colostrum oral care, for example, prior to 2017, was at about 44 hours of life was our mean. So we really did have a long way to improve from where we started to where we wanted to go. Documentation was a big piece of our education that we rolled out to the team. We understand that there sometimes are barriers to meeting our performance measures and what the expectations would be. And the best way to be able to track these is to educate the team, the nursing team, especially on the importance of documentation. So that was a big piece of our education to the team, both in the NICU and to other units as well. And the best ways to document, especially if there are barriers that are existing to why we can't meet these performance measures. Colostrum oral care, for example, it's important to note if a mom maybe is critically ill or not able to pump for a certain reason. So why she's unable to provide colostrum. We wanted our team to understand that, to be able to document and speak to that. Early initiation of trophic feeds, how to document appropriately for that so we can track that data in the best way possible. Documentation of skin to skin, and this was a really big piece of our documentation and one that we probably focused the most on. Our original goal was to have skin to skin occurring within 24 hours of eligibility when the infant is deemed eligible. And there are times where that was occurring where it was maybe falling on the same day as mom's discharge from the hospital, and maybe she wasn't feeling up to performing skin to skin that day. So we impressed to our team the importance of documentation to those barriers and why these things might not occur, so that we're able to track our data most appropriately. Family meeting with the providers, we're impressing upon the team, both nursing team and the medical team, to document those things in the chart. When we've reached out to the family to try to schedule a family meeting, and just make sure we can track that information. We don't want to miss anything, and documentation is the best way to make sure everything's covered. OTPT consult, the first oral feeding guidelines, and the discharge planning meeting. So some of these things came a little bit later on. Our care plan, nursing care plans are a big piece of how we're documenting our education with our families. We were educating the team about the importance of documenting on every single shift about the things that we're discussing with the parents. When are they receiving education about the risk of infection if there's a central line in place? Where are they receiving education about skin to skin and the importance of that? Why we think it's so important, about the initiation of those early trophic feeds and the colostrum oral care. So this, again, just goes back to how important our documentation was in the education piece. And then finally here on our care plan this is just an example of how we have some of our goals broken down. They're both parent-centered and patient-centered, because for those of you that work in the NICU, you know that the patient is not our only patient. Really, the family is a big piece in our family-centered care model. So some of our goals are for our parent-centered goals, and those would be things like anxiety that the parents are experiencing, knowledge of specific diagnoses of the patient, and then our patient-centered goals, looking for some of those risk factors for that baby, risks of infection, absence of respiratory distress, things like that. I'm going to now turn it over to Jessica, who will take us through some of our small baby course. Thank you. Hi there, my name is Jessica Villarreal, and I'll be talking to you today about our class that we offer for our nurses in the NICU on small baby care. This is an example of our agenda. So we start the day, and the day we do provide 3.75 hours of contact hours for nurses. So if you can see here, we start the day with just a description of why we went to small baby and applied for the DSC prematurity and what that means. And then we move on to that, from that to a trauma-informed care video. I'm going to touch on this video in a little bit. And after our break, we slide right into the golden hour. And then from there, the healing environment, which Maggie will talk about a little bit later on, about light and sound and our guidelines for those. And then from there, we go on to positioning, cue-based care, minimizing pain and stress, safeguarding, protecting sleep, and then two-person care, which she'll talk about as well, which was a big change of our nurses. And then beyond that, we offer a skill session where we break it down. We teach nurses how to draw their own heel sticks, because if the baby doesn't have a line in the small baby area, we are drawing our own lab work on our babies, just to minimize handling and such. And then we also go through our policy for UA lines and drawing back blood off of the line and then flushing it, and the speed at which we do that and such that's safest for our babies. So it's kind of like a synopsis of our day that we offer for our class. And then this is just, I know Terry talked about aims and the original aims for the prematurity DSC, but this goes a little bit further into our current data that we collect, and we can look at different areas like clinical, administration of colostrum oral care by 12 hours of age. We also have skin to skin holding within 24 hours of the first family visit at the bedside after the infant is eligible. So that's a little bit different than what Terry was talking about earlier, where we actually look at when the family first visits after those 72 hours, or when the patient is eligible if they've come off of the oscillator, something like that. Another clinical aspect that we look at is the OTPT consult at 32 weeks of gestational age, and then also first oral feeding
that is correct per our guideline. And then we offer a discharge planning meeting at 33 weeks of gestation, or when the baby is taking at least 20% of their oral feeds. And then if you look back up on the slide a little bit under perception, it's really looking at the family's perception of that family meeting that's offered, and are they getting a score of at least 4.5 out of 5. Terry touched on the book by Mary Coughlin. We did use this when we initiated our small baby training for a small cohort of nurses in the NICU. What we did was we assigned the nurses readings from each chapter, and then we would have a kind of online discussion about our thoughts on that. And it really helped to create a good teamwork, a team base, and buy into the whole program and why we're doing what we're doing. So in our agenda that I showed you, we talk about the trauma-informed care video. And this here is a link that, I don't know if you can reach that through your slides, but this is the link that we use to show the video. It's about an hour long, and it really talks about the trauma that patients suffer in the NICU. And that sounds really harsh. I think for a lot of us, when we think of the word trauma, we think of maybe a gunshot wound or a drowning, something like that. But it's really the stress and the constant handling, the light, the sound, all that, and everything that the babies go through in the NICU can really be traumatic and, you know, create lifelong effects that can be devastating actually for the patient and the family. So it is an amazing video, and if you haven't seen it, I would recommend it. I am going to go into the golden hour, and Dr. Slane talked about it, but I'm just going to talk about how we teach this for our small baby course for the NICU nurses. So these are the components of the golden hour. Again, scripting, and we'll look at that color-coded script again. Team cooperation, communication, the importance of thermoregulation, early administration of surfactant, minimizing oxygen exposure while optimizing ventilator management, minimizing the stimulation of the infant. And, you know, this is really important, not just for staff, but also for our parents as well. And modeling that, you know, can be kind of hard when you have an admission and, you know, there's a lot going on, but trying to speak in lower voices and really bring down the sound during our care for these patients. And Maggie will talk about that a little bit later. Prioritizing care, early insertion of lines, and following our IVH bundle. So we do use a head positioning device, and we'll talk about that a little bit later as well. And then it's really important to educate our families early on, not just on the importance of early colostrum care, but on light, sound, handling, parent involvement, and all of that. And then trying to coordinate and prioritize care with other departments, not just the NICU. So that could be radiology, phlebotomy, etc. So this is our script, and you've seen this probably a couple times today. For the purpose of our NICU small baby course, we really talk about nurse 1 and nurse 2. So nurse 1 would be your delivery room nurse, and nurse 2 would be like your assistant when you get back to the unit. So ahead of time, we're going to set up the giraffe if possible, activate our mattress, get our limb leads ready, everything you're going to need for the delivery room. We want to, when we get back to the NICU, call for X-ray, for ET tube placement, and then check the glucose within an hour, which I'll talk about a little bit later as well. And then the nurse 2 could be setting up, getting all the supplies needed for line placement, you know, taking the amino acids out of the Omnicell and starting to warm those up, make sure we're following our AL protocol, getting all our limb leads you know, connected properly, and then assessing the baby, getting a you know, brief assessment in before they start with the insertion of lines. And then it's just important that our goal is to have their hood down on our isolette within 1 hour of admission to the NICU. So they kind of try and keep everyone on track. And also on here, there's roles, you know, set aside for the respiratory therapist, the neonatologist, and the nurse practitioner, or the PA or hospitalist as well. So it's really a great communication tool. And if you look on the left, like it breaks it down into the time frame, and it really just guides everyone in how they're going to proceed with the admission. So it's,
you know, if you haven't done a small baby admission in a while, I always encourage people to kind of look through that. If you know you're getting an admission, be aware of it and kind of just familiarize yourself with it before the admission. So it's a great tool that we have, and it really aids in communication. Some of our pre-delivery preparation in the NICU, the RT is going to set up the vents and have everything situated for that. The NICU RN will grab the supplies like we talked about. You know, if we're having a baby expecting baby less than 26 weeks of gestational age, we'll aim for a dual lumen UV. We'll try for a UA. And then we have different starter TPN for our babies. So if the baby is less than 26 weeks, we will use a D5W starter TPN, excuse me. And then 26 to 29 weeks, we'll use a D10W starter TPN. So while the nurse is gathering those supplies, maybe then the medical provider is starting to set up for their umbilical line, like the tray, and priming everything and then covering it prior to the delivery if they have time, so that it's all set to go when we get back to the NICU with the baby. So we also have pre-delivery preparation for our delivery room, and this is really a collaboration with our labor and delivery department. Some of the equipment that we use is our giraffe. We do pre-warm it to 37 degrees. We have an intubation box prepped and ready to go with all of our supplies and situated just so we're ready to start. We have a neopuff set up and checked by our respiratory therapist. Our suction is set and checked. We have our surfactant ready and the administrator adapter available if we choose to deliver the surfactant in the delivery room. If not, we'll just bring it back with us to the NICU so we can administer the surfactant there. We have our golden hour, and this consists of our Neo Wrap, our warmer mattress, which we just activate right before the delivery, a hat, and we use a turtle, but it's a midline head position device. We also have a monitor with the ECG leads, a pulse ox available at the bedside. We call ahead of time to our delivery rooms or the charge nurse in the labor and delivery department and ask to have our temperature increased to 74 to 77 degrees. So it's nice and warm in there for our babies. If the neonatologist has time, maybe they'll introduce the NICU team to the family. We like to do a quick briefing before the delivery to identify everyone's roles and make sure everyone's comfortable in their roles and sure of what they have to complete in the delivery. And then we'll just kind of discuss and determine if there's a plan for delayed cord clamping or not. Stabilization in the delivery room. This consists of obtaining our vital signs. Our RT will apply the pulse ox to the right hand, and we'll apply the limb leads and attach those to the cardiorespiratory monitor. We do, like I said, we use the head positioning device for neuroprotection, really trying to keep that head midline and maintain that. Thermoregulation, of course, is huge. So we will apply plastic wrap to our smallest babies and use the warming mattress as well. And we'll keep those on until we get back to the NICU and the baby's temperature has stabilized. And then respiratory guidelines, again, will follow for surfactant administration when indicated. So it is a priority of ours to involve our families in the delivery room right from the get-go. So how do we do that? We'll invite either the father or the partner to the bedside to touch the baby, to take pictures. Sometimes they're just really overwhelmed and they're, you know, like so frazzled they don't even know what to do. So oftentimes we'll become the photographers ourselves and really just kind of capture those first moments for them and help them with that. If the mother is awake, if she's not under anesthesia or something, we'll bring the baby over to her in the giraffe, really trying to still maintain that midline position, not lift them too much or move them around too much, but we do try to provide the mom with a moment to see her baby before they go back to the NICU, because it might be a while until the mom's wheeled through the NICU to see the baby again. And then I know this was brought up in a question and answer earlier about the transport back to the NICU. For us, it's a quick kind of walk right down the hall from our labor and delivery units. So we'll wrap the baby, we'll warm the baby, we'll maintain them midline right in the giraffe, and then we'll neopuff them back to the delivery or from the delivery room to the NICU. So it's a quick walk for us. I realize in other units it's not so quick, so we might have to kind of tweak that a little bit. And then these, you know, in our class, we talk about RN responsibilities during the small baby admission. We do use the bed scale on our giraffe beds, and we'll remove the turtle just briefly, or the head positioning device just briefly so that we can weigh the baby. Unless perhaps you've decided to give surfactant in the delivery room. In that case, we'll probably weigh the baby in the delivery room and so we can adjust the dose to make it just right, so we'll do that in the delivery room. We do get a head circumference, so oftentimes our head positioning device is applied based on an estimate of what size we think they need, and then we may have to adjust to a different sized head positioner just based on what the baby's actual head circumference is. Again, we are going to attach the monitor, make sure our temp probe is on. We're going to follow our Oxygen with Love guideline, make sure we're not giving too much oxygen, but we're providing just enough. And then we can get our heart rate, our oxygen saturations off of the monitor. We're going to, again, maintain thermoregulation. We want to really make sure that our baby is nice and warm, get our vital signs. We probably get 1 limb blood pressure just to check it before we get deep into, putting in the lines at the bedside, because that sometimes can take a little bit longer than anticipated. If it is taking a little longer to get those lines placed, we will check a glucose within 1 hour after a birth. We would prefer to do that through the UA or the UV, but if we need to, we'll do a heel stick just to make sure. We found, based on different audits that we had done previously, that after 1 hour, that's when the blood sugar was really beginning to drop for our baby. So we try to check it within an hour, even if the lines haven't been placed yet. And if that's the case, then when we would do that with a heel stick. And then we're just performing our assessment and measurement after the lines are placed. So you get those initial vital signs, everything's good to go. You get a chem strip later on, and then you can get the rest of those measurements and the rest of your assessment at the bedside after the lines have been placed. And on the bottom here, we talk about preparing antibiotics and admission meds. That would be for that second RN that's kind of helping, assisting with you, because the first RN during line placement is really focused on being an observer and watching insertion of the lines, the UA and the UV, to make sure it's done as sterilely as possible. And finally, I'm going to talk about management on day of life 1 through 3. Again, we have respiratory, where we're really watching those oxygen saturations, minimizing ET tube suctioning, paying attention to the tape and the depth, and everything's good to go with that. As far as neuroprotection, we want to make sure that the baby is maintained midline. We have the head of the bed elevated to just 30 degrees. In our institution, we use a Z-flow positioner, but other people use bendy bumpers or whatever your devices that you're using to really provide developmental boundaries for your baby and securing them nice and snug in there like they're still in the uterus. We don't weigh our babies in the first 3 days of life. We wait until they come off the neuroprotection bundle. But we like to coordinate care between medical personnel, nursing, RTs, etc. Protect from light and sound, which we're going to get into a little bit later, but that's very important. And then we'll do head ultrasounds as per our guidelines. For these babies, skin protection is very important as well. So we do provide humidity in our isolates for 14 days, and we have a guideline for kind of weaning that each day. We try to avoid PIV insertion and instead use the dual lumen UV or use it UA, etc., for blood transfusions, blood draws, etc. And then just being careful with our baby's skin, really protecting it and being, mindful of the tapes that we're using. And, do we have Duoderm or other products available that we can really protect their skin and, avoid peeling off layers that aren't necessary to peel off. We like to rotate our pulse oximeter site very regularly because, again, their skin is so sensitive. We don't want to damage their skin any further. We do frequent nasal assessments for our non-invasive ventilation, and then we don't bathe our hours. We're really
Yeah. What green scissor?
Can everyone please mute themselves? Hello all, my name is Maggie Campestri. I'm gonna speak a little bit today about creating a healing environment. What we teach the nurses
when we're going over the small baby course with them, the different developmental care that they're going to be encountering when caring for the small babies, whether it be sound, light, pain, non-pharmacological interventions on things that they can do. And we're focusing on the small babies, but this can also truly apply to all of the patients that we care for in the NICU. So what are some attributes of a healing environment? A healing environment includes the physical space. It includes the interpersonal aspects of all of our teams working together to create a therapeutic relationship for our patients as well as their families. And above all of that is kind of the organizational environment that reflects a culture of safety. So all of those things work together in this environment in the NICU. So neonatal development and protection. The neurological system, it's in a very highly active stage developing during this third trimester that now we're caring for these little guys. So we want to provide the most developmental supportive care that we can, because we know that if we do all of those things, we can have fewer days on the vent, earlier success with their feeding, leading to shorter hospital stays, and hopefully improved neurodevelopmental outcomes during the first 18 months of life, as well as long-term effects and sequelae from their prematurity. And that's the kinds of things we'll be seeing in a follow-up clinic and whatnot. So we really want to focus on this neurodevelopmental protection. The sound. So the auditory system becomes functional in utero around 25 weeks, and it continues developing. And this sound exposure that these babies are hearing in the NICU can have some adverse effects on them. You'll see the thing that I always kind of go back to, and I really try to impress upon the nurses when they're taking this class, is when you look at the change of shift noise. This showed that it can be upwards of 127 decibels, which is just about 13 decibels lower than a jet engine. So you're talking about double the amount of staff members there giving reports. So instead of in our small baby area, maybe you would have 3 or 4 nurses. We're now talking 8, possibly 9 if you have some orientees and some other staff members around. So it's really double the amount, can get quite loud. And suddenly that baby that hasn't had any DSATs or episodes is suddenly having a lot of DSATs and episodes at 7 p.m., 7 a.m. It's probably not a coincidence. There's a lot of noise going on. So it's just really being aware of that and the noise that's happening in the unit. It's just a good graph that really shows you different sound levels, and some of the sound levels here in our NICU can be quite loud. So what can we do to help with some of that sound level? Accountability is kind of number one. Everyone being accountable for keeping the noise level low. So that might be like just modeling it. If you're noticing that things are starting to get loud, and just saying, hey guys, it's gotten a little bit loud in here. Let's just lower our voices. Sometimes if you're not, someone might not be comfortable saying that. A lot of times if you just start to naturally lower your voice, others will start to naturally lower their voice. So something like that can be done. Responding to alarms, being aware of, opening and closing the isolate doors,
we have our computers in the room. So making sure, you know, when you close the computer, that's not making a lot of sound. We have little earmuffs that we put on the babies, especially during that first 72 hours. You can use the earmuffs. But if they need it more frequently, if they're more sensitive to it, that can be used at any time. Keeping unnecessary conversation away from the bedside, keeping the SpectraLink phones away from the bedside, just really individualizing for that baby what their needs are. Mindfulness, this is just an intention, the practice of focusing our attention purposely on the present moment and accepting it without judging. So the mindfulness or intention that you carry when you're going in and taking care of this micro-preemie and someone's child. So as like I said, a lot of these things can really be applied towards all of our patients, not just our small baby, but all of our patients, and the intention that you carry. Talking about pain, newborns experience critical periods where brain development occurs. The newborn experiences pain during this development. It can lead to long-term effects and enhance future pain perception as adults. This is something that really is touched upon a lot in our class, in particular in the video that we show them. So it focuses a lot on that long-term effects of pain. So just really being mindful of painful procedures and what we can do. So what are some of the things we can do to minimize pain and stress? The most effective thing we can do is to prevent pain, is to minimize the number of painful procedures. So advocating for your patient, I think nurses are great advocates for their patients. They're the eyes and ears right there at the bedside 99% of the time. So I think they're great advocates in what their patient is showing them, but we can utilize, you know, just your hands-off vitals. What's your baby's vital signs like without even going in and touching and doing anything with your baby? Reviewing clinical necessity of certain procedures. Can all the labs be batched to a certain time? Can we do the x-ray at a certain time? Those kind of things. Just using those assessments and observations. And another big thing is minimizing the number of repeated procedures performed after a certain amount of attempts. So meaning the most skilled person, whether it be for an IV stick, an intubation, ART stick, it's, you know, we do have people who have to learn, but if it's a difficult one, then the most skilled person doing that IV stick. Comfort measures, non-pharmacological interventions can really be very relevant and used for our babies. We can do things such as containment, can do facilitated tucking, we can do breastfeeding if the baby is stable and older, or some non-nutritive suck, repositioning, nesting the babies, all of these things, skin to skin, any of these things that we can do just to provide comfort measures for them alongside if they need an analgesic. But there's many non-pharmacological interventions that can be done. And that brings us to these non-pharmacological interventions is involving the family. Sometimes when a small baby is born and they're very critical and very sick early on, it's difficult for parents to feel involved in the care of their baby. So giving them any opportunity that they can to be involved and to provide that comfort, teaching them what their baby's little cues are when they're distressed so that they can anticipate that and then provide that care.
And for us is really a win-win situation, because if we've, given these parents that ability to, anticipate their baby's cues, it can only help them more to become more confident. And as their path in the NICU continues through feeding and discharge, and really, allows them to be the full caregiver in taking care of the baby that they are ultimately taking home. So we want them to be really involved in the care. It's the best thing for them and for their baby. Protecting sleep. So evidence-based research shows that practices that protect sleep integrity and support circadian rhythms can be integrated into the care given in any small baby unit. So how do we do that? We can do that by having scheduled non-emergent care given based on the baby's sleep-wake state. So it's the baby's cues, not our cues and our timeline. Cycled lighting is a big thing for us. We have isolette covers, so having flaps up for 12 hours and then flaps down for 12 hours when it's gestationally appropriate. We have a graph that we go by. And then just the staff being adept at the infant sleep-wake cycle. So when the baby is awake, doing, what needs to be done, and then when they're resting, let them sleep and rest. So we're going to talk a little bit about cue-based care. So how we handle these babies, and has some pictures that kind of illustrate some of the two-person cares that we do. Key elements in providing and developmental appropriate care. So again, when we initially started this, we started with a care times, like a Q6-hour care times. We quickly changed that. It wasn't really working and it wasn't really appropriate because maybe the baby was sleeping during that time. So going based on the baby's cues, and clustering the care when the baby was awake and it was a good time. Supporting them by containment or some swaddling if they needed that, using the two-person technique, and then protecting from other like environmental stimuli, whether that be some sound or light. So lowering the light, you can always use, we have little felt strips that you can use to cover the baby's eyes, different things such as that to provide a developmentally appropriate care. So here we have some different behavioral cues that the baby's showing. Kind of in the picture on the left, the baby's showing us when they kind of have gone limp, that they're done, they've had enough. This looks like is getting weighed or lifted, and clearly is kind of tired and not really feeling well for that. Having the splayed fingers is another big thing when they break eye contact. Some hiccuping, even so much as having, skin color changes or modeling irregular respirations. This is when, you need to kind of finish up your cares. If you're in there, finish up your cares because your baby's telling you without telling you, I've had enough and it's time to move on. And then recognize the cues of a baby who's, very ready to awake and interact. Knowing, the skin color, the nice respirations, visual alertness, bringing the arms and legs up or bringing the hands to the face. And maybe on an older baby, it's different sounds that they're making. This is just a graph that just shows some different things of an organized versus a disorganized infant. And really the main thing is like an organized baby is going to have more stable vital signs, obviously, able to be consoled, able to have more smoother movements of their extremities versus a disorganized baby. And then the two-person care method is simply just kind of gently, if the baby is still asleep and it's been many hours since you've changed the diaper, gently rousing the baby, going in, speaking quietly, and then doing some flexion with the baby, cupping the head, some hand hugging, those kinds of things. And these are the kind of things that we can teach the parents to do so they can be involved. This just shows a couple of different pictures showing like a containment, having two-person cares. This is something that easily could be done with, doesn't have to be two nurses. It could be the RN and the RT when they go in to assess the nasal assessment, could be mom and the nurse doing it when she's going in to do an assessment. So, keeping those parents involved. And then this is just, we go over the two things that Jessica had said, the heel sticks, and we go over with the nurse's umbilical arterial line drawing. So doing that at a controlled pace. And then we just have ongoing education. We provide it a few times a year for the different cohorts of nurses that come in, starting in the NICU. They have a 3-day multidisciplinary orientation course that involves a lot of the speakers that spoke today with lactation, with the speech language, and then a small baby course that we teach. There's bedside references, there's binders in our small baby area that contain all of the information, the different metrics that we are measuring and those kinds of things. We have a data board. So when we have a new small baby, when they'll come off the bundle, when they are eligible for skin to skin, all of those things. And then being involved in our small baby committee, and all of those things. This is part of the bedside reference that we have. It's a binder that's at all in our small baby area. And a person's a person, no matter how small. Thank you.
Chris, are you on?
Yes, can you hear me?
We can.
Okay, great. Good afternoon, everybody. My name is Chris Tuzlowski, and I'm sharing this presentation on small baby unit benchmarking success with Joanne Plazinski. I have shared, or I have worked at HUMC for over 25 years. Originally, I was in the role of the clinical nurse specialist. And during that time, I was a facilitator for all of the CQI teams that we've had in place since when Cassandra presented her slides of how the unit has progressed with the many multidisciplinary teams. And I was the person that was there when we implemented the small baby area. So this presentation will attempt to describe for you how the multidisciplinary team used quality improvement methodology, such as PDSA cycles and driver diagrams, and how we tracked our progress and measures to establish and maintain and improve our outcomes in the small baby area. Next slide. So this slide is an overview of the process that we utilized. So being aware of your unit's culture is extremely vital. as you've heard, we've participated in the Bond Collaborative since 2000. So change in our unit is very accepted, and we have a culture of change, and there is a willingness to standardize our practice and to improve our outcomes. It's also very, very important that you engage your leadership team and it's vital. Their support is extremely vital, especially when you're trying to design a small baby area where you're trying to define staffing patterns, who's going to work in that area, whether you're going to have other staff in that area, whether you need to upstaff, and actually to provide the time for staff education, because you do want to educate all of your staff. And that has to be done on staff time most of the time, so they need to look at their staffing. We actually did a formal proposal presentation to leadership when we started. It's also important that you develop a multidisciplinary team and that it is inclusive of all of your stakeholders. You need to also be cognizant of the fact that you have to keep that size of that team very manageable, because once it gets too large, you're just talking, and nothing gets done. So our team included medicine, nursing representatives, an RT representative, nutrition, child life, leadership was on that team, OTPT, and at the time we had a parent resource specialist that was part of our team. This team met at least monthly, and we performed a gap analysis, which I will describe in a little bit, and we developed evidence-based practice guidelines. We reviewed the part of what we did monthly is we reviewed the previous month's data for every single baby that was admitted into the small baby area. We discussed variances and we identified future action plans as to address those variances. It's also very, very important that you develop a communication plan. Meeting minutes should be distributed. Staff meetings, in every staff meeting, there should be an agenda regarding where you are, what you're doing, what PDSA cycles you're doing with the small baby area. We implemented a newsletter. We sent out emails, and each of the stakeholders on that team was responsible to communicate where things were at their individual staff meetings. And we also developed a small baby area board in the unit that everybody was able to see. Finally, you need to develop a SMART aim and PDSA cycles for each of those SMART aims and action plans on how you're going to meet the goal using QI science. Next slide. We used the model for improvement in our work, and this is a framework to drive continuous quality improvement. I'm sure all of you are aware of this. It's a method for structuring an improvement project. The model begins with three fundamental questions about any given improvement designed to address the aim, like what are we trying to accomplish, the measures that we're using, so how will we know a change is an improvement, and the changes to be used. What changes can we make that will result in an improvement? Next slide. The aim statement should be specific, who and what, measurable by how much, achievable. I know Dr. Spillane talked about some of those achievable goals as in relationship to the time for the top of the hood to go down. It should be relevant and it should have a time frame. This slide, which you've seen some of these aims before, states our overall aim and the sub-aims for our project. We had many other sub-aims, but just three of the ones that we'll be talking about. And there were multiple PDSA cycles that were implemented for each one of those sub-aims. Next slide. So measurement is extremely important. Data is critical. You can't improve something if you don't measure it. Graphs are better than tables. And although yearly data is valuable, it's not great for improvement. You want to bring it down to even sometimes weekly, sometimes even per PDSA cycle. You want to plot your data over time. It's better than plotting before and after. Seek usefulness, not perfection in your data collection plan. And try to integrate your measures into daily routine. So we actually, when we were implementing the golden hour, we actually had a data collection sheet that we developed at the time. And we had a person that was able to come to the bedside at the time and collect the measures that we were trying to measure. And you should use both qualitative and quantitative data, and you'll see that in our presentations. And I've listed 2 resources. I'm sure some of you know these resources that can help you with your measurements, setting up your aims, your measurement, and so on and so forth. Next slide. So again, I'm sure you're familiar with some of this. This is the PDSA cycle that is used to test ideas before you implement a change. It enables you to test a change on a very small scale. Sometimes we did 1 or 2 patients. We tried to do it for 5 patients or even 1 patient on days or at nights. So it allowed us to build on our learning from these test cycles in a very structured way before we implemented things on a wholesale basis and rolled them out to the entire unit. These cycles helped us with the team to distinguish testing from actually implementing. We're telling them we're not implementing something yet. We're trying to see if it's going to work. We tested ideas for change side by side with existing processes that were in place. And we thought rapid cycles. So like I said, we would do 1 patient or something over a week, and then we would stop and we would examine our outcomes, and we would decide whether we were going to adopt it as it was, or whether we were going to spread it, or we were going to totally abandon it and start from scratch. And in this way, because staff was involved and provided feedback, we minimized resistance, and we created attraction by the team, and we engaged the team in the changes that we were implementing. Next slide. So Dr. Planer had presented this small baby diagram, but I want to describe what a driver is. It actually is a very visual display of what the multidisciplinary team's theory is of what drives or contributes to the achievement of the project aim. So the outcome is on the total left. It was what we were trying to achieve. This was a clear with primary and secondary drivers. This was a clear picture with these primary and secondary drivers. It was a team's shared view, and it's a tool for communicating how large this project could be and the range of stakeholders where a team is testing and working. This small baby driver nicely displayed our interventions, which are the secondary drivers over there, and which areas we were planning on improving. So the circled areas here were the primary drivers that we initially addressed, and the secondary drivers were the interventions or the PDSA or change cycles that we were going to try to implement. Next slide. So I talked about several speakers had discussed something that we did, which was called a gap analysis. So this was the responsibility of the multidisciplinary team, and this is pictured how we did this gap analysis. So it was a process to assess our performance for the purpose of identifying a discrepancy between the recommended best practice and our current care delivery. And it also, on the far right column, identified how important this was to our unit. This is a gap, this pictures a gap analysis of with a focus on developmentally supportive care as it related to skin. So in the first column, like I said, to the left was the potentially better practice. And this exercise helped our team to prioritize the potentially better practice. And we call them potentially better practices because they are evidence-based, but based on your local site, they could be better or they actually could make things worse. So you have to think about local. This exercise helped our team to prioritize and to identify that skin care in this population of patients was inconsistent and that parents did not receive formal education regarding this developmentally supportive measure. Next slide. So this is a PDSA ramp showing all of the many PDSA cycles that we did in order to reach our goal of skin-to-skin care within 30 hours of the infant eligibility for skin-to-skin care. Actually, within now it's changed, and I'll discuss why, because it's within the first time that the parent is present at the bedside and the infant is eligible. So this is numerous PDSA cycles, and what I don't have on here is our balancing measure actually is unplanned extubation. Next slide. So although we had a skin-to-skin care policy, in cycle 1, we recognized that baseline data was not being collected and there was no set expectation for when skin-to-skin care should be implemented. So in cycle 2, the team reviewed the evidence and further defined exclusionary criteria, so which babies are excluded, identified the goal, and included a rationale as to why this was important, and identified what was the numerator and the denominator and what was our goal. We did this with each one, we completed this type of form with each of the change processes that we were trying to put into place. And this was placed on the small baby board in the unit so that everybody was on the same page as to where we were going with this measure. And this policy was then communicated to all members of the multidisciplinary team. Next slide, please. So now that we had this identified the exclusionary criteria, ventilated babies, the only exclusion was babies on high frequency oscillators. But vented babies were now eligible for skin-to-skin care. And although staff was comfortable with a sitting transfer, they did not really didn't feel comfortable with a standing transfer. So in cycle 3, we worked on RN, RT education on how to do a standing transfer. A standing transfer for skin-to-skin care is really preferred because it is less disruptive for the baby, especially if they're on a ventilator. However, this was really a new concept for our unit. So we developed this clinical guideline, which is in our small baby binder, which is pictured on this slide. And we also offered simulation training for the nursing staff. We had put together a isolette with baby in it and attached it to a ventilator. And we had the nurses and the RT simulate how and where you place your hands and how you hold the tubing and so on and so forth. Next slide, please. Cycle 4 involved improving skin-to-skin documentation in the EMR, as data collection was difficult with the current documentation options. And the previous speaker spoke about this a little bit. There actually was no place in our record to document date of eligibility, and especially if skin-to-skin was offered and refused by the parent. This was important to us as we met initially to review the data. We recognized that we were including in the numerator things that were actually variances. Because if the parent refused skin-to-skin care, this became a variance and shouldn't be included in the numerator. The current slide shows how we improved our current documentation to include date of eligibility, the type of mother or father interaction, and including if skin-to-skin care was offered and refused or performed. And we further included a comment area as to why the parent refused skin-to-skin care. This actually took a long time to get done because we had to engage with our IT folks to get them to make some of these changes. Next slide, please. Although some of this, now that the staff was fairly comfortable with providing standing transfer, we recognized that families weren't. And so, and we wanted to describe to them why this was standing transfer was preferred over sitting transfer. In cycle 5, the child life specialist actually offered parent simulation training on standing transfer, and we also included this in our education to families. Next slide. Cycle 5 also included the development of standardized education for the families, which involved the creation of a handout and a poster available in English and in Spanish, which really describes why it's important, why you should do it, not only the benefits to the baby, but the benefits to the mother and the father, and how often they should at least try to do it. Next slide. To further involve our families in developmentally appropriate infant care based on infant cues and also their gestational age, part of what we developed for parent education was this handout. It provided parents education on what parenting interventions they could provide at each gestational age. So it was divided up, it was called Tips for Parenting in the NICU based on infant development. And the topic, the original topic was developmental sleep, touch, movement, senses, and feeding, what was going on with the baby at each gestational age. And then in the green section below, we describe what can you do for your baby at that gestational age. So this was an effort for us to empower families and to normalize the experience of parenting in the NICU based on the gestational age of the baby. Okay, next slide. So, despite all of these previous cycles of change and the impact of COVID, which you can see here on this slide, this is our data from 2019 when we started this journey through 2020. You could see that we've been some months we were able to achieve 100%, but most of the time we were below that benchmark or that goal of 90% within 24 hours of eligibility. So the team decided to do a deep dive and to try to understand the reality versus the perception. So we even though we knew the variances, we wanted to understand what was really driving these issues. So next slide. We decided to do parent and staff interviews. The questions were developed by the multidisciplinary team. And included a parent resource specialist, and this parent had twins in our unit, twin girls, I think, that were born at 28 weeks. So 8 small baby graduate and current parent interviews were conducted in January of 2020 by that parent resource specialist via phone. And 48 nurses were actually interviewed there were nurse members of that multidisciplinary team. So they interviewed both day and night nurses. Next slide. So these were the themes. This is what we learned from the parent interviews, that most parents received skin-to-skin information verbally, even though we spent all that time developing those educational materials. The parents really got their information from the medical providers verbally, and that staff described how to do skin-to-skin, but they never really talked about or stressed the importance of doing it. Maternal issues were the primary reasons why mothers may not be doing skin-to-skin, was that they were sick or they were going home on the day of discharge. That there was inconsistency between staff in offering skin-to-skin despite the level of encouragement, despite no perceived changes in infant status. So the family didn't think the infant had a higher acuity at that time when they were at the bedside, but they felt that there was inconsistency between the staff. Fathers didn't perform skin-to-skin as often as mothers, as there was inconsistency in awareness that the father can perform skin-to-skin care. Next slide. So from the staff interviews, we learned that the #1 barrier is patient acuity. Infants met criteria, and it was documented that the infant met criteria as eligible, but the acuity of the patient at the time affected whether it was offered or not when the family was at the bedside. And the staff stressed over and over that it was they wanted safety over benefits. Things like increased oxygen. So we asked, what are the barriers? What are the infant acuity issues? Things like increased oxygen requirement, bradycardia episodes, or one of these extremely low birth weight infants with small ET tubes because there's no cuff on them, right? Hesitancy with umbilical vein catheters. So especially if they're low-lying or if there's long lines in place, especially if this is the infant's only IV source. They were hesitant to do that, to move patients when they had that kind of line. UACs was an exclusionary criteria for us, but umbilical venous catheters was not. Another issue was nurses who don't often work in the small baby unit. Although we try to assign same group of nurses into that area, sometimes it's taxing and the nurses undergo burnout. It's extremely a high acuity area, and sometimes we had to put nurses in there that maybe didn't work in there as often. So some of these nurses didn't feel comfortable offering skin-to-skin. And then there was things like timing of parent present at the bedside or availability of staff. If you have to move a baby that's on a ventilator, you need at least 2 people there, somebody to support the baby, somebody even 3 sometimes to support the lines, somebody else to assist the parent. And a lot of times things are going on. Their parents tend to visit in the evening a lot, change of shift, nurses are giving report, respiratory is doing their vent checks. at least in our unit, generally at the beginning of the evening shift, they are hanging lines or and especially things if there's an admission going on in the unit, there's competing variables and the ability of staff to be available and present to help parents move that baby. And then there was peer pressure, which was kind of interesting to us. Comments from other nurses or medical providers that it's not safe to do with that one specific baby. And then there were parental situations. How do you deal with families who appear sick, they're coughing, or we've had situations where nurses feel that the parents have the smell of smoke around them and they don't feel comfortable encouraging that family to do skin to skin. Next slide. So one of the things, I think this isn't not in order, but I'll do this anyway. One of the things that came out from our Joanne, can you go back one slide? No, okay, go forward. Thank you. So one of the things that came out from these interviews was that we developed a small baby data board. And this is a picture showing you what it looks like. It's just a whiteboard in the unit. It has the patient rooms and it has all of the measures across the top that we're trying to achieve. And it was incorporated into the workflow of the staff. So the staff does this. They document when the baby is eligible for skin to skin, if skin to skin was accomplished, the date that it happened. It tracks measures in real time for us, and it keeps everybody on the same page. Next slide. Oh, okay, so these are some of the recommendations or the action items that we took from that from that interview. We learned that eligibility is very variable. It changes day to day. Parents don't read the written information in a timely manner, so that we learned that information is best delivered verbally. And that the medical team, it's important that the medical team discuss the benefits and skin to skin expectations. We heard from the family things like, if the doctor says it's important to do, then we'll do it. Inconsistency of eligibility status led to the development of that small baby board that I just showed you. And now eligibility, skin to skin eligibility, since we know it's a moving target and that they may be eligible today, but not tomorrow, eligibility is now discussed at bedside rounds so that everybody is on the same page. Lastly, some of those interviews for the families were done post-discharge. And so we wanted to learn what the barriers are, or like kind of address the barriers in real time while the families were still in the unit. So now leadership during their rounds engages the small baby families on their rounds to correct misconceptions, to stress the importance, and to ask if there are any barriers. And the last thing is ongoing education. We are a large unit with over 100 nurses. We occasionally have traveler and float nurses. And although we strive for consistency of assignment in that small baby area, we really do find that there are times when somebody that maybe works in the less acute area is assigned to there. Next slide. So this is our data for skin to skin within 24 hours of eligibility and parent present at the bedside that started in the first, these are by the quarter from 2019 through 2024. And you could see that COVID was a big issue for us because we didn't know if it was safe. And then again in the second quarter of 23 and the first and second quarter of 23, we had an influx of travel nurses and new staff. So one of the things that we do struggle with still is parental presence at the bedside. And for that reason, the goal was changed to no longer to be within 24 hours of eligibility of the infant's eligibility, we now have included the fact that we are looking at parental presence at the bedside and 24 hours within that first parental presence at the bedside. Okay, next slide. So now I'm going to switch to colostrum oral care. You've heard a lot about that today. We use this exact same process that we did for skin-to-skin care with the use of human milk. And this is the gap analysis that was performed by that team when we started our work on colostrum oral care. Next slide. And this is our ramp of all of the different PDSA cycles that we did as part of reaching our goals of colostrum oral care within 12 hours. And you've heard quite a bit on colostrum oral care from the previous speakers. In cycle 1, we defined exclusionary criteria and standardized care. You've heard about those colostrum care kits. We defined in cycle 3, we defined a process for when that colostrum care kit was to be given, and we identified an expectation that the physician who's going back to talk to the family after delivery should update that family within 3 hours and provide that kit. Prior to that, there was no expectation, no time frame expectation. Chris Perdone spoke quite a bit about involving the high-risk antepartum and the postpartum nurses in managing or teaching them about our goals and hand expression and the importance of colostrum. By cycle 5, they developed an education program for everybody involved on hand expression. And then cycle 6, the NICU RN, you've heard about this, is calling the mother's nurse by actually 6 hours, not 8 hours, if no colostrum is received, so that everybody's on the same page and they could discuss barriers and how can they help each other to be able to get this colostrum. Next slide. So this is just an example again. I showed you a similar slide for skin to skin. This is how we approach all of our change processes. And we try to standardize our small baby board this way in terms of each one of the measures that we are trying to work on. I think it's the last slide, Joanne. And this is our data slide showing colostrum oral care. We have been consistently meeting our colostrum oral care since the third quarter of 2022. Although we continue to collect this information, the team has moved on to other measures, which Joanne will, and you could see, just so that you could realize that we had an issue with colostrum during when COVID was happening, because nobody knew about the safety of breast milk at that time. So there was a drop off there. So Joanne will take over now and talk about where things have gone from here.
Thank you, Chris. My name is Joanne Pazinski, and I'm over professional practice here at Hackensack. And I'm just going to talk briefly about the fourth metric that we have, what our upcoming plans are, where we've been, and the tools that we've used to get there. So metric 4 was dealing with the family meeting that was held by day 7 to 10 days after admission. And we received that one from our parent partner, who was able to get information from the parents and himself and his wife as well, that said that in the first 24 to 48 hours when they were at the bedside getting that information, they were not absorbing anything. So it was better to wait a week, and after day 7 is when we usually obtain our head ultrasound, so that the physicians felt that was a better time too, so that they had more information to give them. And you could see what our denominator is. Our exclusion is any infants who are obviously transferred and not present 7 to 10 day or expired, the parents were unavailable, or if there was any social issues, or if the mother was seriously ill. You could see our family meetings, we started out initially slow, but we were able to achieve greater than 70% since the second quarter of 2021. In the first quarter of 2021, that was when there was that little surge of COVID again. So, but since then, we've been up pretty much. We did have some barriers, and a lot of it had to do with parents saying that they were coming in and didn't show up. Some meetings were held, they were just not documented at the time of the meeting, so that was unfortunately marked as not done. But this is how we collect our data. I'm going to go to the next slide, which just shows one that's filled in so you can see it better. So what we look at is the baby's name, the gestational age, what the weight was, the medical record number, date of birth, time of arrival. We color code it so you can see that green is we met the criteria, pink is it was not met, yellow was they were excluded. So in the first baby, it happened to be a transfer from another organization. The mother was not present. She remained there for an additional 24 hours, so she was unable to perform, give us any colostrum for oral care, but we were able to feed the baby with the use of donor milk. She was discharged in a timely fashion, able to provide kangaroo care and have her family conference just last week. The red is when we have a baby that expired unfortunately within 24 hours of being there. And then we just had a baby earlier last week that was in the green on everything except for had not met kangaroo care eligibility as of yet. And then we just received twins, and there's one that the second one is yellowed out as far as the trophic feed because there was blood in the meconium, so they withheld feeding for the first 24 hours. So as far as obtaining qualitative data, this is a prime example. There were 6 themes that we received. And that was bedside nurses are an important source of information that can be vital to stress reduction. Information about the baby is overwhelming. It's best to address one issue at a time. Parents who attended NICU 101 orientation rated the class as extremely helpful and a source of very needed information. We have increased attendance. It started out at 31%. It went up to 62% by 2021. And we are currently at 100% thanks to Angeline, who sees every one of our small baby parents. Additional qualitative responses were that parents needed to speak with the neonatologist frequently, or when there was a change in the condition or a change in the physician who was assigned to the care. Parents felt it was vital that nurses encourage interaction with their baby. And then, as Judy had said earlier, there was moms are recovering, so they're not always able to be with their babies. Unfortunately, siblings, when COVID hit, we stopped our sibling visitation, but a lot of these parents had additional siblings at home that were too small and they couldn't leave them to come in. We are very thankful that we have our social workers who provide lift tickets, so it helps out with transportation. But if you think about it, our 22-week moms are back to work at 8 weeks, especially in this economy. So, you know, by 30 weeks, the parents that we're expecting to be at the bedside are unable to be because they're back to work. This is just an example of the metrics that we had initially submitted to the Joint Commission. It just goes over our metrics. You can see that we were in the red initially, but then we started to get into the green by the 3rd quarter. In May of 2022, we had our recertification for our prematurity DSC. We looked at 3 clinical areas to focus on, and that was planning our discharge to home family meeting, including OT-PT at 32 weeks on all of our patients. And Hildy spoke a lot earlier about the first oral feed and the guideline. This just shows how we actually measure it. It includes everything. I don't need to read it all. Unfortunately, in August of 2022, we received notification from the Joint Commission that There were 16 DSCs being retired, and unfortunately, prematurity was one of them. But it did not stop us. We continued with our goals. We still submit documentation. This is just showing that it has the 3 new goals. And then we have our function-based definition sheets that we use that are listed out. It tells why we're doing what we're doing, what the indicator is, what the functions are, who collects it, who's the responsible party, and what the data sources are. There's one for each. I'm going to go through them quickly because we're out of time. Currently, this is our 2023 goals. Due to a lot of this is our late planning for home family meetings and initiation with the correct nipple, but like our October babies only started to bottle feed in January. So there is no data there because we were unable to collect it at that time. So we had barriers through going home, and a lot of it, the same as we discussed earlier, was that these 38-weekers were staying on respiratory support. The families were not present anymore. They were back to work. We did have a great success with our OT-PT consults at 32 weeks because we have a multidisciplinary rounds every Tuesday, and there is a representative from OT-PT who is there. So if the order is not in, we are able to obtain it. We still have some barriers to correct nipple size because although we have a standard process for this in the unit, with our rising census and our increase in travelers and floats, the third quarter of 2023 had some misuse of the initial nipple. They used the wrong one. So at our current state of family-centered care, less than 10% of our parents are actually at the bedside for greater than 4 hours, and we have 24 hours, 7 days a week access. 15% of our parents are at bedside rounds, and those are typically the ones that are still in-house. We hold multidisciplinary rounds weekly. We have family meetings that Dr. Island has encouraged the physicians to reach out to their families daily with updates. We have parent education program that we offer, the NICU 101. Judy talked about these earlier. We have a social worker that touches base with our families weekly. Angelina, our March of Dimes representative, our lactation consultants, and our child life support has been wonderful. She's reinstituted our sibling visitation program, is starting Beads of Courage, Reach Out and Read, and as well as our cuddler program. So what are our next steps? First of all, it takes a village to incorporate that. We are in our infancy development stage of our NICU development unit. We are taking our small babies. The goal is that once they hit 32 weeks, then they're pretty much off respiratory support, to move them to a developmentally appropriate unit with looking at sound, touch, light, doing more education, having more focus on the discharge with goals, planning, and teaching. I just told you that. We also do a developmental follow-up program. We register all of our babies for at 4 months corrected age. They are all seen initially by a neonatologist, and they're followed up with developmental peds at 6, 12, 18, 24, and 36 months. And at that time, early intervention and pediatric specialists are referred. This is not just for our extreme premature, but also our medically complex. So in conclusion, measure what matters. The only way to achieve optimal change is if you have data that you can look at over time. Do small tests of change. Don't be afraid if you don't reach your goal. Work out the kinks. Use the people at the bedside. Make sure that you're talking to everybody. Listen to parents. They offer so much information that you can it's unbelievable what they tell you. Remember, working as a team can produce great results, and just share your data and ask for feedback. Now I empower all of you to go out there and design your own small baby unit or make your own small baby unit even better. Thank you.
Thank you.
Sorry.
We're going to transition now to our final quick Q&A session. We'll be with you shortly.
While they're assembling, I'll start looking at the tons of questions that are in the chat here.
Oh, sorry.
All right. Well, fantastic work. Two great presentations. Very elegant quality improvement work. That's right up my alley. So just looking at it and seeing your specifically loved your PDSA ramps. Not many groups really know how to do that well. And I thought that those were some great examples of PDSA ramps and really kind of building on the previous cycle of change to inform the next one to achieve an overall goal. And your data was fairly clear. Although you use bar charts instead of control charts, your data was very clear that you showed improvement in those areas. Really impressive work. So lots of stuff in the chat. I'm going to start going through some questions here. You guys have touched on it in a couple different places between both presentations and probably likely earlier ones today, but can somebody just clearly describe all in one place what your criteria are for skin to skin? Like, what's exclusion? Can it happen in the first 72 hours? What lines can be in place? What type of ventilator can they be on? Just so everyone hears kind of what qualifies a baby to be eligible for skin to skin or kangaroo care.
Sure. We have our neuro bundle, which is the first 72 hours of life. That is an exclusion in itself. We minimize handling and movement of the baby during that time. So eligibility happens after 72 hours of life. A baby needs to not be on a high frequency oscillator or jet. So an exclusion would be high frequency use. Another exclusion would be an arterial line in place. So if the baby still has an umbilical arterial line, that is an exclusion. We do allow babies to do skin to skin with an umbilical venous line, but usually with a conversation with the provider just to confirm that the team is all on the same page with that. But that's not an exclusion if they have a venous line in place. Other exclusion criteria would include a chest tube, or there is one of our criteria that's listed in our medical record would be a critical state. It's a little bit more vague, so that really leaves it open to the team to discuss if we feel like the baby's just not stable enough.
Okay. And I think I did hear you say that for skin to skin unplanned extubations was a balancing measure, something that you did track. And you haven't seen an increase in unplanned extubations with your with more skin to skin early on?
Not with our small baby.
Awesome. Getting back to your neuro bundle in the first 72 hours, I thought I heard you say that you actually don't weigh the baby in the first 3 days. And I'm just curious how that impacts your ability to adjust fluids if people are used to using weight change as part of their formula in their mind of how to adjust your TFL day over day.
We use the birth weight for the first 3 days of life. We don't adjust beyond that. Weigh them once we take them off the head positioning device after the neuroprotective bundle is finished.
Right, but you don't know if a baby lost 100 grams or 300 grams or
So
50 grams.
Difference oftentimes when we do that first weight after taking them off the bundle, we'll see a big difference.
Yeah.
And then go there. So it's
so how do you I guess my question is what informs your decision of going up by, do you just standardly go up by 10 a day or 20 a day on TFL, or do you have like how do you make decisions around fluid adjustments in the first 3 days if weight is not part of that calculation?
We use our body chemistries as a way to adjust fluids based on what our sodium values are.
Okay.
We urine output, and the net balance of fluid from our flow
Got it.
sheets.
Awesome. So it's I's and O's, sodium, but you don't take weight into account. You don't find that value. Okay. Thank you. Perfect. There's a lot of questions about what types of nurses can work with the small baby. So there's a question, do you require nurses to have a certain amount of experience before they can care for your small babies? There's a comment about two-handed care is recognized being the best, and is that braced in the unit? And then there's a question also very similar, do you have a specific pool or team of nurses that can care for small babies, meaning a group of more experienced nurses, or can any nurse care for these babies as long as they've attended the small baby course?
I'll take the piece about the team in terms of nursing. All of our nurses that come to our unit are trained in the small baby protocols that are specific to our unit. So every nurse goes through the small baby course. They all have the same training, and we have a really extensive orientation program as well. For a new nurse, especially to a neonatal ICU, it's about 6 months. So they will rotate and get experience during their orientation with the preceptor in the care of small babies. So we don't have specific nurses that are only the ones allowed to work in the small baby area. We will rotate through. We have some that prefer to work there and some that maybe like a different type of patient care, but everyone is trained the same way. And we really do try to train all of our staff to be skilled in working in that area. I think Maggie, I'll let you take the next part of the question.
About
Two-person care.
The two-person care, yeah, that is still at times can be a work in progress. Like I said, the education that we provide, all of the nurses had that education when we initiated this years ago. We currently now provide the education to all nurses when they come on and begin their orientation process. So it is something that just like noise can be a problem, it's something that sometimes needs a little bit revisiting, that this is what's best and evidence-based practice for the babies. So sometimes it just needs a little gentle reminding.
And also too, with our two-person care, it doesn't necessarily mean two nurses. It could be a nurse and a respiratory therapist, or a nurse and a parent, a nurse and a provider. So there are other options, and we try to kind of work together to do that.
Sounds like you really embrace that.
Yeah.
Yeah. There is a question about who from the provider side cares for your small babies. Do you have residents? Are residents allowed if you do? Or is it just neonatologists with AP, with NNPs or PAs?
The residents and the fellows all round with the neonatologist, so it is a group effort. They are all overseen. We do have guidelines that they follow.
So just agreeing with everything that Joanne said, we are affiliated, we're an academic center, so we have residents, fellows, neonatologists, and we really value a multidisciplinary, diverse team of providers that are caring for patients. So we think it's important for learners to learn those skills and certainly the philosophy that you need to embrace when you're taking care of such fragile patients.
Awesome, great, no, love it. I just trying to get through all the questions in the chat. There's tons of them. There's a question about what if a baby has an initial low blood sugar? Do you place a PIV while trying to place an umbilical venous catheter?
So that is why we check the blood sugar at like approximately an hour. So if there's still the providers are still trying to place central lines, we'll check it. If it is low, we will place a peripheral IV in the meantime. We try to avoid it, obviously.
Awesome. Next one, your process for warming TPN or IV fluid, and there were some answers to that question, but I'm not sure it quite got at the question that the initial person was asking. So I'll just so you could address it more broadly than how it was answered in the chat.
Our starter TPN, we do stock several bags of both the D5 base and the D10 base on the unit that comes from the pharmacy. So it's routinely stocked in our Omnicell. When we are made aware with the labor and delivery team that an admission of a small baby is going to be coming, we remove it right away, even before the birth of the baby. So if we know the delivery is imminent, we remove it. We'll even put it inside the isolette to maybe warm a little bit, but we try to just get as much advance notice from the labor and delivery team, and we're able to pull that fluid right away.
Great. Awesome. Do you have policies about opening your giraffe top, like limits to time or reasons to open it, and any research or literature behind your practice?
Well, our goal is to have the hood of the giraffe down within an hour of admission to the NICU. Beyond that, we do try to just be mindful and limit and kind of cluster our care together. So if I'm going to be putting the hood up with the respiratory therapist, the suction position, whatever we need to do, and I know the practitioners around is going to want to assess my baby and the baby's showing signs that they're, awake, then I'll try my best to call the practitioner to the bedside so we can kind of do that at once and not have it open for an extended period of time. And again, sometimes that just requires gentle reminders for all of us that the hood's been up for a while. It's time to lower it, keep the humidity in there and keep them warm. So,
and we try to encourage the team to leave it closed if you're doing routine care. If it's not necessary to open it, we try to leave it closed as much as possible. But that type of isolette does allow the top to open if you need to have better access to the baby. So we try to encourage the team, impress upon them how important it is to keep it closed for thermoregulation, but be mindful that sometimes it might need to open for certain tasks or procedures.
Right, like changing a diaper easier to be done with the hood down, but if I need to put a peripheral IV in for some reason, say, I'm gonna need the hood up to be able to do that, but we'll try to minimize the amount of time it's spent with the hood up.
Awesome. There was a question about your staffing ratio. I assume that meant your nurse staffing ratio, nurse to patient ratio.
We typically start, especially on an admission, we try to keep that a 1-to-1 staffing ratio. So we always try to have a nurse assigned as a small baby admit. We are a large medical center, so labor and delivery is quite busy. So we try to allow for a nurse to always be available to admit a small baby and to have that be a 1-to-1 assignment. Then it would really depend on the status of the baby, but while they're an intensive care patient, 1 to 2 would be the max. So a nurse wouldn't have any more than 2 patients, but really only if that patient status is appropriate. So it still may be a 1-to-1 depending on the patient.
Great. I think we got the question answered here about midline head positioning, whether you allow for log rolling, and it sounds like that's true. You put the patient in the tortal and then you move everything together.
Yes,
Yeah.
yes.
And we do a similar thing in our unit as well. I think we've already touched on the skin to skin exclusion. There was a comment about how awesome it is that you have a parent education leaflet that's specified for the particular parent and baby. And then there was a follow-up question about that, asking the question, is there a way to receive a template of it or a sample one that we can design in our own unit? It's a great personal touch instead of just having a generalized NICU pamphlet, as every journey is so individual. So the ask here is, can you share an example or a template that others can use to personalize their parent education leaflet?
Sure. Yes. They can reach me at joanne.pazinski. It's on the at hmhn.org.
Additionally, in your registration emails, they are directed from my email, so I am happy to redirect questions or inquiries to the appropriate person, and we will respond to those inquiries as soon as possible.
Lindsay Kahn is the person that asked the question about the template or the example. We asked this, we got the skin to skin one. We asked the all NICU, yes, we yep, I think everything else was just really positive comments and thank yous, and people that have otherwise commented on answers that you've already given. So I think, unless there's anything else going into the chat, I think, oh, you know what, I have one quick question for you. Do you resuscitate your babies in the L&D room where the mom delivers, or the C-section room where mom delivers, or do you have a separate resuscitation room for small babies?
In the room.
In the
Where
room,
mom-
okay.
Your mom.
And so, this brings us to the end of a wonderful day. I'd like to take a moment to thank God for this team, our leaders, our institution, our patients, their families, and all of you who came together today, demonstrating your dedication to the care of these small babies. Thank you again, and we look forward to continuing the conversation.
Thank you. Thank you.